allowed India to become the diabetic capital of the world.
A very good afternoon. Namaste. On behalf of Team Dipsy and Team Artist, we extend a very warm welcome to all of you once again today for the second day of the SAIDIP Congress 2021, an initiative in South Asia for diabetes in pregnancy. We heard from all our office bearers yesterday, Dr. Hema Divakar, the President, Dr. V. Balaji, Secretary Scientific Program, Dr. Sunil Gupta, the Program Coordinator, Professor Seshaya, and Dr. Anil Kapoor, the advisors. This Congress has 4 ICOG credit points and 2 credit hours from the Karnataka Medical Council. The video that you all just saw showcased the power of commitment by our leaders to prevent and cure diabetes in pregnancy. We, the OBGYNs, the physicians, the diabetologists, the dietitians, along with the government and the key stakeholders, have taken the shapath, the oath, the 1,000-day challenge to defeat diabetes, have healthy women, healthy children, and thus a healthy India. We hope to have a very rich and scientific session today too, just as we did yesterday. Moving on to the first session of the day, which is a keynote, the Dipsy session. In the beginning, Dr. Hema Divakar will be in conversation with Dr. Rohan Palshetkar and Tanu Modi. They will be talking about solutions for PCOS. Dr. Rohan Palshetkar is an associate professor at D.Y. Patil School of Medicine. He heads the unit Bloom IVF at the D.Y. Patil. He is the Foxy Yuva Orator 2020 and ISAR Yuva Orator 2019. Dr. Tanu Tiwari Modi is the Director and Head Marketing, Cinta MedTech Private Limited, Mumbai, which deals with digital lifestyle management solutions that complement conventional pharmacotherapy that drive positive health outcome in patients. Over to you, Dr. Hema.
Thank you, Purvi. Just before we begin, I very warmly welcome Dr. Rajiv Chawla-ji, who is the president of DIPSY in the current tenure, a senior member, Dr. Cynthia Alexander, who has stood as a strong pillar of support to DIPSY and all initiatives by Professor Sheshaya and his team from Chennai, and of course, our very own Dr. Sunil Gupta, who has already joined us for the session that is to ensue. Let's talk solutions. The evergreen problem of PCOS and weight loss. So for this, we have Rohan, who has just been introduced, and Tanu. We are putting them face to face to discuss what really happens in the metro scenario of practice and whether these youth leaders and young brains are working out of the box to get us some fantastic solutions. The National Digital Health Mission, as the Prime Minister has announced from the Red Fort, are we in sync with Atmanirbhar Bharat? And are we moving towards something very exciting, very new, very novel in the space of PCOS, weight loss, and other things which go around it? So, Rohan, we are taking you back to your clinic, especially the Bloom centers in many metros, a chain of 9 clinics, where many young girls and women would perhaps be dropping by for their infertility treatment. You are always there for second opinion. Why? Because the first opinion is always from Dr. Google. And then they'll end up with you because they've already got loads of information all scattered and the scatterbrainy, as we call them. How do you deal with the specific issue of so many obese population, 37% as per the recent NHFS report, which is a complete contrast to the malnourished women that we used to have in the past. So would you tell them to lose weight? PCOS, obesity, infertility. That is the nexus. We are taking you right back into your clinic, Rohan. What do you tell these girls, women, etc., who seek your help?
So, ma'am, generally at the clinic, when these patients are coming to us, our major concern is that when these PCOS patients come to us, they've come with a little bit of being a little healthy or a little bit overweight. So our major concern when we talk about PCOS and fertility is about ovulation, because majority of these patients which are there don't ovulate because of the PCOS and obesity. The biggest issue is that PCOS and obesity is a very vicious cycle. I always tell them that when you have a PCOS patient, if you are obese, it worsens your PCOS. And as you get more obese, the PCOS worsens. And this cycle continues, and you have to find a break somewhere. So it's very important that these patients, when they're young, it's important that to instill the fact that lifestyle modification can make a huge difference to their fertility status.
Right.
It's said that even with all the research that's done, even a 5 to 10% in the body's weight loss is going to increase the is going to increase the ovulation rates, and this is going to improve their fertility. Now, the biggest issue that comes is long-term follow-up with these patients, because these patients, yes, you can explain to them that lifestyle modification, you have to lose weight, you need to exercise, you need to do dieting, but the problem is, how do you manage and how do you target these women to do a proper follow-up and to ensure that their weight loss and lifestyle modifications are met? So
Rohan, I think, whilst you're talking about this, your key question is, how do you make this happen? And you want this to happen, certainly, right? Absolutely. That much we've gathered from you. So let's go to Tanu and ask her that what does the market study show? What do women really want? Of course, nobody knows what women really want, but we will ask you with respect to weight loss. They want quick fix solution. They want precise information. They want the targeted thing. So how did you hit upon the idea? Let me straight come to the point. Innovative idea of an app, which is called the Zuri app. And Zuri happens to be the beloved name of the daughter of Rohan Palshetkar. So we have a very special sentimental affinity towards that, so to say. This is the recent discovery. So how did you hit upon that idea of Zuri app, and what is this app meant to do for these young girls and women when Rohan doesn't have time in his clinic to keep on telling them again and again about a number of things that he wants to always tell them?
Oh, ma'am, firstly, why PCOS? Because PCOS is becoming, if I may say so, with all the expert panels, becoming another diabetes in India. It is going at the levels of the epidemic. So as the last AIM statistics was, it was 1 in 5 women, and especially in metros. Now it is called as a lifestyle disease because the lifestyle of every woman, right from a young girl who is going to college till a girl who is like working girls like me, who are very, very busy, who don't have time. Even if we pay dietitians, we enroll in endless gym courses, endless fitness and yoga courses. But then it becomes very difficult. The compliance is very, very difficult. And the younger generation, we want everything at the tips of our finger. So what we thought is, how should we close the loop? Now, coming from the medical industry, so this app literally we got us thinking. We thought the thought process was more than 6 months into it. So we got expert panel. We had people like you discussing and coming over, and then thinking, what is it? Because doctors like you are giving prescription. You are doing everything that is there in your mind. But the moment the patient walks out of the clinic, what is it that can connect the loop or close the loop? So that was the entire genesis of the concept of Zuri, where we are giving a scale, that is the body composition scale. And what we intend to do is, over the larger data set, because we are technically a healthcare IT company, And over a larger data set, we intend to even customize the equations. So right now, what I'll tell you, one interesting fact, that most of the scales, the body composition scales that are run, does not have a customized Indian algorithm. We have an Asian algorithm, but we don't have an Indian algorithm for Indian women or Indian population. So once we have critical mass and critical data, we also intend to make this change. So so again, coming to the concept, there's a scale, there's a connected scale, there's a connected app, and it just completes the circle. That is
Okay,
how we
Rohan,
intend to do that.
I'm swinging back to you that yes, this is an era of the app, and everybody on their own also will download some app or the other. But when they come to your chamber, that's not what they expect from you. They say, give me a prescription, give me something which will make me reduce my weight and also help me conceive. So metformin, much spoken about, when to start, when to stop. Maybe many don't know the continuum, but still it goes on and on. Now, drugs like Medital, which have metformin, and the new kid on the block, myodecanoinositol, which has been pushed into every formulation that we can have in the market. So what has been your choice, and how do you approach these?
So usually I do like to use a combination of metformin as well as myoinositol because this is shown to improve ovulation rates, especially in patients trying to conceive. So giving a combination of myoinositol as well as metformin, as you said, Metital, it's actually a tablet which comes in its combination, and compliance is better because the patient needs to have just one medication. What it also helps is with also weight loss as well as lifestyle. So while you're doing your dieting and exercise, this drug also helps you lose the weight and also improves your insulin sensitizers. So in those terms, what's happening is your ability to improve the ovulation rate while decreasing your weight is going to be helping. Another thing, as Tanu was saying, like about the Zuri app, what this would do is help us reach targets, in the sense that any person who's trying to improve their lifestyle or trying to lose weight is looking for targets. So if you reach a certain target and there's something that is measuring you, or in my situation, I always like to be held responsible for a certain target. So like if Hema ma'am tells me I have to do this work by this date, I know that I have a deadline and I have to make sure that I have to get my work done for Hema ma'am. So similarly, even patients, when you give them a target, it has to be realistic. So this app is actually going to help them like, okay, I've reached that target. I'm reaching my inches. I'm reaching my weight loss and my body composition is improving. What this gives me an advantage as a doctor is, okay, she's lost, say, about 5% of her body weight. I've added her metformin, I've added the myoinositol, but this is also giving me an advantage of improving her ovulation rates. So rather than making these patients jump directly for any advanced treatments such as IVF or maybe IUI, we can actually give them an opportunity to conceive even naturally if that option is available to them. So a combination of weight loss along with metformin, along with myoinositol is going to give a very holistic approach towards patient care and towards fertility approach of these patients. So it has to be a wholehearted multi-pronged approach where we actually have to do not only drug management but also lifestyle modification as well as managing the fertility conditions as well.
Excellent. That was a good, very pointed information that Rohan has given us. Now, quickly in the next 1 minute, Tanu, can I take you through these slides where you can explain to us what your app really has and does for us?
Yes, ma'am. So as we can see on this screen, the app is divided. The key features of the app are divided into the diet, that is the Eat tab. Then there's the fitness. So whatever is the spectrum of PCOS, we have tried to cover all of that within the hardware and the software. So as here is the diet recommendation that is unique for each profile of patient that has been created. The calorie recommendation, weight and fat monitoring that comes along with the hardware device that will be synced in the software, the period cycle monitoring tracker, the yoga and the fitness videos that are curated by experts, and the content in the community. The content is curated again by the experts. Like we have got mental health experts, we have got dietitians, we have got gynecologists, IVF experts who are creating a lot of video content, blogs, and other things. The entire concept is there's information, there's misinformation, and there's misinformation. So what we want is a single platform where there's complete information for the management of PCOS. So this is just one of the feature slides that just give you the visualization or the UI of the app, how it will be. So there are there are calorie goals, both in terms of macros and the micros. Then there is transformation. Once the patient goes and loops into the journey of losing weight, they can create, and especially in the social media, this generation of which likes to share everything on Instagram. So we have got shareable stickers like, and then this tab, this refers to, this is a period cycle tracker. We are also tracking ovulation. At least we are trying to predict. So these are the softer aspects that we also intend over a larger data scale, intend to improvise. So this is the last slide where we have got, since we are seeing a lot of inclination towards yoga, mental health, and even in PCOS, it's very, very critical. We have got yoga where you can be your own trainer, you can be your own guru. There'll be a lot of live interaction with industry experts that will be coming in. And this is just about the key features of the app, ma'am. Another thing that I would like to tell is with the app, we get the downloadable health report. Along with every doctor, they get their own dashboard so they can track and monitor their patients. So it's beyond the clinic approach that we are trying to give with Zuri.
Yeah. So as how it is showcased in this thank you slide of ours, that this is what the next generation is all about. And I think there are lots happening on the app world, and something which is authentic, something which is precise, something which is feasible for a user-friendly mechanism, which can connect the doctors and the community and the patients seamlessly, may hold a lot of promise for the future. And we really, really hope that Zuri kickstarts with the collaborative efforts of all those whom we have spoken with. And inside it, we invite the diabetologist colleagues as well as a continuum of the PCO, infertility, the glycemic management, and the metabolic syndrome, which is also influenced by obesity for ever and ever in her life. Also joined into our program now Dr. Rakesh Sahai and Shalini Jaggi. We very fondly welcome them as we begin the next official session at the SAIDIP 2021, with many, many thanks to Rohan and Tanu, who have in a shortest possible time given us food for thought. And I really do think that we are on the right track, and we will be looking back with pride on lot many more things that Zuri has done for us very soon. Thank you so much.
Thank you so much, ma'am.
Thank you.
Thank you, Dr. Hema, Dr. Rohan, and Dr. Tanu. You really have our minds buzzing with more curiosity about the app, and I'm sure more questions are going to come along as we move. So moving on to the next DIPSI part of this DIPSI session, we have Dr. Shanta Kumari, Dr. Madhuri Patil, and Dr. Cynthia Alexander to chair this session. The speakers will be Dr. Sunil Gupta, who will talk to us about the inclusion of gestational glucose tolerance as a category in the classification of hyperglycemia and pregnancy. Following this, Dr. Rakesh Sahai will tell us whether there is a link between GDM and the thyroid status of the patient. And Dr. Rajiv Chawla will tell us about the link between GDM and PCOS. Dr. Shanta Kumari is President-elect FOXY 2021. She initiated Dhira, a socio-medical campaign to eliminate violence against women. She's a senior consultant OBGYN and laparoscopic surgeon at Hyderabad. Dr. Madhuri Patil is the clinical director of Dr. Patil's Fertility and Endoscopic Clinic, Bangalore. She's the founder, chairperson of Karnataka chapter of Indian Society for Assisted Reproduction, KISAR. Dr. Cynthia Alexander, as you all can see, won the Wonder Woman Award 2020. She's a former director, IOG, Superintendent Hospital for Women and Children, Chennai, and professor, former, and HOD, OBGYN, MMC, Chennai. The speakers in this session, Dr. Sunil Gupta, we've heard him yesterday. He's a diabetologist, CEO and MD, Sunil's Diabetes Care and Research Center Private Limited, Nagpur. He's the recipient of 2 national awards for diabetes education and Vaidyakiya Shiromani. The next speaker today will be Dr. Rakesh Kumar Sahai. He's the professor and head department endocrinology, Osmania Medical College and Hospital. He's on the advisory board. He's the member of the Thyroid Research and Practice. The last talk in this session will be by Dr. Rajiv Chawla, who's a senior consultant diabetologist and director, North Delhi Diabetes Center, Rohini, New Delhi. He was the president, DIPSI 2019. Over to the chairpersons.
He is the president.
He is the president. I'm sorry.
He is currently the president of DIPSI. That has been a constant confusion, Rakesh Chawlaji, as how my Kundali, in that it is written that all the time we are misguided as to who. I think the COVID era has changed the calendar quite a bit. Yeah, so quite a bit. So there's a sea of confusion in the transition. But however, we strongly believe that leadership is not in position, but in action. And this is a group, ladies and gentlemen, who are constantly together supporting each other for the mission of defeat diabetes and constantly in action. So we are now going to be presenting the first speaker in this session. Sunilji, all yours.
Thank you, Dr. Hema, for kind words. And
thank you, Hema. Should I share the slides?
Yes.
I invite Dr. Sunil Gupta to speak on inclusion of gestational glucose intolerance as a category in the classification of hyperglycemia in pregnancy. Over to you, Dr. Sunil.
Yes. The slides visible, and am I audible now?
Yes, yes.
Yeah, okay. So it's a wonderful session once again, and thank you very much, Hema ma'am and the whole team. My today's talk is on gestational diabetes, gestational glucose intolerance. Should we include this category in hyperglycemia in pregnancy? And my humble thanks and regards to Professor Sheshaya, Dr. Hema, Dr. Balaji, Dr. Anil Kapoor, and of course the DIPSI President, Dr. Rajiv Chawla, and the SAIDIP team. There's nothing to disclose for this particular talk. Now, the gestational glucose intolerance, what exactly it is. And if I recollect that possibly last 10 years, we did not have too much of discussion on this particular topic, especially in regular forums, because we are more busy in implementing the Government of India guidelines. And this particular talk has remained little on sideline. And that is why I'll just go through revision of some of the important recommendation discussions in earlier scientific forums on this particular talk. Now, GGI means if you just go through a textbook, you'll find that ACOGN is still, American College of Obstetrics and Gynecology still follow two-step test for diagnosis of GDM. First test is the screening test, which is 50 gram 1 hour test. They give 750 gram of glucose, irrespective of the time of the meal, whether you are fasting or non-fasting. And then you take 1 hour test. If it is more than 140, then the 1 hour test is more than 140. They subject the patient for OGTT, that is oral glucose tolerance test, where you give 100 gram glucose and take 1 to 3 hour test. I'm not going to go in detail. If the two tests are positive, then you used to call it as GDM. So terminology has come. If suppose instead of two, only one test has come positive, that also was diagnosed as mild GDM. If suppose your OGTT is negative, but the 50 gram 1 hour test is positive, that has again been called as mild GDM or glucose IABG, or the multiple names there. The first message is if you will call, and these are those days recommendation by international workshop on GDM and expert committee, and have changed it. WHO has come out with another classification in 1998 that IGT in non-pregnant state is GDM in pregnancy. So you give 75 gram glucose. There was no fasting recommendation. Fasting still remained as 126 that time. But 75 gram glucose after 2 hours, if it is more than 140, you call it as gestational diabetes. This was, so now again there was the mild GDM was actually defined from this criteria as after 75 gram glucose, if it is between 120 to 140 and not crossing 140, that should be called as mild GDM. That was the discussion and recommendation. And that is why GGI now, with changing names, if the 2 hour value is about 120 but less than the value of the diagnosis of OGTT, not 2 but any one value in 3 hour test which is come positive, or if the 50 gram GCT is positive, that is more than 140 at 1 hour. And if I take it little further, if you use 75 gram 2 hour test, I'll say more than 120, 1 hour more than 140 or 2 hour more than 120 should be called as GGI. And if the OGTT is negative in this case. There are various names which have been coined. Canadian guidelines in 2004 coined it as IGT of pregnancy, impaired gestational tolerance, in impaired glucose tolerance of pregnancy. Canadian literature again has come out with different name, gestational impaired glucose tolerance, abnormal GCT and normal OGTT, mild glucose intolerance. Australia and New Zealand combination has come out with another name of borderline GDM. Netherlands has called it as mild GDM. India, we started with isolated abnormality of blood glucose, IABG, and IABG, which was from the 3-hour test, and impaired gestational glucose tolerance, IGGT, from the WHO criteria. And gestational glucose intolerance is the recently coined name by DIPSI. So if you talk about the why this concept has come, because every one of us, there might be little controversy on multiple figures when it comes to diagnosis and screening. But when it comes to target, I feel there is no controversy since almost 2 or 3 decades that 2 hours should be less than 120 and fasting should be less than 90. Some literature may say 95, but there is no confusion on the 2 hour of 120. And that is why the concept that if you're targeting your goal as 120, why you should not keep a cutoff value of 2 hour of less than 120 rather than 140. That was a debate. And we all know that mean blood glucose, if crosses more than 105, there is increased risk of increased risk of perinatal mortality and morbidity. And that is why we should try to achieve as tight control in pregnancy as possible. And that is why in 1991, the first possibly when I started my practice 1990 onwards, after passing my MD, when I started taking interest in diabetology, I found this paper which was published in our RSSDI journal, which was published by Dr. Seshaya group. And it was, they have coined here impaired gestational glucose tolerance and isolated abnormality of blood glucose. So IGGT was, if you're following WHO criteria, between 100 to 140. And if you're following the other criteria, which was 2-step test, then any one reading which is positive. So these are 2 names were coined. And they have concluded that even if it's a minor abnormality of blood glucose or glucose intolerance might be dangerous to the child, it is thus concluded that minor form of abnormal glucose tolerance have deleterious effect on fetal outcome. Identification and treatment of such subjects results in marked reduction of perinatal mortality. And this was the early paper from our country. Then if you go to the literature, the data has shown that poor response to 50-gram challenge test are at higher risk of having macrosomic infant, even though they may not meet the generally accepted standard of GDM. Thus, any woman with a plasma glucose higher than 140 milligram after 1 hour 50-gram test glucose test, despite even OGTT is negative, should be taken as caution. Moses has come out with another paper from Australia, 138 women with GDM, 144 women which are borderline, 120 to 140 blood glucose after glucose, and women with GDM, particularly those receive insulin, have a more favorable fetal outcome than women who have a glucose results from 120 to 140. These results suggest that current diagnostic criteria of GDM with respect to fetal outcome may need revision, and additional subgroup of pregnant women may benefit from the dietary advice. And the data also says around 80% or 90% of these women responded very well to diet therapy, only 8% or 10% required insulin. Now, this is another, I feel, the pioneer work of Jovanovic, who actually unfortunately is no more with us now. Women with minor abnormality in blood glucose sugar levels should be trained to monitor their blood glucose rigorously and control through insulin if required. And that is why we then started taking interest in this. And from the early 2000 itself, even late 1990s, we have started publishing of data. This is one of the paper which we published in almost 16 years from now in Australian Association of Diabetes, or SAIDIP group. And then another papers have also come. Is there any benefit of the treatment of mild gestational diabetes? And here again, it has come out with the conclusion that we have now 2 good papers which are available, which has shown that mild gestational diabetes also is important. And they have actually quoted a COIS study from Australia and New Zealand, and MFMU study from UK. And both of them have shown that if you treat mild GDM, possibly we'll be able to have benefit in the fetal outcome. And they have classically shown it here on large for gestational age, birth weight, neonatal NICU admission, and some of the induction of labor. So there is some data, and they say that they concluded that we fortunately do not have large scale multicentric randomized treatment trial to provide evidence that treatment of even mild GDM with dietary intervention and insulin is as necessary as effective. So we should at least have some data on these lines. Now, this is a paper from Australia again, borderline gestational diabetes, where they have shown that women with borderline gestational diabetes and their infant had higher risk of having adverse health outcome compared to those who are negative OGCT. And that is why intervention strategies to reduce the risk of these women and their infants is the need of the hour. And they have shown macrosomia, they have shown neonatal intensive care, NICU admission, neonatal nursery, everything found to be higher in these mild GDM women. Relationship between excessive gestational weight gain and neonatal adiposity in women with mild GDM. And this paper has concluded that in women with both treated and untreated mild GDM, excessive gestational weight gain was independently associated with both greater birth weight as well as adiposity. So you can't ignore mild GDM. There's a wonderful paper from our own NRI, who's Ravi Ratnakaran from Canada. And he has a wonderful profile of mild GDM, and he has further gone one step ahead. Beta cell function declines within the first year postpartum in women with recent glucose intolerance. And they have three groups. They are normal GCT, normal glucose tolerance test women during screening, abnormal value in GCT but normal in OGTT, or one value abnormal in the cohort of 3 tests, 0, 1, 2, 3, 4, and then the classical GDM were 2 values positive. And they have seen that the beta cell function at 3 months and 12 months after postpartum certainly was found to be lower, even when you have one abnormality, or even if it is not lower than the normal, even in postpartum phase in patient who had only GCT which was positive. There's a difference in the circulating fatty acid composition and dietary fat intake in women with GDM and mild GDM. Abnormalities in the fat metabolism was seen in both GDM as well as impaired GCT non-GDM, and reducing pre-gravida weight and altering diet might prevent this circulating fatty acids. Another wonderful paper, fetal myocardial performance in pregnancies complicated by gestational impaired glucose tolerance, gestational IGT. And what this concluded is they have seen fetuses of women with GIGT had a greater abdominal circumferences, large amniotic fluid index, and a tendency of heavier at the 3rd scan. And there is no significant difference in the migraine thickness, but they have found that there is from the left and the right ventricle MPIs, that is myocardial performance indices or index was between 2 groups. In the first and the second scan had decreased significantly by the late gestation in this group. So even it has also affected the myocardial performance index in these individuals. In the fetuses, histopathological placental lesion in the mild GDM and as well as diabetic mothers. Results have confirmed that distinct placental changes have been associated in patients with diabetes as well as mild GDM, and it depends on the period during which the diabetic insult occurs. It may reasonably be inferred that subclinical maternal hyperglycemia during pregnancy, as shown in mild GDM group, is responsible for increased placental and arteritis and postpartum lesion in the live fetus. And that is why we should not ignore mild GDM. Oxidative DNA changes in the diabetic and mild GDM hyperglycemic pregnant women, and this has concluded that the GDM and GDM over diabetes and mild GDM were all related to increased oxidative DNA damage Diabetic pregnant women showed increased level of oxidative DNA damage, perhaps mainly due to the hyperglycemia. On the other hand, oxidative DNA damage detected in women with mild GDM might be associated with obesity, hypertension, and or insulin resistance. The type of DNA base affected seemed to be dependent on glycemic profile or the oxidative stress. Glucose intolerance in pregnancy, future diabetes. This I already shown you that if you have abnormal GCT, you're more likely to have the glucose intolerance in the after the delivery. That's the postpartum risk of pre-diabetes and diabetes increases even if you have one abnormal value in the GCT, or if you have GCT positive or one abnormal value in OGTT. And they concluded that any degree of abnormal glucose homeostasis in pregnancy independently predict an increased risk of glucose intolerance postpartum. And that is why we can't ignore this particular terminology. And the same Dr. Ravi has again come out with metabolic syndrome data in these young women postpartum. And he has shown classically here, if you see, all statistically significant, whereas dysglycemia, hypertension, triglyceride, low HDL was found to be statistically significantly increased in women who had mild GDM as well as in women who had GDM versus those who were normal glucose tolerance. And this is again a cardiovascular disease. What we say that all women with GDM are at higher risk to go have cardiovascular disease postpartum in their 5 to 15 years a postpartum phase. And this is GDM, but this is again you can see the red line which has shown that mild GDM is also prone to have the cardiovascular risk. And this is a recent paper from India, from Sushila Rani is one of the author, and anthropometric and skin fold thickness measurement of newborn of gestational glucose intolerant mother. Does it indicate disproportionate fetal growth? And I'll not go into detail of the study, but the conclusion is that gestational glucose intolerance during pregnancy does cause disproportionate growth, increased fat body mass, but not skeletal mass, and increased adiposity in their newborn. This emphasizes the need of strict glycemic control, and during pregnancy, large multicentric trial is required. So even mild gestational diabetes they have covered, and our work towards this early detection of this mild GDM and treatment has continued from almost since now 20 years. And this is another paper which was published in 2017 in International Diabetes Federation, and we have around 209 women, and we have seen that the fetal outcome, those women who had bed obstetric history, those women has history of fetal losses that has reduced from almost 25% to almost less than 3 or 4%. And also there were many of them have been detected in even the early phase, less than 12 weeks, and between 12 to 24 weeks rather than after 24 weeks. And around 12% or 15% have required insulin to achieve the goal. So what we learned about treating these mild gestational diabetes, there another review article which says, in conclusion, treating mild GDM with dietary intervention and insulin when necessary is effective in reducing the risk of fetal overgrowth. However, treatment may not reduce metabolic abnormalities of newborn in milder case of GDM. Increasing maternal glycemia is associated with increasing risk of adverse fetal perinatal outcome, with no obvious threshold at which risk increases, making it difficult to determine the optimal threshold. So we don't have exact threshold. Whether treatment of mild GDM associated with future metabolic disease and obesity in the mother and her offspring remains unknown, with the data at present suggesting no such association, at least in the first decade. And there's one data of 5 to 10 years post age of offspring of these mothers. However, there may be a sex difference, and they have found that that in vitro exposure to the maternal mild GDM with treatment effect more apparently affects male neonates versus female. Because maternal BMI and pregnancy associated hypertension appears to have a stronger impact on future health of women and their offspring than maternal glycemia, postpartum lifestyle intervention should be aimed. If suppose you call them as normal, possibly will not be able to address the primary prevention in these women. Are there benefits of gestational diabetes in treating lower level of hyperglycemia? What are the recommendations? Now this 2016 recommendation of Canadian guidelines that even the milder form of hyperglycemia that would be identified by IED-PSG guideline may benefit the treatment. So even they have also said that mild form should be addressed. So our concern is hyperglycemia is one of the most common metabolic disorder complicating pregnancy across the globe. While rising maternal age, obesity, physical activity, 1 in 6 women now has pregnancy complicated by hyperglycemia. We all know that. We have heard since yesterday. Australian the ECOIS trial has confirmed that treating women with GDM reduces serious perinatal complications. London et al. Has shown that the treating women with hyperglycemia reduces maternal weight gain, gestational hypertension, preeclampsia, seizures, infant adiposity, birth weight. Emerging evidences suggest that intrauterine early postnatal environment can influence cardiovascular and metabolic health in later life. Maternal hyperglycemia in GDM is thought to confer a greater risk of diabetes and obesity in exposed offspring via fetal programming. Animal models have also suggested similar association, and the prevalence of obesity and diabetes continue to increase worldwide. Until we can put a stop to this vicious cycle of transgenerational obesity and diabetes, which offers opportunity for intervention for diabetes and non-communicable diseases, will continue to impose the greater burden on our families in future. And that is why we should be cutting out this transgenerational transmission of the non-communicable disease. Here we are talking about diabetes. By aggressively, possibly, we may require to add more and more. Of course, research is required on mild gestational diabetes in our country. More data, possibly, maybe RCT trial or something should be done even from the available cohort. Maybe we'll come out with some more recommendation in future. And this is the conclusion from this wonderful paper. Although this study did not demonstrate an overall effect on childhood obesity with treatment with mild GDM, our observation with respect to the metabolic differences according to the sex among the offspring remains little confusing. The association between neonatal adiposity and childhood obesity in this study is also apparent, and a potential treatment effect was suggested in female offspring with highest neonatal fat mass. Thus, the possibility that fetal programming of metabolic function in GDM can have an intergenerational effect that may in turn be modified, and they are talking about the mild GDM. And this is the last slide. This is Yojev. Yari Yojev has presented a wonderful data on CGM in non-diabetic pregnancy. They still says that pre-meal remains 78, the 1 hour of 105, the peak is 110, and then after around 2 hours, it's coming to 84. So the mean blood glucose is around 98. When you're talking about mean blood glucose in non-pregnant, non-diabetic pregnancy is 98, then why should we be focusing on 140 as a diagnostic criteria? If we are strict, if we try to achieve a normal glucose, if you want our fetus should not recognize, there's a wonderful quote, if a glycemic control can be maximized to the extent that the fetus no longer recognizes that its mother has diabetes, then the treatment of mother during pregnancy may become the first step in prevention of obesity and diabetes in the offspring. This is almost now 20, 30 years from now, and we should be more aggressive in focusing even milder form of hyperglycemia in pregnancy. Maybe that we are talking about DIPSI criteria today, but in future, if we have further data, at least from our country, we'll be able to incorporate. So I appeal all youngsters, all researchers to please help us getting this data further strengthened for us, so that in future we'll be able to include this mild GDM or gestational glucose intolerance in the hyperglycemia pregnancy classification for our country. Professor Shia always says, make in India, and that's why I further stimulate every one of us to work in this field in a collaborative manner. And Hema is already there with us, and many more researchers like Dr. Rajiv from North, Dr. Hema from South, and of course we are from Central India, and many more of us can join hands to work on this. As waiting for this opportunity to come, but unfortunately Corona has not allowed us to organize this DIPSI 2020, and that is why that confusion which started again just a few minutes back still exists. And so maybe that Dr. Rajiv Chawla will declare some date in very near future, and we'll be meeting soon at Delhi if the Corona pandemic issue goes away. Thank you very much for patience listening.
Dr. Cynthia, please unmute yourself.
Hope I have not exceeded the time.
No, it was, thank you for that very informative talk. And with that elaborate statistics that you've shown, really it was an eye-opener. And I'm sure generations will benefit by this talk in the future dates. Thank you.
Thank you, ma'am.
Now we'll go on to the next speaker. We invite Dr. Rakesh to speak to us on GDM and thyroid status. Is there a link? Over to sir.
Thank you, ma'am. I'll share my screen. At the outset, I would like to thank the organizers of SAIDIP, Dr. Hema Divakar, Dr. Rajiv Chawla, Dr. Sunil Gupta, Dr. Balaji, Dr. Sheshaya, and Dr. Anil Kapoor for giving me this opportunity to be here today and to discuss about GDM and thyroid status. This is an important issue, and what I would be trying to do today in the next 15 minutes or so is to discuss about the link between these two common problems. So if you look at these two conditions, these are the most common endocrine conditions which are encountered in pregnancy. And that's why there's going to be overlap. Is this overlap by chance, or is there a link between the two, is what I'll be discussing. So if you look at the prevalence of these two problems, we all know about hyperglycemia in pregnancy. We know that 1 in 6 live births are affected by hyperglycemia. This is the data from the IDF study, and our region, the South Asian region, has a significant burden of hyperglycemia in pregnancy, as is evidence from this IDF Atlas of 2019, and the global estimates which were there. I mean, as all of us are aware of that, and we know that there are more than 5 million people, women with GDM in India at any point of time. So the prevalence of gestational diabetes has been reported to be widely varying from different parts of the country. We have very low prevalence rates in some parts of the country, very high prevalence rates in other parts of the country. But by and large, we know that this goes with the background prevalence of IGT in the population. And similarly, if you look at the other side of the coin, we see that hypothyroidism also is a very common problem. And is estimated, although in the we have data from the US here showing about 2.5% prevalence of hypothyroidism. We have one study from northern India showing a prevalence of 6.47%, but we have a recent study, not very old study. I mean, this was published in 2016. We did a 11 city prevalence study of hypothyroidism.
Doctor, I'm really sorry to interrupt. There is a message which is popping up. Could you just save your PPT, sir?
Save my PPT. I have not seen the message. Is it coming to
Rakesh, in the center, there is a message, save your changes, just cancel it. Now you go on slideshow again.
Yeah.
Switch on slide on.
Sorry for that. Is it now coming?
No, yeah. Use right cancel. Click cancel. Cancel on this mess. You can't see this message. Okay.
No, it's not coming on my screen.
Okay. No issues. Please continue. Yeah.
Is it still in there?
Yes, sir.
I'll just stop sharing and share again. I'll do
Yeah, sure.
You stop sharing. You save it, and
you have to save it actually. Yeah.
You save it, and then
I'll just go to that and see.
You didn't save the changes actually, so it's reminding save or don't save.
Sorry for that. Now is it there?
no, you put it on the show.
Yeah.
Then it's still showing.
Still showing. Yeah, I am not seeing that.
You may continue. Yeah. You will have to first save it and then reopen the PPT actually, but it's all right.
Save it, close the PPT and reopen.
You'll have to save it first and then reshare.
Sorry for that.
You made some last minute changes you didn't save actually. So it's asking again, save or not to save.
Actually, you close the presentation.
No, actually, it is case reports. Some case reports, some app is there, which is there. So please, you want to save the changes, case reports. It's not this particular PPT. It's a different PPT.
Sorry. I'll just close PowerPoint. Sorry, very sorry.
Kindly check whether multiple presentations are open, sir.
Yeah.
Some other PPT.
Yeah. Sorry for that. Extremely sorry for that. I think now is it gone? Is it gone?
No, unless you put it on. Yeah.
Gone.
It's fine now, sir.
Gone.
Sorry, very sorry for that. I'll resume from where I stopped. So I was speaking about the high prevalence of gestational diabetes, and the fact that thyroid disorders are also very common. When we're looking at the 11 city prevalence in our country, we found that we did this study in 2016. We published this study, and we found that there was a prevalence of 13% of pregnant women had hypothyroidism, using a cutoff of a very conservative cutoff of TSH of 4.5. And if we had used a cutoff of 4 or even lesser, that prevalence rate should have been higher. But going by the new ATA guidelines, 4 is what is the cutoff generally recommended. But we looked at a cutoff of 4.5 and found a prevalence of 13.3%. And when you looked at anti-DPO antibodies, they were present in 20.7% of all pregnant women in our series, and 40% of those who were hypothyroid had anti-DPO antibody positivity. So that was the prevalence of hypothyroidism in our country across 11 cities. And what I would like to highlight here is that there are several physiological changes that happen during pregnancy in the thyroid function during pregnancy. It's a physiological stress leading to a near pathological outcome. We know that because of the increase in estrogens, there is a 2 to 3-fold increase in the binding proteins, leading to increase in total T4 and total T3, reduction in the free T3 and free T4, and because of similarity in the structure of HCG with TSH, there's a transient fall in HCG in the first 8 to 14 weeks, and then there is increased peripheral metabolism of TSH, also leading to of the thyroid hormones, leading to increased requirement, also because of the increased plasma volume. So there's an increase in the requirement for thyroid hormones during pregnancy, and there's a significant change in the thyroid function tests, and it's important to know these to interpret it properly to identify the presence of thyroid dysfunction. So besides that point, what we would like to say is that there's an increase in demand for thyroid hormones by about 30 to 50% in pregnancy. Now, untreated hypothyroidism has several implications for both the mother and the fetus, and while those things are known, I'm not going into details of that. But what I'm trying to emphasize on is today is the effect of thyroid function in relation to the glucose homeostasis. How the thyroid function, how the thyroid hormones influence the glucose homeostasis. So they regulate hepatic gluconeogenesis, intestinal absorption of glucose, peripheral uptake of glucose. All these are regulated by thyroid hormones. They also promote glycogenolysis, and they modify the circulating insulin levels and counter-regulatory hormones. So, and they also have an effect of modulating the messenger RNA and protein expression of glucose transporters. Through all these mechanisms, what we are saying is that thyroid hormones have a significant impact on the glucose metabolism. They increase the insulin resistance, they increase the insulin requirements. Although they have some effects which are matching the effects of insulin, but majority of the effects increase the insulin resistance. So thyroid hormones act differentially in the liver, skeletal muscle, and adipose tissue. They oppose the actions of insulin in most of the tissues. In some places, they act synergistically with insulin. So as you can see in this cartoon, there is increased, as you can see, most of the effects which are seen on top are increased beta cell function, increased hepatic gluconeogenesis, hepatic glycogenolysis, increased intestinal glucose absorption, are all increasing the insulin requirement, while the increase in blood-4 activity, increased peripheral tissue glucose utilization is synergistic to the insulin action. So So therefore, that brings us to the question again, that are GDM and thyroid disorders coexisting just because they are common conditions, or is there a link between them? Is it purely coincidental? Or some studies have shown that there is no association between gestational diabetes and thyroid dysfunction, but there are many other studies which have clearly shown an association between hypothyroxanemia or low thyroid hormone levels in which are clearly connected with the development of the gestational diabetes. Some studies have shown that hypothyroid patients are at a higher risk of GDM. Thyroid autoimmunity has also been associated to be a causal factor for has been associated to be a causal factor in both ways. That is, thyroid autoimmunity can induce GDM development, and GDM women with GDM have greater degree of thyroid autoimmunity also. So let's look at this studies which have looked at thyroid autoimmunity in GDM. The association between these are probably proposed because there could be a common antigen which is shared between the pancreatic beta cell and thyroid follicular cells. And this speculates that hyperglycemia at the time of pregnancy or immediately after delivery triggers the autoimmune disorder. So both ways this could happen. It could be triggered by thyroid autoimmunity itself, or that could influence the development of GDM, or it could be GDM which can trigger thyroid autoimmunity also. So interestingly, if you look at this study, which had patients in 4 groups, that is GDM women, non-GDM pregnant women who are not having GDM, those who post-delivery after the GDM, and healthy mothers. So they looked at these 4 groups, and they looked at thyroid autoimmunity, and what they found was that there was no difference between thyroid function and prevalence of autoimmune thyroid disorders during pregnancy. However, a significant increase in thyroid autoimmunity was seen in women previously affected by GDM. So those affected with GDM have a greater degree of thyroid autoimmunity. Another meta-analysis of 20 studies looked at thyroid autoimmunity and GDM, and they showed, I mean, as you can see here, all of them are, and the forest plot shows that they're just on either side of the of the central line, showing that there are some studies which are showing that there is some association, others are showing no association, but all of them are not very significantly different. So that question is not yet answered. Well, let us look at the effect of hypothyroidism or hypothyroxanemia. This is another condition where the TSH levels are normal, the T4 levels are isolated, T4 levels are low, and that is what is called as isolated hypothyroxanemia of pregnancy, and whether these have an effect on the GDM. So this was a study which looked at 50 GDM participants and 60 non-GDM participants in the control group. TPO antibodies were present in 30% in the case group and 15% in the control group. And TSH and free T4 were done in each trimester. And what we see is that in the second and third trimesters, the levels of free T4 were lower in the case in the group that had GDM as compared to the control group. So this shows that there is some degree of association, but there are other studies which have have a larger number of patients. I'll show you some more studies on that. What was seen was that in the control group there were no incidents of isolated maternal hypothyroxanemia, but the GDM group had a prevalence of had a significant number of women with isolated maternal hypothyroxanemia. So that was one thing. But when you look at another interesting study from Shuai Yang from Hong Kong, what they looked at was they looked at the levels of they looked at low thyroid. They proposed that low thyroid hormone levels in early pregnancy are associated with the risk of developing gestational diabetes later in pregnancy. So they looked at the GDM woman. If you see, the GDM woman had lower levels of had higher TSH level. I mean, had similar TSH levels but low FT4 levels. As you can see, these FT4 levels are significantly different between the 2 groups, and the TPO antibodies were not different, but the low T4 was contributing to, I mean, was shown as a factor which was leading to the development of GDM later on. So this study had large number of patients, 3,600 women who developed GDM as compared to 23,000 women who did not develop GDM. So totally more than 25,000 women were studied in this analysis, and they showed that low FT4 levels correlated with a higher prevalence of GDM. Then another interesting study which has looked at thyroid dysfunction and autoimmune antibodies in early pregnancy, and the risk for development of GDM later in pregnancy and adverse birth outcomes. A total of 1,170 women with singleton pregnancies participated in the analysis, and what was seen was again the TSH, free T4 and free T3, and the thyroid antibodies were studied. And as you can see again, the high TSH with antibody positive group. So there were 4 groups again here: the TSH, normal TSH, antibody negative, normal TSH, antibody positive, high TSH, antibody negative, and high TSH, antibody positive. So this group with high TSH and antibody positivity had the highest, 4 times higher rates of GDM as compared to the reference group, which is normal TSH without antibodies. So clearly showing that higher TSH with antibodies is correlating. I mean, is showing a 4-fold higher risk of developing gestational diabetes. Now, there's a meta-analysis which looked at 20 different studies, which is again published in 2016, I think 2016, which looked at many different studies. And this had one study from India also, from Sahu et al. And the meta-analysis looked at overt hypothyroidism and its relationship with GDM, clearly showing that overall, from all the studies, there was a clear association between, although the Indian study did not show much of a difference, but all the overall analysis of all the 20 studies showed that overt hypothyroidism has a clear link with development of GDM later in pregnancy. And even subclinical hypothyroidism did show a greater risk for development of GDM, a 50% higher risk for development of GDM in subsequently in pregnancy. Then there's a longitudinal study of thyroid markers across pregnancy and the risk for gestational diabetes. This was published more recently in 2018. What they looked at was they looked at 107 patients with GDM, and there were 214 non-GDM controls. And when they looked at the factors contributing to the development of GDM, family history of diabetes, and pre-pregnancy BMI were significantly different in the GDM group. Apart from that, what was seen was that if you look at their levels of FT3 FT4 ratio was another important parameter that stood out as a differentiating factor in those developing GDM. So higher FT3 by FT4 ratio was one factor which was clearly showing up at 10 to 14 weeks, and even at 15 to 16 weeks. If you looked at 15 to 26 weeks, if this was done at both the times, it was correlating with a greater risk for development of GDM. And this change from the first period, that is 10 to 14 weeks, to 15 to 16 weeks also was significant, and that contributed. So thyroid function early in pregnancy is indicated for subsequent risk for GDM. FT3 by FT4 ratio, or rather the FT3 levels itself early in pregnancy, are independent risk factors for GDM. Increased levels of either marker, they have a greater GDM risk, and the ratio is associated with a higher risk. And now let us look at another study which looked at subclinical thyroid disease and the incidence of gestational diabetes. When it is 24,000 women included in the study, 23,000 were euthyroid, and 584 had subclinical hyperthyroidism. Another 528 had subclinical hypothyroidism. And what did they find in this was that the likelihood of gestational diabetes was again linked to the TSH level. So higher TSH level clearly linked with a greater risk for development of GDM. And another study looked at again at those 4 categories which we spoke of earlier: the TSH, high TSH, with antibody positivity, 46% prevalence of GDM as compared to TSH normal, antibody negative, 14%. So clearly there is a great increase when there is increase in TSH and antibody positivity. So what we understand from this is that overt hypothyroidism is clearly associated with the risk of developing GDM later on in pregnancy, and even subclinical hypothyroidism has this association. Hypothyroidism probably has appears to negatively affect the glucose homeostasis by inducing insulin resistance, and these women with hypothyroidism have a amplified insulin resistance, and that have increased risk of developing gestational diabetes. Now let us quickly just spend a minute on hyperthyroidism. If you look at hyperthyroidism, that also has significant impact on glucose metabolism. But if you look at some studies, a small study like this showed with just 150 subjects studied, showed a link between GDM and hyperthyroidism. But other studies with larger numbers of women, 24,000 women included here, and the one which I showed earlier, clearly showed that the low TSH of subclinical hyperthyroidism is not associated with the risk of developing GDM. So by and large, most studies with subclinical hyperthyroidism have not shown increase in risk of gestational diabetes, but the rising levels of TSH have been associated with the development of gestational diabetes. So hyperthyroidism studies have therefore shown conflicting results on the risk of gestational diabetes with hyperthyroidism. Few studies have shown no association, while some have shown a positive association, particularly with gestational thyrotoxicosis, and most of them, however, have shown a negative association. Now, one other aspect is gestational diabetics. Women with gestational diabetes have a higher risk of developing postpartum thyroiditis. This has been shown in this study, which looked at 342 women with gestational diabetes and compared them with 313 healthy pregnant women, and they were followed up for 1 year after pregnancy, after delivery also, and it was seen that 16.6% of those who had GDM developed had developed thyroid dysfunction in the postpartum period, whereas only 6.1% of those who had who were non-diabetic or did not have GDM, only 6% developed thyroid dysfunction, showing that there is a likelihood of having a great, risk of developing postpartum thyroiditis in women with gestational diabetes. They have a higher likelihood of developing postpartum thyroiditis. So in summary, I would like to conclude by saying that conflicting results amongst various studies may be due to patient selection methods, may be contributing to that inter-assay variability or difference in the number of participants in each studies. There's a need to carry out universal screening for thyroid dysfunction amongst pregnant women in the first trimester, and which holds true for screening for gestational diabetes or even identifying pre-gestational diabetes in the first trimester. Therefore, there's a need to study both these conditions, and there is a need for larger prospective studies to evaluate the association between thyroid dysfunction and gestational diabetes. But what is known today is that thyroid dysfunction is common in gestational diabetes. Both subclinical and overt hypothyroidism are associated with higher risk of gestational diabetes. In the presence of thyroid autoimmunity and thyroid dysfunction during pregnancy, women should be followed up carefully for a development of gestational diabetes in that pregnancy and in subsequent pregnancies also. Though hyperthyroidism increases glucose intolerance, studies are inconsistent regarding its association with gestational diabetes mellitus. Gestational diabetes, women with gestational diabetes have an increased risk of postpartum thyroiditis also. So with that, I would like to conclude and thank once again the organizers for giving me this opportunity, and I would be happy to answer any questions that are there.
Yeah, thank you, Dr. Rakesh, for an excellent lecture. And I think this has given a lot of insight to most of our clinicians that testing for thyroid in pregnancy, as well as especially when there is GDM, is very, very important. We do have questions, but we will take them at the end of the session. And now I invite Dr. Rajiv Chawla ji to speak on GDM and PCOS.
Good evening, everyone. At the outset, I am extremely thankful to Professor Hema Divakar and the entire team of SAIDIP for having given me this opportunity, in particular Dr. Sunil, Dr. Sheshai, Dr. Balaji, and Dr. Anil Kapoor, sir. I slightly twisted the topic because since yesterday I thought we have been listening about GDM. So what I thought that let me make a case for PCOS, how they are connected to GDM and how we can check the progression of PCOS toward GDM and subsequently higher risk of NCD in the future. So we know that PCOS was first described in 1935 by Irving Steen as a symptom complex associated with anovulation. They also described the association of enlarged cystic ovaries with amenorrhea, obesity, infertility, as well as hirsutism as PCOS. Subsequently, in 1919, again a definition came that it should have everything, whether there is an oligoovulation, clinical and or biochemical signs of hyperandrogenism, or it should be excluded for other etiologies for contributing towards hyperandrogenism. 2003, again, there was a revision of the criteria that let it be only 2 out of 3 when we talk about oligo or anovulation, clinical as well as biochemical signs of hyperandrogenism or polycystic ovaries on ultrasound after exclusion of other etiologies. But I think as on now, it is a Rotterdam consensus which came in 2003, which still holds true, which defines PCOS as the presence of any two of the following: an ultrasound appearance of polycystic ovaries, menstrual disturbances, and evidence of hyperandrogenism, which could be clinical and biochemical features after excluding other causes of hyperandrogenism, especially congenital adrenal hyperplasia. So when we talk of clinical criteria, let it be a hirsutism and acne, which are signs of androgen excess. And when we talk about biochemical signs of androgen excess, it could be androstenedione or increased testosterone levels or DHS levels on the higher side, or it could be a free androgen index or even LH levels on the higher side, or a disturbed LH-FSH ratio also. So we know that there could be many etiologies contributing towards hyperadrenal stage. It could be congenital adrenal hyperplasia. It could be androgen secreting tumors, Cushing's, thyroid dysfunction. It could be hyperprolactinemia simply, or it could be drug-induced androgen excess. So all these causes we should rule out before we conclude that it is PCOS. When we talk about incidence and prevalence of PCOS, well, there has been various studies talking about various numbers of prevalence in terms of prevalence of PCOS, but I think it is possibly the commonest cause of anovulatory infertility. As we know today, 90% of the infertile women going to a gynecologist or an obstetrician with anovulation, they have PCOS. The prevalence of PCOS is 40% in women with impaired glucose tolerance. And if you have a manifest type 2 diabetes, it could be 85% in those patients, those who earlier had a menstrual irregularity or PCOS. But when we talk about Indian scenario, well, again, it is little different than as compared to the Caucasians. Studies conducted on Indian PCOS women have suggested that abnormalities of the insulin receptors are possibly much more common in Indian women with PCOS as compared to those with Caucasians. So there is possibly an urgent need to organize preventive strategies when we are talking of starting with PCOS in adolescents, subsequently conceiving into their adulthood, then getting converted into GDM, and subsequently we know that if you follow these GDM patient, about 50% over 5 to 10 years will get converted to type 2 diabetes. Not only that, even offsprings born out of GDM mother, especially if there has been a poor glycemic control, will tend to have much higher NCD also. I think it is very, very important to focus right in the beginning from adolescent stage with PCOS, lest these patients, they ultimately develop into GDM and subsequently into type 2 diabetes. We know it is a vicious cycle of insulin resistance and PCOS. So it's a very, very dynamic dual relationship, but possibly it is the insulin resistance which seems to be the core defect, although it is again Han-Theory type, because there are elevated testosterone level, elevated estrogens, there is decreased sex hormone binding globulin, I'll be alluding to in detail. There is going to be an increased androstenedione, as well as DHA levels are also on the higher side. Today, when we talk about PCOS, it seems to be a much more complex metabolic disorder, with insulin resistance being a core defect, which is then subsequently associated with hyperandrogenism, with reproductive dysfunction, menstrual abnormalities. Subsequently, the risk of developing GDM in once these conceive is much higher. Not only that, risk of PIH or hypertension as such is much higher, and subsequent risk of developing macrovascular complication and even endometrial carcinoma is much higher in these PCOS young female. So when we talk about the pathophysiology of PCOS, we know that basic defects in PCOS are hyperandrogenism, which is seen in about 70% of patients with PCOS. It is anovulation, and of course the insulin resistance, which again 30% of the PCOS have impaired glucose tolerance. And when you talk of type 2 diabetes, almost 10% will have type 2 diabetes coming as a result of PCOS also. But 50% of patients with PCOS will have insulin resistance as well as both hyperinsulinemia right in the beginning. So when we talk about physiology, if you have a look on the hypothalamic pituitary gonadal axis, it is a hypothalamus which then leads on to increased frequency of gonadotrophic releasing hormone, GnRH. So there is going to be an increased pituitary sensitivity of increased GnRH, and this leads on to an increased pulse frequency of LH, which is a preferential mechanism as compared to an FSH. So there is an increased LHS versus decreased FSH ratio, which is almost diagnostic, as when you try to sum up with all the criteria with anovulation and of course having evidence of 60 ovaries on ultrasound, which again I'll be taking in details. So not only you have an increased estradiol and increased androgen secretion, which acts again stimulates pituitary to increase LH, and there's going to be a decrease FSH also by negative feedback in these patients. As a result of an abnormal neuroendocrine function in PCOS women, they have a persistent rapid LH dysfunction. I told you there is a preferential increase in sensitivity and cycles and frequency of LH. So LH and FS ratio gets disturbed. This leads on to an increased ovarian androgens and an impaired hypothalamic progesterone sensitivity. With reduction in FSH, there is obviously going to be an impaired follicular development, which will then subsequently lead on to an impaired progesterone production, subsequently leading on to not only hyperinsulinemia as well as hyperandrogenemia also. So as I said, insulin resistance remains a core defect, and it is possibly insulin receptor defect, which is much more common, which then leads on to a compensatory hyperinsulinemia from the pancreas. By virtue of hyperinsulinemia from the liver, you have a reduced sex hormone binding globulin production, which then sets free androgens and testosterone level, which go very, very high. On the other hand, from the hypothalamus, I told you have a preferential increase in LH production, a reduction in FSH. So stroma thickness also goes up. Follicles are not getting matured. There's not going to be an ovulation, and this leads on to an elevated androgens levels also. So if you have hyperandrogenism, not only you have a weak androgens like DHA and DHES, which will manifest subsequently as villous hairs or terminal modulated hair, but you have a strong testosterone production also, because sex hormone binding globulin is on the lower side because of severe insulin resistance into the liver. So you have all the side effects coming as a result of higher levels of testosterone. So what happens is that when you talk about clinical presentation of women with PCOS, when we see in the adolescent age group, they primarily have a menstrual irregularity. They have cosmetic concerns in the form of acne, hirsutism, or villus or hair loss. But once they are in the reproductive age after their marriage, not only they have an infertility, they have an early pregnancy loss. Somehow with intervention, even if they conceive, even then pregnancy loss is much higher. And the onset of pregnancy induced hypertension and GDM, which again I'll be discussing in detail, is much higher in these females. And towards the menopause also, if you have had PCOS in your adolescent age, that increases the overall onset of metabolic syndrome, and the risk of carcinoma, endometrium is very, very high in this PCOS female. When you talk about Rotterdam criteria on ultrasound, we know one or both the ovaries should have volume more than 10 ml. So there is an increase in ovarian volume, and each ovary will have at least more than 12 follicles by 2 to 9 millimeter in diameter, and it has a eco-dense stroma to differentiate it from a normal ovary. So when we are talking about PCOS getting converted into GDM or into the metabolic syndrome, again, we conclude that it is the insulin resistance which seems to be the core defect, with a lot of clustering of other risk factors, whether in form of dysglycemia, whether in form of early onset of hypertension, because these patients have a visceral obesity which is contributing towards significant increase in insulin resistance by its mechanism on liver. So there is going to be an increase in sex hormone binding globulin, reduction in sex hormone binding globulin, setting free testosterone levels and androgen level going on the higher side. So there is going to be a clustering of all these risk factors, making these patients who at a very high risk for development of metabolic syndrome in the subsequent life. Not only they have visceral obesity, they have hyperinsulinemia, they have hypertension, they have a atherogenic dyslipidemia, which leads to rampant atherosclerosis and hyperglycemia. Many of these patients, almost 1/3, will get converted to type 2 diabetes subsequently. And of course, this all happens because of physical inactivity and atherogenic diet, as well as visceral or abdominal obesity, which sets in not only the stage for developing PCOS, but subsequently also for GDM, and also leads on to conversion towards type 2 diabetes. So the criteria for metabolic syndrome in PCOS will be when you have an abdominal obesity, waist circumference more than 88 centimeter, when your triglycerides are already more than 150, your HDL level is low, your blood pressure is systolic more than 130 and diastolic more than 85, and you have a impaired fasting glucose, something like more than 110 milligrams. So even if there are 3 out of these 5 criteria are there, that means in PCOS, you already have the onset of metabolic syndrome. So these patients are going to have subsequent sequelae, not only in the form of NCD, risk of hypertension, they are also at a greater risk of developing coronary artery disease, and subsequently the risk of carcinoma endometrium in the post-menopause is also going to be very, very high. And as I said, PCOS is possibly a stage before the onset of gestational diabetes. In fact, all those females who develop PCOS have hyperinsulinemia. If they have moment there is a reduction in beta cell function, we know in the first trimester there's going to be an increase in requirement of insulin. And of course, earlier first trimester, you have a better insulin sensitivity. So there is going to be an increase in 60% insulin resistance, which will be compensated by that improvement in insulin values or expression. But subsequently, in second and third trimester, there is going to be an increase in requirement of insulin because of increased insulin resistance towards the third trimester by almost 200 to 250%. So if you have any amount of beta cell dysfunction, these females are likely to develop gestational diabetes. So it is not uncommon to say that GDM affects almost 4 to 7% pregnancies. Well, this is a very, very old data. In 2006, Dr. Rakesh has already shown you the 2017 and 19 subsequent IDF guidelines these days talking about 1 in 6 live births coming out of hyperglycemia in pregnancy. That means prevalence of GDM is almost to the tune of about 15% now, but definitely there's going to be a much higher risk of developing GDM, at least by 2.4 or 2.5 fold, which is going to be independent of age, race, ethnicity, and multiple gestation in all females, those who have PCOS. So GDM complicates 40 to 50% of PCOS pregnancy subsequently, and these females are subsequently, by virtue of having pure insulin resistance, central obesity, they are going to be at a much greater risk also for developing type 2 diabetes over next 5 to 10 years. So very good position statement, which got published in Journal of Clinical Endocrinology and Metabolism in as early as 2007. Out of all review of literature at that time, concluded that all PCOs should be screened for IGT at 2-hour oral glucose tolerance test. If you have a normal glucose tolerance, then subsequently it can be repeated every 2 years. But if you have an impaired glucose tolerance, then these females should be screened maybe 6 months to every 2 years to follow this patient, lest they get converted into type 2 diabetes. And every effort has to be done. This has to be used as a window of opportunity to make these females very, very physically active, lest they develop type 2 diabetes over next 5 to 10 years. So a suggested evaluation for patients with PCOS could be a physical examination, their blood pressure examination, of course, BMI, waist hip ratio. If values are greater than 35 inches or more than 88 centimeters, these are abnormal. Then the presence of stigmata of hyperandrogenism as well as insulin resistance, which could be in the form of acne, hirsutism, androgenic alopecia, or acanthosis nigricans, which could be real bedside marker for developing the risk of not only PCOS, but subsequently GDMs also in the pregnancy. So in the last, I'll just run through the management option in PCOS, what are going to be the goals. Of course, lifestyle changes are the main strength on which we should bank upon. It will definitely reduce the risk of developing subsequent GDM and type 2 diabetes and cardiovascular disease in these patients. We should avoid effects of hyperinsulinemia. We should reduce production and circulating levels of androgens. We should also protect the endometrium against effects of unopposed estrogen, lest these females develop carcinoma endometrium. And we should also induce ovulation to achieve a normal pregnancy in all those PCOs who are sort of looking for pregnancy. Lifestyle modification is going to be great. I told you, and every effort has to be there, not only to modify their diet, to reduce their saturated fat intake. They should have more complex carbohydrate with low glycemic index, exercise of at least 150 minutes as per Caucasian guidelines or ADA. But Indian guidelines say that this has to be at least 60 minutes a day, out of which 30 minutes has to be anaerobic and at least 15 to 30 minutes muscle building exercises, maybe 2 to 3 times a week also, which can reduce the risk of visceral fat and can cut down on insulin resistance. And we know that if we can somehow lose weight, we can sort of avert all these morbidities and mortalities in this patient, because by weight reduction, not only there's going to be a lower circulating free androgens and insulin levels, there is also going to be increased sex hormone binding globulin. Moment you have increased SHBG, there is going to be a reduction in free testosterone levels. So all those patients who are not pursuing for pregnancy but they have PCOS, they're possibly the best option. I'll not be going into the detail. Could be only OCPs, which could be the first line option, just to correct their menstrual abnormalities. And still after 6 months, if everything has not been corrected, you can put them on spironolactone 50 to 100 milligram BD or aldosterone antagonist diuretic also to have anti-androgenic effect. And of course, there could be a role of metformin, but that evidence with OCP with metformin is not very, very great, except it is of value in all those patients who have impaired glucose tolerance, because it is significantly going to improve the insulin sensitivity. But all those PCOS female, those who are going to pursue pregnancy or looking forward for pregnancy, their weight loss of 5 to 10% is extremely important. It is important to induce ovulation in those by clomiphene or maybe by gonadotropin use. And of course, clomiphene is the first line option in these patients. There you can then subsequently add insulin sensitizers like metformin or maybe TZs in the beginning, which will not only improve hyperinsulinemia, but will also regulate reproductive endocrine axis. Thiazides, we know, have been very good in terms of peripheral reduction of insulin resistance, but metformin is wonderful in terms of reduction of insulin resistance into the liver. Especially it is useful along with OCPs or along with clomiphene in those patients who are looking for pregnancy by reduction of insulin resistance from the liver as well as from the periphery. But a meta-analysis of 8 studies on pregnancy outcome have not shown the risk of major malformation even if you conceive on metformin. If you are a PCOS patient and you conceive while you are on clomiphene and on metformin, but few observational studies have suggested that there could be, if you are on metformin, there could be a low risk of GDM and PIH. So that could be one reason that most of the gynecologists, I need to learn from them, they still want to continue metformin if female is conceived till 12 weeks, although as per our own guidelines, ADA or DIPSI, we say that moment a PCOS has conceived, we can stop using metformin, because then there is no point continuing. And many studies have in fact countered that carrying rate is not better even if you continue with metformin, so it should be immediately stopped. TZs are not safe moment you conceive, so you have to be very, very cautious. And the last word about a new kid on the block, what Dr. Hema very rightly referred to is myostatin, which is significantly coming from grapefruit and from beans, almonds, and walnuts, because the content is very, very high. Because it has been seen that if you have a inosol deficiency, it is there in PCOS females as compared to the normal woman. And moment you have an inositol decreased level, that sort of decreases PI3 kinase activity. So what happens is that GLUT4 expression is going to go down, which will again contribute towards higher insulin resistance into adipose tissue and muscles because of non-utilization of glucose. And a small data of 50 patients, those who were on install 2 gram versus folic acid, it was seen that with my install there is going to be a reduction in insulin level as well as BMI, HOMA insulin resistant index will go down, and there is also going to be a reduction in total as well as free testosterone on my install. So my install along with metformin could be a very good option in sensitizing, in reducing insulin resistance, and also in getting better outcomes in terms of disappearance of hirsutism and in acne. So to conclude, PCOS is one of the commonest reproductive endocrinopathy to affect women, almost up to 10 to 15%. PCOS is the most common cause of anovulatory infertility today, and PCOS probably represents a spectrum of disease with variable presentations. Pathophysiology, I have already discussed, it is primarily insulin resistance with androgen excess through various mechanisms, through hypothalamic pituitary gonadal axis. Diagnosis, I told you, lab criteria, clinical criteria, and cystic ovaries on ultrasound. Those criteria are already discussed. Current treatment options are primarily focused on lifestyle modification, which is the most important part. Combination of OCPs in those females who just want a menstrual correction. They are not looking for pregnancies. But those females, those who are looking for pregnancy, maybe their clomiphene along with insulin sensitizer could go a long way. But it is most important to diagnose PCOS because of the long-term consequences. We are not just talking about PCOS today. We are talking about a larger continuum, a larger picture. When we are handling PCOS, we are not only cutting the overall prevalence of GDM, we are also cutting the overall prevalence of conversion from GDM towards type 2 diabetes by improvement in insulin resistance, by having much more physical activity, and maybe subsequently the risk of NCD will also go down. But well, you require a lot more research in this area to say how to actually handle this syndrome. Thank you very much for your patience listening. And Sunil said that Well, I think in every conference, I must put a disclaimer that as long as we have the next conference, which we are proposing in month of August, maybe possibly on 7th and 8th, till then, by courtesy of Sunil, I still remain the president. So, Sunil, my apology to you. Thank you. Thank you, Professor Hema, for this wonderful opportunity.
Thank you,
Dr. Rajiv, for that wonderful talk and making the twin metabolic disorders so easily understandable. Thank you. And I, on behalf of my co-chairpersons.
No, there are some questions. I'll just take. So thank you, Dr. Rajivji. So still there's a lot of debate on whether hypoandrogenism or hyperinsulinism is a primary defect. But today the evidence points more towards hypoandrogenism because it has been seen that PCOS women have their children born to be insulin resistant and having hyperandrogenemia. So the first question is to Dr. So that is why this to Dr. Rakesh ji as to why the government guidelines and endocrine society have not recommended universal thyroid testing in pregnancy.
Well, I think it is recommended. Universal screening is recommended in our country, just like universal screening for gestational diabetes is recommended. The Indian Thyroid Society and the Endocrine Society recommend universal screening of for thyroid dysfunction during pregnancy.
And I think actually screening for anti-thyroid antibodies like TPO is important because it has been seen that quite a number of them, if not treated, who have TPO positive, become overt hypothyroidism if they're subthyroid. So do you think we should do TPO in all patients?
Yeah, I think Dr. Shashank Joshi has also joined in. He has been part of the recent guidelines. He will also tell us about the recent ITS guideline, the Indian Thyroid Society guideline, which recommends universal screening, if I'm not wrong. I mean, I'll ask Dr. Shashank Joshi to add to this.
No, I agree with Rakesh. We recommend universal screening, particularly in a country like India. Universal screening is mandatory, whether it's thyroid or diabetes. So I think it's a no-brainer. Of course, we have data to support it. And Indian Thyroid Society guidelines, in fact, with Rakesh also is a part of it, has recommended with Foxy actually. And the meeting was held in Bangalore. And I think when the ITS con also was held in Bangalore, and I think the Foxy also is in Bangalore when the whole body met. And I think they have jointly recommended that universal screening is needed and necessary.
What about measuring TPO? Whether you think it should be done in all or only in a selective population?
Measuring TPO is almost routine in India, but whether it should be done in all is from a science standpoint, is a controversial question. And whether treatment of that also, whether it really works, is a controversial question. There are some scanned RCTs which show that it may have some role, but if there is a backup of infertility, probably the role is more compelling, and the evidence is more compelling. In absence of infertility, I'm not so sure whether there is any role.
Yeah, but it's also been shown that if you have a high TPO, the chances of having an increased miscarriage is there. And therefore, probably, especially in women who have PCOS, they recommend screening of TPO in these patients.
As I said that, TPO is positive in 10% of population. So we are not so sure whether really it adds true value. So as I said, if you have science in green, yellow, and red zones, I would say it's still in yellow. I would not say it's absolutely level A evidence. I would say I would still be a little cautious on that recommendation. Yeah. Universal TSH, no question asked. Universal TPO, Usha, you want to say something? Sorry.
No, I just want to say that if someone's TSH is perfectly normal, below the upper limit of the lab standard, you don't have to do a TPO. If it's clearly more than 10 and we are anyway definitely going to treat, you don't need a TPO. It's only those indeterminate that are in the middle, and you can use a TPO to decide first, to treat. So I'm just thinking it should be a more targeted because it's an expensive test, and like Shashank said, it's already present in about 10% of people. So it may be a costly thing to add to a routine screen.
There's another question.
Shashank and Rakesh, I just need one clarification. You have that publication IGM 2016 talking about hypothyroidism in pregnancy, where you have used that cutoff TSH as 4.5 or 4 plus. But now there are studies talking about when we are aiming something like 2 or 2.5, the prevalence of hypothyroidism, non-manifest or subclinical in pregnancy is even higher. In your study, you said it is 13%, with TPO almost 20%. So do you think that it is high time that we should bring the TSH point or cutoff to little less than 4? Because a lot of evidence has come that you make it less than 4, actually it is much higher prevalence.
Yeah, the recent American ATA guideline has actually looked at this value of 2.5 and all that, and they looked at the outcomes and tried and have concluded that you need to look at the country specific values of thyroid hormones during pregnancy, and region specific or rather country specific. So we have data from our country which is looking at pointing towards 4 being a better cutoff point, 4 or 4.5 being a better cutoff point, and based on that it is recommended that wherever you don't have data, you also use again 4 as a cutoff rather than 2.5. So going by all that, 4 is a more reasonable cutoff which is followed by.
There's another question. It says that if patient
the point is that I agree with Rakesh that we need to develop region-specific, trimester-specific reference ranges. TSH is very heterogeneously done in India, unlike some other parts of the world, and therefore to develop those TSH-specific reference ranges for normal and abnormal are different. There is some very elegant work from Calcutta and from Rohtak, based on which this was made. And the ETA stuck to that 2.5 and 3 in a bigger way. ATA has been much more open about it. It's a very gray zone area, and there's a lot of pharmaceutical pressure to lower these norms. But as I said, that I agree with Rakesh completely and Rajiv that we need to rework our norms. The trade-off is very tough, particularly in situations of recurrent fetal losses. The trade-off is tough. And there you will have to use individualized clinical discretion rather than an individualized TSH value and a cutoff which is region specific or trimester specific. So I think the therapeutic trials of thyroxine have been warranted in difficult or brittle cases. That's something of a norm. And this has been a traditional norm for the last 40, 50 years. So I think that's something which has not changed. If you see the old papers and if you see Anthony Topp's old BMJ editorials almost 30 years back, they talk the same thing. That if you are in doubt, treat. But, it doesn't work in all the cases. It will work in some of those. But otherwise, we need to have local, regional specific, trimester specific ranges for a standardized method. So when you are saying that this value is 4, you have to spell out the method. And that's what the ATA recommendation, which Rakesh was alluding to, now has clearly spelled out. ETA has still stuck to its gun and they have still maintained what they have said. They are very sacrosanct about it. But Europeans are more rigid. Americans are more evidence-based in terms of a litigious society. I think India, we have to balance between cost, availability, accessibility, and affordability. I think so. We have different trade-offs and different ways of handling the whole situation. But for that individual case, you will have to individualize.
Thank you, Shashank. There's another question by Dr. Archana. Is if patient is on metformin for PCOS or diabetes mellitus, she becomes pregnant, can we continue it until what gestational age? And do we have to stop for a day or 2 before delivery?
I have already answered that in my session, but well, again, to allude on that, see, ADA very clearly says that moment you conceive out of PCOS, you should start metformin, but most of the gynecologists still feel comfortable continuing metformin till 12 to 14 weeks because I told you 8 studies summed up that neither there is going to be any congenital abnormalities on metformin and maybe carriage rate will be little higher. So gynecologists are comfortable continuing metformin, although ADA 2020 clearly said that moment you conceive on out of PCOS, you may stop metformin and go with diet and lifestyle modification. Need there be, if there is an impaired glucose tolerance, you be on insulin. Metformin can be reconsidered or restarted after 20 weeks. This is what our DIPSI guidelines also said, which were released yesterday also and 2017 also, that after 20 weeks, metformin is absolutely safe. But prior to that, metformin ideally should be avoided. If at all you require any drug for better glycemic control, it should be insulin only.
Yeah, but according to the international guidelines, they say that it's the discretion of the clinician whether you continue or you do not continue.
ADA 2020 clearly said that you stop metformin once you conceive on PCOS. But I agree, a lot of papers and evidence
published in 2008.
I agree. I agree. I agree. I
So I
agree.
thank all the three speakers of the session for an excellent presentations as well as discussion. And I hand over to the organizers to invite the chairpersons and speakers for the next session. Thank you.
Our heartfelt thanks to Dr. Sunil Gupta, to Dr. Rakesh Sahai, and to Dr. Rajiv Chawla, the present president of DIPSI, for excellent deliberations on 3 different aspects of GDM. Before we move on to the next session, I want to express our gratitude to Torrent Pharma, Shield Connect, USV, Novo Nordisk, Montana Iris, and Life Sciences for their continued support in our endeavor of SAIDIP 2021. Now we move on to the second session of the day, that is the Divas session, where we will be having a panel discussion on pre-pregnancy care, a window of opportunity. To moderate this session, we have Dr. Usha Sriram. Dr. Usha Sriram is the founder of Divas, which is meant to prevent and protect girls from diabetes. She is also the director of TAG VHS Center for Diabetes and Endocrinology, Voluntary Health Services, Chennai, and the president, Indian Society for Bone and Mineral Research. The panelists for today's discussion are Dr. Chitra Selvan. She is a professor and consultant endocrinologist at MS Ramaiah Hospital. An area of special interest is women and diabetes. Dr. Shalini Jaggi. She is consultant diabetologist and director, Life Care Diabetes Center, New Delhi, and consultant diabetologist, Apollo Cradle Hospitals and Clinics, New Delhi. She is also a fellow of the Royal College of Physicians of London, Edinburgh, and Glasgow. The other panelist is Dr. Purvi Chawla, who is a consultant diabetologist and director of clinical research, Dina Diabetes Care and Mumbai Diabetes Research Center, Mumbai. She is also a consultant at the Bharatiya Arogya Nidhi Hospital, Juhu, Mumbai. On the panel is also Dr. A. Paneerselvam, who is a consultant diabetologist at the Aruna Diabetes Center, Chennai. His areas of interest are prevention and good control of diabetes, creating awareness at all levels. Dr. Sampath Kumar is from Muthu Kumaran Medical College and Research Institute, Chennai. She is also the President Board of Studies at the MGR Medical University. She was the president from 2015 to 2019 and member Board of Studies at the Meenakshi Medical University. She also was the governing council member at the ICOG from 2015 to 20 and has received the IMA Doctors' Day Award from the IMA TN State Branch. Dr. Sharmila is the president of the Menstrual Hygiene Management Consortium, director of Aditi Hospital and Parvati Ayavu Fertility Center, Trichy. She's also a consultant to the Southern Railway Hospital, Trichy, has been awarded the Shri Mohan Lal Award and Mohan Lal Desai Prize for standing first in DFB. She has been the past secretary of the Trichy OBGYN Society. And Dr. Shashank Joshi, who have been just hearing, he's a consultant endocrinologist at the Leelavati Bhatia Hospitals and Joshi Clinic, also the president of the Indian Academy of Diabetes, the past president of the Endocrine Society of India, and immediate past president, the Association of Physicians of India in 2014 to 2015. Over to the moderator, Dr. Usha.
Thank you so much, Rita. Thank you for the really kind introduction. And thank you for introducing this amazing panel of my favorite girls and, if I may say, my favorite boys as well, Shashank and Dr. Paneerselvam. from Chennai. Thank you all first for being a part of this Divas Symposium at SAIDIP. So first thing I have to thank Hema and Professor Seshaya and Dr. Balaji and all the SAIDIP leadership for including this this session in today's program. Thank you so much. And what we intend to do in the next 45 minutes or so is to discuss in detail preconception care of women with type 1 diabetes, type 2 diabetes, and also with pre-diabetes, which is extremely common. So without further ado, and largely because unless we take care of the women before they enter the pregnancy in a way that would be ideal for us to manage throughout the pregnancy, doing a lot of things once they have become pregnant, as I mentioned this afternoon in another panel, is the horse is out of the barn. It's a little bit difficult afterwards, but doing it before conception would make it so much better. So first I will share the case presentations and then invite the first moderator. Can you see the slides?
Yes, ma'am.
Okay. So please go ahead with clinical scenario 1.
Yeah. Thank you, Dr. Usha, for the introduction. So we're going to discuss a clinical scenario in the context of pregnancy and type 1 diabetes first to start with. So we have a 24-year-old woman who's had type 1 diabetes for 12 years now. She's on 38 units of insulin glargine at night and takes Lispro insulin about 6 to 10 units with each meal. Her blood sugars range between 65 to 110 milligrams per deciliter in the fasting state and between 130 to 180 milligrams per deciliter 2 hour postprandial state. Her last HbA1c was 7.3%. Her obstetric history has been slightly complicated. She's had 2 miscarriages in the last 3 years. One of them were at 8 weeks of gestation and the second one at 16 weeks of gestation. So she's had quite a bit of scarring and trauma related to this whole thing. And she's undergone an extensive workup for recurrent miscarriages, and all of those workup has come out normal. And the gynecologist wants the diabetologist and the endocrinologist to now plan for the next pregnancy. So if I can ask our panelists to discuss our next few steps. May I now invite Dr. Usha Sriram to share her thoughts, and then may I also invite Dr. Sampath Kumari to share her thoughts as well.
Sure. Thank you, Chitra. And actually, this was supposed to be Dr. Banshi Sabu's slot, but he couldn't be here today. So I'm sitting in for him. So this is a very, very difficult situation because pregnancy losses are tough for anyone, and especially for type 1 patients, because it's with each passing year they may develop newer complications, and we also need to understand what caused the miscarriages, which I will come to in the third point. The first one is, of course, blood glucose control and targets. Fortunately, the targets are the same in pregnancy for both type 1 and type 2, but pre-pregnancy, I think for pre-gestational diabetes, we need to get them under really good control, and an A1C of 7.3 is clearly not acceptable. While some professional societies are okay with an A1C of 6.5 or below, many others would like it as close to 6 as possible. And some even allow below 7 if that is all that is possible without getting into serious hypoglycemia. So we have some work to do in terms of this patient, 7.3. I would aim to bring her down as close to 6.5 and below without causing hypoglycemia because it's type 1. As far as a choice of insulin, I think she was on glargine, if I remember right. So in terms of the professional society's recommendations, typically they ask us to use something like Detamar as a basal insulin or LPHs, in basal insulin. But if somebody like a type 1 patient has been on glargine and doing well, and if we have the luxury of making the change ahead of time, you can, with the new Fiasp or with Detimar and with analog insulin. But if she's doing well on glargine and wishes to stay on it, no harm. I don't mind continuing the glargine in this patient. So I would use a basal insulin and also insulin, analog insulin short acting. One other option is we could also consider pump therapy, especially because she's had 2 miscarriages. If we find out that the previous pregnancy losses were because of poor glucose control. And then what I would do is probably discuss pump therapy as well with the patient to get them under very, very good control so there are no more pregnancy losses. The last one, the question about role of CGMS, I think it's extremely valuable because it helps us to do many things. One is to know when hypos are happening, the time and range. It also helps us, and also the new guidelines have come out from ADA and other societies about for pregnancy, how much should be time and range. So we can follow those guidelines. It also helps patients to be motivated about the changes with their diet or changes with their activity when they have the CGMS and they can make those changes. So these would be my approach to these questions.
Thank you, Dr. Usha. May I now invite Dr. Sampath Kumari ma'am to share her thoughts. Ma'am, specifically as an endocrinologist, my question to you is, do you think the diabetes is one of the causes for the recurrent miscarriages? Or do you think is the HbA1c of 7.3% not good enough before we plan pregnancy? So your thoughts, ma'am.
Good evening to all. First of all, I thank the organizers for giving me an opportunity. Yes, diabetes could be one of the cause for miscarriage, but diabetes alone is not the cause. So we have to see at 8 weeks and 12 weeks from her history whether any other etiology was present, whether her BP was under control and whether she was thyroid, and everything has to be ruled out. Diabetes alone will not be there, I don't think, from the history. So as far as she is a case of type 1 diabetes, as Dr. Usha madam told, we will keep that diabetes under control, and HbA1c, we will counsel her as a pre-pregnancy. Her HbA1c should be around 6%, such that she will be free from other anomalies. And she has to be given the 5 milligram of folic acid before she plans. Once the HbA1c is controlled, we will go with that nutrition diet and the folic acid, calcium, and all nutritional effects, and the lifestyle exercises. If there is no other cause for the pregnancy loss, and because of type 1 only, means we have to be very sensitive to keep the HbA1c under normal, and then we will ask her to become pregnant. This is the way I want to rule out for her.
All right. Thank you, Dr. Sampath Kumari and Dr. Usha Sriram. May I now hand over to Dr. Purvi Chawla to take us through the next clinical scenario, please.
Good evening, everyone. Thank you so much for this lovely inclusion. So moving on straight to the next case. So we have a young lady, 31-year-old, diagnosed with type 2 diabetes since the past 3 years. And she had a history of GDM in her first pregnancy. And thereafter, 18 months later, she developed type 2 diabetes. So now she has been hesitant getting, thinking about pregnancy again. But typically, the child is now, her first child is 5 years old, and she probably has second thoughts and wants to think about pregnancy again. For her diabetes, she's been taking vildagliptin and metformin combination, and her A1C is still at 8.1. So she was started again. Her therapy was stepped up, and there was voglibose also added to this regimen of vildagliptin and metformin. And the next question is, should she consider the pregnancy? Should she forget about it? How do we go about this? So what is our advice to her going to be? And for that, may I invite Dr. Sharmila and Dr. Paneerselvam to please share your thoughts as experts on the panel.
Good evening to all. Actually, thank you, Hema ma'am, for the opportunity. It's very rare situation that we get a patient like this in the pre-pregnancy period. Usually they land up pregnant and then come to us. Very difficult situation to manage, and she's already on a oral hypoglycemic agents and she's not controlled also. So very difficult, but when you get a patient like this, I think we should take it as a golden opportunity. Counsel her correctly. HbA1c of 8.1 is not acceptable when she's planning a pregnancy. Try to bring it down as low as possible, around 6, so that she's got a better chance of continuing a pregnancy and reducing the complications which will happen during obstetric period. And the other thing is, as Sambat ma'am said, folic acid is mandatory now. You give her folic acid so that at least there's some form of protection for her. And blood sugar control should be totally taught to her. She has to be taught on blood glucose monitoring, because during pregnancy, they actually do it much better. So when you talk to them before pregnancy, you can always utilize that period. A diet, exercise, everything has to be planned out clearly, and counseling forms a big part, because many women who are like this will accept a counseling because they do not want a complication during their pregnancy. And evaluation of comorbidities should be done so that you don't have a problem before she starts a pregnancy, so that it's smooth. And that's what I would
could you
go about.
elaborate on the comorbidities that we should evaluate?
Yeah, the thing is, fundus examination should be done, and we need to check out our kidneys, whether they are functioning well, whether they need nephropathy starting. And echocardiogram also should be done in the present day of time, because we are facing quite a number of problems during pregnancy with cardiac problems after they become pregnant. So all these you need to evaluate before you counsel her to start a pregnancy management.
Right, madam. So good evening to all of you. Next to SAIDIP. So my baby is OHA and pregnancy, but unfortunately she has developed type 2 diabetes, GDM. But after GDM, they are likely to develop type 2 diabetes at least after 2 years, minimum 3 years to maximum 5 years, or even 10 years. But she has developed within 1.5 years or 18 months. Probably she might have not been aware about it. So this area makes us aware that we should educate all our GDM mothers. They should not develop diabetes within this period, or at least during next pregnancy. Because of awareness and education, some of them are avoiding GDM in the second pregnancy.
Oh, we are not able to hear you.
Dr. Paneerselvam, I think there's some technical difficulty.
Ma'am, I think the screen is frozen, so the connection.
Pose the question to an alternative endocrinologist, please.
Sure. We have Dr. Shashank Joshi and Dr. Usha Sriram also with us, and Dr. Rajiv Chawla is also there. So great, we can discuss that.
Okay, do you want
I think ma'am would love to hear your thoughts on this. And I
want to hear from Shashank and of course, if when Paneer takes his thing back, we'll have him give his views as well. You know, I didn't talk about comorbidity evaluation in the previous question because this was coming up. And I think it's really important that Dr. Sharmila brought up the eye exam because it's also been told that sometimes with height control, when we initiate height control, they can have transient worsening of the retinopathy. And so they need to have an eye exam before we initiate the, tighten the control, and then the kidneys, of course. And a new specialty is evolving called cardio-obstetrics, primarily because of all of these things, because now the leading cause of morbidity and mortality for pregnant women now is heart disease. So, and also because of, cardiac assessment and very important because some of them can have dissections and things like that during labor. So that's very important. And if somebody has had type 2 diabetes for a long time, all this applies as well. But she's just, had it for a very short time. But at least I would do some basic stuff like eye exam and a kidney exam, maybe not a heart exam. So it's very important. And the same choice of insulin schedule for initiation applies here as well. I would, switch her to insulin, and I will let Shashank and Dr. Chandra talk about that. And my favorite is the postpartum care. I think all GDM women, and I think that's what Pani was trying to talk to us about, is we shouldn't let them out of our sight. They should be talked about this high risk for future type 2 diabetes from the day they are diagnosed with GDM. And if I may, please indulge me just for a minute. I just want to say that the tone that we take with the patient on that very first meeting, when we tell them that they have GDM, it sets the tone for the rest of their life. Because if we tell them, don't worry, this will go away as soon as you have the baby, just be a little careful. If we take that tone, they are not serious about it. On the other hand, if we say, I'm so glad we picked this up, this is a wake-up call, and this could put you at very high risk for type 2 diabetes, and we can overcome all that with breastfeeding, attention to weight, preconception care before next pregnancy. So if we take up that tone and keep on talking about it, not in a menacing tone, but in a very positive way, if we keep on talking to them, I think it will be very, very helpful to the women. So I give it back to you, Purvi.
Thank you, ma'am. Thank you for that. I'd love to hear thoughts from Dr. Shashank and Dr. Rajiv Chawla and Dr. Sunil Gupta as well. And we have Dr. Paneer Selvam back.
Okay, good.
Yeah, regarding, I think Madam covered voglibose and vildagliptin as well as the metformin, better stop and continue insulin. Titrate the insulin dose and effectively control diabetes with the help of insulin before she conceives. So that should be the primary goal. Then only she can have safe pregnancy and safe delivery also. Regarding comorbid conditions, after the age of 30, she may have some hypertension or dyslipidemia, that also, or hypothyroidism. We have to evaluate.
Great. Thank you, sir.
And postpartum care, again, after delivery, of course, she will continue to have type 2 diabetes.
So what is a reasonable time frame
Hello?
for this? Yes, sir.
So we have to continue insulin, still lactation. After lactation, we may have to give oral drugs for her. And of course, contraception also. After 2 deliveries, she can go for permanent family planning procedure or even temporary procedure. But she can get controlled with her breastfeeding. We can go back to oral tablets. That should be the way of treatment for this patient.
Very well, sir. Also there should be focus on weight loss in this postpartum period.
And such patients actually listen very well when you talk to them in the postpartum period, because she has come willingly for a pre-pregnancy consultation. And if you catch her in the delivery period and talk to her about the postpartum and how she can even totally control her diabetes with her lifestyle management, many listen because they feel that the complications are actually most late to understand now. To the ages now, they think if they can do better, it will be good to them as well as for the baby, because the future of the baby depends on them. The fetal origin of adult diseases seem to have caught on to the general population also. So you catch on that, talk to her, and when you counsel them, most of them manage. And we have seen first pregnancies, them having GDM, and second pregnancy, totally normal sugar levels. That too we are seeing in some women now. So counseling forms a big part in the management, and that too in the postpartum period.
Right.
Excellent, ma'am. So with that, I hand over the baton to Dr. Shalini Jaggi for the third case.
Thank you, Dr. Purvi. I think we're all having a great time, and many thanks to SAIDIP, Dr. Hema, Dr. Usha, Dr. Seshia for having all of us here. So now my clinical case is something which is somebody who's very awakened, because normally this doesn't happen. By the time they come to you, things are already over the bridge. So now this is a 26-year-old lady with BMI of 30, a strong family history of diabetes because both her parents are already diabetic, and she has just done her check and her A1C is 6.1. The reason she's come to you is because she's already married for 6 months and needs some counseling because eventually she's going to plan pregnancy. Of course, she does not have any noticeable comorbidity. She's not on any other medications for anything else. So she's already on barrier contraception. She's somebody who's aware because she's got a family history of diabetes, and she's just come to you to discuss. So this is exactly what we talk of, preconception counseling. So I would like to ask Dr. Shashank sir first. So what exactly are the red points here, the warning points that you need to warn this patient since she's come to you even before she's conceived? So this is somewhere where we can really make a difference. When we're talking of NCD prevention, we're talking of GDM prevention, we're talking of all these strategies. So may I ask Dr. Shashank sir, regarding this case, what exactly are the warning signals here? What are her risks? And how do we counsel this lady?
Shalin, this lady is obese. She has a very strong family history of diabetes. She's got an A1C of 6.1, which means she's a diabetic. And, she doesn't understand that these are red flags for her. Being family history, she can't choose her parents. None of us can. She definitely can control her BMI and have it around 23 and below. She definitely can shed some fat and be physically active, eat less, eat appropriately. She definitely needs to have an A1C below 5.8 pre-conception. And she needs to be motivated. But I think people don't take this seriously at all. I think women in general think that, being plump and obese is like a prosperous sign and it's sign of good health and they will have a good chubby baby. I think, at the lay people and population level, people still don't think that they think a little excess fat is good. And, when people see a doctor like me, they feel that, they have come to some wrong place and wrong number has caught them. So I think that's the big problem in India. I still feel length and breadth of India, this is a challenge. And even in the most urban and the neo-rich class, they still have this wrong perception and myth. So I think first is you need to tell them that diabetes is equal to a heart attack. And having a diabetes is equal to a heart attack. I think that's the way, as Ushaka said, that you need to make them feel a little more serious. I personally feel GDM is nothing but type 2 diabetes being diagnosed during pregnancy and will continue after pregnancy if you don't take care of it. And you have to be very blunt with them that you have got a lifelong disease, you need to take care of it. So you need to be very, very proactive and motivational and positive. We can't make them negative. So don't fear them. Don't say them that you are going to die because you have got a heart attack equivalent disease and all. I think you need to motivate them and make them feel good, but at the same time not reckless. So pretty much to prevent GDM, weight loss, appropriate eating behavior, a lot of physical activities need a guard. So that's the way to prepare pregnancy. See, in India, people don't really plan or prepare pregnancy. The only way they want to plan or prepare pregnancy is if they have wish from their in-law side, or they have some religious reasons, or they have astrological reasons. I don't think they come to doctors for planning pregnancy at all. I'm sorry to say that, but that's the truth of life. And we see these people every day. So, yesterday was Amavasya, it got over at 3:05. All my patients told me, these were all pregnant ladies who didn't want to get, who were just diabetic ladies who all got delivered. We had six C-sections after 3:30 yesterday. Ridiculous. But that's India for you,
That's it.
Akka, it still happens in India. Okay. 2021, yesterday Amavasya got over at 3:05 and all the LSCS were planned after that. Okay, so I just don't understand the logic. I mean, it's completely befriending my logic completely sometimes. But that's how it is. There is no science in this. There may be some cosmic rays and astronomy, but it befriends me. And I would like Akka to educate me how planetary changes affect fetal movements and outcomes of pregnancy, etc. We really need to study this. in a scientific way, because our Prime Minister is very keen that we investigate these things now, because with mixopathy around, we need to do that. So our challenges in GDM, so coming back, not digressing, are very serious, that we need to tell that lady in a positive way that she needs to lose weight, she needs to get her A1C down, and she needs to be ready with an A1C at 5.8. And after pregnancy, the first trimester it goes pretty cool. It's the second trimester when there are carbohydrate bombardment, and that's the time it's like a glucose stress test, and that's the time you have unmasking of GDM, and that's really that's very preventable. I feel 90% of GDM can be managed by good medical nutrition therapy at all, itself. You really don't need drugs or insulin, but that doesn't happen all the time, and that's the big challenge we have. So I think, and there are clear-cut predictors of GDM. I think predictors of GDM, of course, family is one of them, weight is another one, pre-pregnancy A1C is another one, presence of other non-communicable diseases, including hypertension also is another one. So all these are clear-cut predictors.
Yeah, there was an installation order also.
I think you need to be motivated. I think we are simply not motivated to take GDM or diabetes in pregnancy seriously, or diabetes in general seriously. I think that 6.1 is often dismissed as a normal value. So
Sir,
I think
one
we are
point
not
I want to tell Dr. Shashank, one point. Nowadays, most of the patients, now even in whether it is in the private hospital or government setups, we have the pre-pregnancy counseling. Even in the government hospitals, we have that 1 hour session for the pre-pregnancy patients. Now it has almost changed, I think, sir. That is doing LSCS in Amavasai. That and all now it has.
Madam, I'm telling you what happened in Mumbai yesterday. What are you talking, madam? I don't agree.
Ma'am, it happens in Delhi as well. I mean,
North
India is very rampant.
Western India and North India is very rampant. Maybe Chennai and South India, maybe it is better, but we still. I'm telling you what happened yesterday. I mean,
we also have, sir. Middle of the night when you have cesarean, better babies, I feel.
Yeah, 3 o'clock. See, the 3 o'clock to 4 o'clock is the Brahma Muhurtam.
Brahma Muhurta.
So, madam, I agree that maybe you see south of India, things may have been a little more advanced, but a lot of these things dominate day-to-day life, and that actually leads to a bigger explosion. See, we have 20% of our country with GDM, and I think that's not something to worry about. I mean, I wear a hat of IVF.
Counsel is very, very important, sir.
Madam, counseling is important. I agree. We want to counsel. But unfortunately, what is happening, ma'am, is that people listen from one ear and leave it from the other ear. And ultimately, the big lady of the house makes all the decisions. I think we have no role in it.
That lady was once upon a time daughter-in-law only, no, sir. When she becomes a mother-in-law, she cannot change abruptly. Now it has changed.
I am very happy to hear this, ma'am. And I think we should call you more often to motivate people in Mumbai and Delhi.
Absolutely, sir. So I think the winds of change have started from the south, and let's see when they reach the west and the north. So just coming back to our topic, Dr. Usha, ma'am. So like Dr. Shashank very clearly said, this is a lady who's on the tip of a volcano. She's obese, the BMI is high, the HbA1c high, she's planning conception. So what exactly would be your advice to her when it comes to preconception preparation for pregnancy? Sir talked about weight loss, sir talked of achieving an HbA1c of 5.8. So how do we bundle up everything so that we motivate this woman? How do we follow up this woman and ensure that this is a volcano that probably we can still prevent from, exploding?
Probably the hardest of the three clinical situations we have discussed, because the first one and two will be motivated, but at least like Dr. Sharmila says, she has come to us. Just we have to grab her and take care of her. I'll start from the bottom, which is predictors of GDM. So as far as predictors, the ethnicity, parents, all that, nothing, age, we can't change any of that. But what we can change, what can predict are, as Shashank nicely said, the BMI, the pre-diabetes, and as I mentioned in this afternoon's talk at the Chelaram Institute, cardiovascular risk factors like cholesterol and triglycerides and HDL all seem to also predict increased risk for GDM. So these are all things, and then the kind of foods we eat, the microbiome. So all that are predictors and they can be changed. So that is something that we need to work on. Because if we go from bottom up, the strategies for prevention becomes that. So as far as preconception preparation of any woman, and this is the one that is closest to my heart because I'm working on this, and so if we need to look at this person as a whole, for example, look for anemia and fix that, which is more present in 50 to 60% of our girls. We need to look for blood pressure and fix that. We need to, barrier contraception is, dicey. It is not foolproof. So I would prescribe some other contraception, which is more foolproof till her A1C is in better shape. Okay. And then of course, definitely for the pre-diabetes, it's primarily diet and weight reduction and physical activity. I wouldn't consider any medical management at this time. And then things like folic acid for sure, vaccination. All her vaccination should be brought up to speed. Any micronutrient deficiencies. If she has a thyroid issue, check that and optimize her TSH. Vitamin D, we know that we can't give big doses of vitamin D in early pregnancy, but we can pre-pregnancy. So we can optimize vitamin D levels, and then also get into other things like exposure to air pollution, about smoking, alcohol, drugs, over-the-counter drugs. So do a complete, evaluation of the woman and her other health history, and then optimize all of these things, because this is a golden opportunity for any woman in the reproductive age. In India, we have something like, I saw a number that blew my head. 350 million women in the reproductive age group. So if we are able to somehow, do this with that age group, a big chunk of our population could get healthy. So these are all things that I would address. At the bare minimum, as Shashank and others have said, healthy eating, physical activity, bringing the weight down, and then all that smoking, alcohol, drugs, medication review, all of that. And because there are people who take things without knowing that it is not safe for pregnancy, either because it's natural or herbal or over the counter and things like that, or they just keep on taking it. So finally, the strategies for prevention, the only thing that has shown to work so far is physical activity and weight reduction prior to the pregnancy. And also the radial, the Finnish trial looked at it between pregnancies in women with a previous history of GDM. It's only this kind of lifestyle intervention that has worked. Yesterday, Hema talked about myoinositol and vitamin D. And I think if a large study can be done across the country, I think that could also prove to be a great strategy.
Thank you so much, Usha ma'am. And just before we wind up and hand over to our chairperson, just a quick question to Dr. Shashank and to you also. This is somebody who's come to you for preconception. So you're picking up all the red flags and trying to kind of, help her get back and reduce the risks. But what do you do to the general population? Because like Dr. Shashank very clearly said, they don't come back, they don't come to you usually. So is there any way that we can probably stem this through awareness, through different movements, creating an awareness for all these risk factors, because all this matters? What do we do? Why are we failing in spite of so much of literature, so much of data? Where are we going wrong? And what can we do to stop this?
Kambi?
So Shalini and Akka, I think two things. One is that Women's Day is being celebrated in a big way now. We know women are the more powerful gender, biologically and otherwise. So I think that's the first important step towards that. And women's health is getting more and more recognition. So I agree with you that we need to emphasize on women's health, and conception is a very important event in her lifetime. And I think that's getting focus. I'm ashamed to say that even today in India, anemia still remains the biggest challenge, and we lose lives of women because of low hemoglobin. So I think that's, till we don't circumvent that, GDM is a far way to go. I'm happy that for Professor Sheshaya is celebrating his birthday, which recently went and which is near and around Women's Day as a GDM day. So we are trying to generate, popular measures, but these are not easy. I think the most impactful is in regional languages, if you have more motivational programs and use social media effectively, because the younger generation is a very aware generation. My only issue with the younger generation is they're very aware, but when it comes to themselves, they don't practice it. They are very well informed, but they don't make informed choices, and that's the stitch which we need to do. And I think for example, Purvi is a social media which kid. I am not at all good on this, so but she's a very Instagrammer and this Facebook and Twitter, and Akka and me are still grappling because we are the old hats and we are still struggling. But Purvi is very, very prompt. Shalini, you are also very prompt. We are still learning, so we are like students, but we need innovative ideas. But I think what you say is very important, that women's health needs to be at the top of the line, in which pre-pregnancy health is vital, crucial, and critical. I think that's extremely important, and I'm very happy Madam Sampat Kumari saying that they are having 1 hour to counsel in a busy OPD in Chennai. People very rarely find that in other parts of India. If you can give 1 hour for counseling, it will be 1 hour. Sorry, Paneer?
Adolescent clinic in government hospital. Adolescent clinic. Adolescent girls are counseled.
Very good. I'm very happy. As long as they are motivated and they make a change, I think that's very, very commendable. And that's very difficult because adolescent girls or boys are very rebellious in nature. Human beings are in general rebellious in nature. And therefore, if you are able to make that change, I think we should congratulate and compliment them and adopt that model across India, because change is difficult to do, and behavioral change is so tough and difficult to do. So it's not easy. Like, I am not at all internet savvy. Like today, I lost that connection and that connectivity couple of times. Last time when Usha called me, I didn't know how to connect only till the end. So today, Akka called me now. Twice she sent me the link. Ultimately, I could get through. So this is not an easy thing, getting through this connectivity and all. So Akka, you need to devise strategies. But I think we need to be more.
I have a strategy.
Yeah.
You will hear about it on the 28th. I have the most amazing. See, nothing is accomplished by alone. So whether it is Chitra or Hema or Purvi or Shalini and I see Purni, I mean, it's just amazing team around. On the 28th, we are going to be launching something, and it's called it's a program called Didi, which is a Divas initiative for diabetes. And one of the things that is highlight of that is going to be preconception care, how we are going to reach the young women of India. And so all I can say is stay tuned.
So what did you say? Didi?
Didi.
Didi. Like Mukka Didi.
Yes, it's like Didi, elder sister, Akka.
The Hindi word for Akka.
Yeah, I know,
Hindi word for Akka.
Nowadays, the Didi is synchronous with her fracture and her pictorial, which is very impactful. But we should use such pictorials, Purvi, to impact actually a behavioral change.
Sure.
That how reckless behavior of not wearing a seatbelt can lead to an accident like this. Similarly, eating inappropriate foods can lead to a fetal accident.
Yeah.
So,
Infographics.
we should use every opportunity to make an impact. Yeah. So now that picture is very vivid in everybody's mind. That was viral. So I think Usha, my suggestion to you and Hema Akka is that use every viral moment which is there in the social space and in the media to make a change. I think that's the way to do it, probably. And then you have all these wonderful girls like Purvi and Shalini to assist you with the modern age tools.
Yeah, but you're not going anywhere. We have recruited you.
I am outdated. I am retired and outdated. I am retired outdated.
No way.
Don't try to escape. So on that note, Hema, thank you so much. Truly,
is that in the platform.
Thank you, Hema.
Very big thank you.
Thank you, Hema, ma'am.
Only one word. Madam Usha, madam, only one word. Sir, I am also retired from government service. Since retired, we have a lot of time to counsel the adolescents. Adolescent counseling alone will reduce the GDM, sir. Thank you.
Yes.
A big thank you to Dr. Usha Sriram and all the panelists. And I just realized that we had the first two sessions of today in peak Rahu Kala, which is 4:30 to 6 p.m. But everything did go off very well. And I'm sure the 2,000 plus delegates attending today have benefited a lot from the case discussions that we just had. Moving on to the third session for the day, which is a special session on ground realities in low middle income countries. The chairpersons for this session will be Dr. Jayam Kannan, Dr. Mandakini Meg, and Dr. Hema Divakar. And they will be listening to Dr. Preeti Kumar and Dr. Rajesh Jain, who will share their experiences about universal testing in India, how to bring the dream into a reality. Dr. Jayam Kannan was Vice President Foxy 2018. She's a Foxy Adolescent Health, part of Foxy Adolescent Health Committee 2013 and 2015. She has a major number of achievements to her name, and we're very happy to have her with us today. Dr. Mandakini Meg, she was a maternal health consultant for the government of Maharashtra, UNICEF. And of course, Dr. Hema Divakar needs no introduction. Dr. Preeti Kumar, she was Foxy Manyata champion from 2017 to 2020. She's the chairperson, Safe Motherhood Committee, Foxy 2020 to 2022, core member, Prevention of Violence Against Women Cell of Foxy 2018 to 20. She's the director, Sunflower Medical Center, Lucknow. And the other speaker would be Dr. Rajesh Jain, who is a consultant diabetes and director, Jain Hospital, Kanpur. He was the representative for the United Nations at a high-level meeting on NCD in 2018. He's a project manager, Diabetes Prevention Control Project with National Health Mission supported by the World Diabetes Foundation, Denmark. Over to the chairpersons.
Jayam, you have to unmute.
Thank you very much, dear Purani and Hema, Preeti. We are all members of the Manyata team. And this aspect of diabetes, which is being given the initiative now, is a very, very important tool which we have been following in the last 2 decades. So, not disturbing your speech, I request Preeti and Jain to share your experiences one after other, your personal experiences on this universal screen. Over to Hema, any message?
No, I will take up for discussion after they speak. Yeah, Preeti,
Okay.
do you have slides to share? Or you
Yeah,
want?
I have slides to share.
Yeah, please go ahead.
Thank you, Dr. Jayam, for the kind introduction. First and foremost, gratitude to Dr. Hema Divakar and the team SAIDIP for inviting me here for this very important discussion, the ground realities on the single step test. So let me share my screen because I have just 10 minutes to speak. A special gratitude to chairpersons as well, Dr. Mandakini Meg, Madam, Dr. Jayam and Dr. Hema. I would be taking to you, sharing the experience, the ground realities which I faced in Jharkhand, because Dr. Hema is also aware that we are doing a project in Jharkhand that is on gestational diabetes mellitus and anemia in pregnancy. So I would be, as we all know, that gestational diabetes mellitus, a lot of discussion was going on just before this session. It is carbohydrate intolerance with recognition or onset during pregnancy, and the definition is evolving now. And we call it as hyperglycemia in pregnancy. And this is definitely a window of opportunity. We had a lot of discussion just before this session. FIGO has given a recommendation that hyperglycemia and gestational diabetes mellitus is considered a global health priority. And it is one of the most common medical conditions that a woman encounters during pregnancy. And this is a very common slide. We quite often see this, but still, this needs to be emphasized again and again during all these sessions. Therefore, the FIGO has recommended that there should be universal testing for all pregnant women and for hyperglycemia in pregnancy during pregnancy using one-step procedure. And the same was endorsed by the government of India in 2018, where the leaders like Dr. Hema were the part of these making of guidelines, and they also recommended that universal testing of all pregnant women using single-step test with 75-gram glucose in fasting or non-fasting state is justified in a country low-resource setting. The question here is, it is a one-step test. It picks up 3 times more pickup of diabetes, suitable for Indian setting, saves time, saves cost. The government of India has also approved, and you have to do it twice in pregnancy, the first trimester or at booking, and the second one is 24 to 28 weeks, and if feasible, at 32 weeks. Now, I'm going to share the ground experiences. This is a project which was done in Jharkhand. It is still going on, and this is a pilot project which is supported by USAID and IB Global, and it is being done by under the aegis of FOXI and Safe Motherhood Committee. The launch of this project was done on 15th of January, and the mission was to defeat diabetes, and I really acknowledge the efforts and support given by Jharkhand team, especially the names which are mentioned here. I would, in next 5 minutes, I will be sharing my experiences, what we really had, the survey data and the analysis which we have done. So we took 34 private centers in Jharkhand. The cities which we took were Bokaro, Jharkhand, Dhanbad, and then Ranchi, Girdi, because these were all aspirational districts, and USAID was interested in taking the study in the aspirational districts. The doctors and the healthcare workers undertook a baseline survey, and then we did an e-mentoring and e-training on the DIPSI guidelines, and then we had the post-training assessments. Now you can see these are the 3 survey tools which were designed. One was for the facility, the second was for the healthcare worker, and the third one was for the doctors. And the questions were related to anemia and pregnancy and gestational diabetes mellitus. Most of the surveys were done on site. All the healthcare workers, the enrolled were 240, and we had the on-site survey of these healthcare workers. And we tried to just find out about the awareness, why, how, when, and whom, among all ranks and resource material availability, record maintenance, and regular communications to prevent the dropouts. The ground reality is universal practice of DIPSI guidelines is recommended, but let us see whether it is implemented or not. The doctors were aware of the single-step test, but they were not practicing. Healthcare workers were very well aware of this single-step test because most of the centers were Manyata centers. Healthcare workers, when we took the lab technicians, they were not at all aware of the single-step test. All the healthcare, most of the healthcare workers and the doctors were aware that yes, all pregnant women should be tested for diabetes in pregnancy. But look at this. This was a survey of the facilities where the glucometers were present in 100% facilities, but they were sending the testing to the labs. About 79% were testing, and the screen positive record were only 53%. Like about all the centers, only 50% of the doctors and facilities were maintaining the records. Coming to the resource material, most of the centers were using glucon C or glucon D. Only 47% of these facilities were using anhydrous glucose of 75 gram. Now, when you look at this test, they had the knowledge of single-step test, but look at the graph of random tests. Most of them were doing the random test in the pregnancy, even though they were very well aware of the single-step test. Now, looking at the survey of the doctors, when to screen, they all were, most 82% of the doctors were very well aware that you have to test these patients twice in pregnancy. But how to screen these patients, only 50% of the doctors were performing single-step tests. But I would rather say, at least we have achieved this data of 50%. We should be proud that the spreading of awareness, we could at least motivate these 56% of the doctors to do single-step test. When you retest, all we're doing at the 24 to 28 weeks, and they were very well aware of the cutoffs of blood sugar levels. Now, waiting time, 65% were making the pregnant patient women wait in the clinics, and 35% were allowing the patients to move out. So we're not sure whether the data was correct or not. Now, coming to the awareness of the healthcare workers, they all were aware of the single-step test, but look at this, because 43%, because most of the doctors, the facility owners were not doing so, healthcare workers were also not basically doing the this thing, were aware. This was regarding the awareness, whether they have the awareness of single-step test or not. So the analysis of the survey of clinician is that 56% were following DIPSI guidelines. 82% test at first visit, 5% at 14 weeks, 3% at 24 weeks. 85% of the doctors are very well aware of the cutoffs of 140. 67% of the doctors, they test 14 days after MNT, and 46% were aware of normal fasting and postprandial blood sugar levels. Only 40%, 47% where the facilities were having the anhydrous glucose 75 gram pouches, and 65% advised 2 hours rest after intake of glucose. Only 20% of the clinicians were following these GDM patients after the delivery. So why universal testing was not happening? The question is this: the reasons for not following DIPSI guidelines were unaware of proper procedure and time of conducting the test, inadequate time of counseling, inadequately trained paramedical staff, unavailability of resource material, and waiting time of 2 hours was again a big challenge. And they were mostly following the DIPSI guidelines in high-risk patients. So patients who were high risk, like they had the previous history of diabetes or family history of diabetes or obese or bad obstetric history, they were following DIPSI guidelines only in those patients, that they were not following in all the patients. Majority of them were doing random testing. So post-training assessment, we did the training, we gave them you can see these booklets, we have given this logbook, we have asked these healthcare workers to write 5 cases of GDM, which they are saying, or in patients who are doing, just write the procedure, how they are doing it, what are the cutoff values, and they are writing 5 cases of anemia and 5 cases of GDM. And when we will go for on-site assessment in the first week of April, we will see these logbooks, and we have also given them the IC material and record book to maintain the data. And now we are also doing the mentoring of these healthcare workers. You can see these are the latest pictures which we have taken, because the on-site assessment is in the first week of April. So post-training results, the internal assessments which we have done is 100% awareness now. All 34 centers are following DIPSI guidelines. They have 42 doctors. Sudden spurt in GDM positive patients. They are maintaining the records, but again, the sustainability of this is again a challenge. We really have to look into how we can sustain the record maintenance in these patients, improve counseling, and provide a shift from doctors to healthcare workers. These are some of the comments that I really want to share with the expert faculty sitting here. I had detected 87 GDM positive in 1 month after correctly following DIPSI guidelines. In 25 years of my practice, I could detect 5 to 6 per year. I tried to analyze my lapses after enrolling in this project. The lab did not have adequate seating space, so women were sent home after drinking glucose. Ma'am, these previously undiagnosed GDM were the cause of stillbirth and miscarriages. Thanks to Vistric for now realizing the cause. So it was a huge coverage in the Jharkhand also, and we are trying to scale up this project. Maybe we'll get some more fund from USAID, so we can take more centers from Jharkhand, and I'm also trying to push in the private sector in UP as well. So let us pledge to ensure universal testing for pregnant women using single-step test. Thank you, Dr. Hema, once again for motivating me, for inspiring me to just move on this path. And we definitely will try, as far as I'm there as the chairperson of Safe Motherhood Committee, I will definitely try to do my best for the women of our country. Thank you so much.
Thank you, Preeti. This is what we call walking the talk. It's not just enough for me to inspire, but it is for you to actually do it. And I think this was in itself very insightful, especially because many distinguished speakers through yesterday and today have told of many more things that can be done before and beyond pregnancy. But during pregnancy, when the target women are available to us, even there, even we know, but it's not getting off the ground. This was really, really good. And what I appreciate is that your persistent and consistent efforts from your heart, because you're really worked up that the change should happen, and that is how the change will happen. That is what the confidence that you're instilling, not only in me, but all of us. So thank you, Preeti. Another hero here is Rajesh Jain, who in the most difficult belt, the same belt of Kanpur, UP, where you belong, for quite some time, he had been struggling that the OBGYNs are not in sync with what he's saying. And then suddenly when DIPSI came, and FIGO came, and FOXY came, then he said, now, they are charged up to do more. So Rajeshri, we would like to hear from you.
Sure, madam. Thank you. Thank you very much. Thank you, Hemaji, and the whole team for this wonderful conference, SAIDIP. I think in last time it was in 2018, and I had my presentation at the time also. So thank you very much. I'll just share my screen. I think you can see it now.
Yes, Rajesh, but you have to go on full screen and it's showing 58 slides. So I don't know in 10 minutes how you're going.
Okay.
Come down.
Yeah, just the slide share here, down
come
icon,
down.
next to the notes and comments, and yeah, still more to the right.
Come down.
To the right and down.
Okay.
Just a little bit more to the right. Another one more. Yes, that's it. Please.
Thank you. So we begin with the UP Uttar Pradesh experiences with NHM. And here what we have done. So this is the project we have developed with the National Health Mission in 2012. And first of all, we have taken the pilot project in Kanpur for 57,000 pregnant women with the single test of DIPSI in 24 to 28 week of pregnancy. So after that, in 2016, we took this project for whole of the state, including 36 districts in the beginning. So in the first year, we included 18 districts, which were the divisional district in Uttar Pradesh, where division is there. And after that, we took 18 more districts, and now total 50 districts has been included under the program. So the UP is a big state. You already know 23 crore population with 57 lakhs pregnant women every year. So it's a huge task. But the UP project was a very systematic, and we go with the precognition that we will be covering in the next 4 to 5 years the whole state. And presently in 36 districts, which is covered under maternal health. So this program is totally supported by National Health Mission with the funding from World Diabetes Foundation. So we have trained more than 20,000 A&M at present. So the program is being run in 1836 PHC, CSC, and district hospital. The best part of this program is there that the 70% of the screening is being done by the A&M in a decentralized manner. So every A&M has been given a glucometer, 75 gram of glucose, and the strips, so that she can screen around 200 pregnant women in a 1 year. So rest of the glucometer, 30%, which is spared for CHC, PSC, and district hospital. So till 2019 March, we have covered 1 million screening, by March 2019. And because of the corona after that, the things are going a little bit slow. So what are the points we need when we work with the government, as my experience with the National Polio Surveillance Project and with the WHO, because at the same time in 2004 to 7, I was supporting the government. So I know how the government works or how the health system works in the country. So that experience helped me to implementing of GDM project in the Uttar Pradesh with National Health Mission. So what are the problem we were facing here is basically the retraining of the ANMs every time. Because in polio program, as you remember, that every time we used to have 3 to 4 rounds in a year. So before the round, we used to train ANM or the ASHA workers. So same thing I'm trying to implement here, because GDM looks to be easy, but it's not very easy. And that is why postpartum screening, we have achieved only 10% till now. Insulin is present in district hospital and CHCs, but not in the PHC at the present. And what we are doing presently is trying to screen the pregnant women in the same day and being feed up in the software, what we call the MCTS software of the Government of India. So that is basically a big problem. Feeding is a big problem, but A&M is doing in the field. So for that, Tata Trust has come and Tata Trust has given basically a tab to the A&M. So now 40,000 A&M will be trained for that. Around 20,000 are already been trained. So the same day we will be getting in the software of the GDM screening. So this is the Government of India guidelines, which has been adopted by UP government, and UP government has put its guidelines in the local language, that is Hindi, and it's given to all the centers in Uttar Pradesh. So presently around 50 districts is being covered under the program. So these guidelines are very simple, which has been framed by National Health Mission in consultation with Dr. Sheshaiah, Hema, and the other team of KGMO and others. So this is a simplified budget of the 18 district, which has been approved basically in the beginning. And now 50 district budget is approved by the National Health Mission. So you can see here the number of ANMs and the glucometers. Okay. So every ANM is getting glucometer and logistic from the National Health Mission itself. So now more district is being accumulated. Now 50 district is being covered under the program. Now comes the IEC part, because when you work with the government or National Health Mission or a Ministry of Health, then the IEC is the most important part. Okay, whatever we do in a community in the form of maybe World Diabetes Day or GDM Day is going to simulate our data in the GDM or the screening of NCDs. So this is the same thing which has happened in Uttar Pradesh also. Every year we used to do the Global Diabetes Walk on World Diabetes Day, where we used to cover every block, PHCs of the 75 districts. So we were covering around 850 blocks under these programs. So this is started actually by the World Diabetes Foundation in 2004, but we started in 2012 in UP. Okay, so we used to decide the location of the walk, join the other forces like Rotary, IMA, NCC, NSS, okay, and promote the walk in the local areas. So these walks were registered in the software actually. So these are the government orders which is being passed for all 75 districts in Uttar Pradesh by the MD of the National Health Mission and also NCC and NSS head of the Uttar Pradesh. So we were taking into account NSS student and NCC student of whole Uttar Pradesh. So later on, the Ministry of Health, order also came with NHM letters. So these are letters from CMOs. Okay, so this is the letter again from the Ministry of Health, Uttar Pradesh Sarkar. Okay, this is a letter for whole of the UP to all the schools for the World Diabetes Day. Okay, so 2019, the letter was passed from the Joint Commissioner of Basic Shiksha and Higher Education to all the schools to conduct a walk for the Vishwa Madhumeh Divas. So this is the very important. Then again at the divisional level, the letter was passed. Okay, so I'm talking of whole of the UP. Now comes the part of the media. So what in Uttar Pradesh we did, we collaborated with basically the Amar Ujala Foundation. And we had a MOU with Amar Ujala that this is the activity which we will be giving, and the publicity activity Amar Ujala did in all the paper of the 75 districts and the block level. So we had huge articles. Okay, more than 250 articles were published in the newspapers, block level, district level, state level. So this is a huge activity, and 5 lakh people walked on the World Diabetes Day. So this is basically the Ministry of Health Minister, Mrs. Rita Bahuguna. She inaugurated our GDM program for next 18 districts. Okay, so this is again an article was published on that, managing diabetes during pregnancy. And Dr. Sheshaiah interview was also taken by Dr. Vivian. Mr. Vivian, he's an editor in Economicals Times. So he published a huge article on Uttar Pradesh model. Okay, so he took the statement of Dr. Sheshaiah and many others, okay, and just publish our project, what we are doing. So these are the posters we take from the IDF and translate into the local languages. Okay, banners, you can see. Okay, again, there is a letters from the government. Okay, this is from the NSS. And this is the basically FIGO guidelines we recently translated into Hindi. So you can find it in PHCs, CHCs in the form of posters over there. So this is the training of A&M we have done. This is just example of Varanasi. So in batches of 40, we did the training at the CHC level. So recently we did this GDM Awareness Day, okay, with the KGMU University, Ops and Gynae Department. Okay, Dr. Vinita Das and his colleagues were there. So this is the poster you will find in every subcenter in PSC in UP. So this is one standard poster. Okay, this is a poster you can fix it in the wall. Okay, there is a gum behind it. So there we are just giving it the pratham bar gavastha ke 16 saptah tak, dusri bar 24 se 28 और तीसरी बार, that is postpartum after 6 weeks of the delivery. And my number is also written there. Okay, so I directly get call from PHC, CSCs and people asking me. So I'm just trying to, and this gave me a lot of feedback that what is happening in particular PHC in Uttar Pradesh. So it's very difficult to go to all the places. Okay. So this is the, basically, Dr. Sheshaya has given me this poster. So we have put it in state health department. Okay. So he has concised it in 3 steps. So again, this is a poster, we have made it with the help of Dr. Sheshaya. Okay. This is the Dr. Baswal letter, which went to all the state for GDM Awareness Day. Okay, so officially now the 10th March is the Gestation Diabetes Day on the birthday of Dr. Sheshaya. And definitely in future, might be this will be the global GDM Day. So these are the Hindi translation of the idea posters. So these are the posters we used to stick in every place. You will find it in my vehicle also. So these are the 2 posters we presented in the last IDF in Busan in South Korea. So what was the impact of all these programs into the Uttar Pradesh screening? So 20 times screening has been increased due to the IC activities. Okay. So even the NCD, not only GDM project has helped the NCD people to screen for the type 2 diabetes. Okay, because previously they were doing random blood sugar. Okay, but when we had plenty of 75 gram of the glucose available, now type 2 diabetes is also being diagnosed with 75 gram of glucose. So again, this present data was presented in IDF, okay, of the GDM. I will not go into detail. So this is the 2018 activity we did in the Lucknow. Okay. This is the Green Park activity we did last year in 2019, where 15,000 youths have participated. Because I have seen in the whole GDM, unless we care for our girls, non-married girls and the women, we are not going to, break the cycle of GDM. Okay, because healthy girls are very, very important. So during these hours, during these times, we saw 70 to 80% of participation for the women and the girls. Okay, so we always take care of that the participation of girls students are more than the boys. Okay, so this was a 15,000 enthusiastic youths participated in this activity in the Green Park, where did the yoga, Zumba dance, okay, and various activity in the Green Park, you can see. So just some gym people we took there. So there was this one activity. Okay. So these are the girls from the schools. You'll find a lot of girls here. So that's why relevance to GDM. Yes. So this is the whole Green Park Stadium was allowed first time in the history for the health purpose or for some activity related to diabetes. Now you can see Mr. Sethi here, my colleague. So he's the basically regional sports officer. So we collaborated with Mr. Sethi, and we were able to do this big activity in Green Park Stadium. So this is the rally. Okay, this is the huge crowd you will see in the Green Park Stadium. Okay, so there was a local singer. She was available at the time. So she also came there and gave us concert. So you can see. So you will see the front page of the Amar Ujala. This has this message on the World Diabetes Day. Okay. So this is my last slide, and these are my role models actually. So I think some of them you can recognize. Dr. Sheshaiya, Dr. Hema, Dr. Anil Kapoor. He has helped me in this project for the last almost 7 to 8 years. And here is a Wayne. She's my communication manager in the Denmark, and my project manager, Weldon Carton. So they all are my basically the role model for me to spread this whole GDM program, especially in Uttar Pradesh. Thank you very much.
Thank you, Rajesh. I've always found you to be a very interesting person with a lot of interesting kind of work that you put in. It was indeed, walk through so many activities which you have taken to scale, and I must really appreciate what you've done. And also at the same breath say that Dr. Rishikesh Pai, who is the position of president-elect, is briskly making notes. This is how the Foxy leaders are, within their own brain storming as to how much more they can do with connect and collaborate. Yeah, Rishi, welcome to.
Yeah. Hi. I was wondering, I said, if we have we need about 1,000 people like Dr. Rajesh Jain, dedicated to the cause, and we'll have a change in the country. So when I was listening to him, I was really amazed at his dedication. Even before that, Preeti has also done a great job. And I'm obsessed with the idea how, for example, he has touched 1 million, but we have 1,300 million people. So how do we, because our country is, putting out so many children, even if you say that 26 million people are getting delivered every year, means we are putting out 26 million births or whatever. How are we going to, he is such dedicated, and he has done 1 million, which is a fabulous, what a number it is. But compared to the country, it is, how are we going to, we need a simultaneous connect, and that is what we need to do. We need to have a meeting of all the stakeholders. We need to go to the Himalayas and sit there in Kailash Parbat, and we need to say, okay, you are doing diabetes. There are 10 organizations doing diabetes. Sit here on one side. There are 10 organizations doing blood pressure. Sit there. There are 10 doing anemia, malaria, HIV, tuberculosis. We need an integrated, one day training to all the, God knows how many ASHA workers are there, digital training to everyone, starting from morning till evening. Bus, 5 minutes, 10 minutes on diabetes. Diabetes यानी क्या? ये blood sugar इतना बढ़ता है. This is diabetes. Treatment is this ABCD. Only 5 minutes. Tuberculosis यानी क्या? So that there is an integrated approach. Within one day, we teach all the 1 million ASHA workers by digital. Then we go all out. The army goes out. Simultaneous, 30 states has to take. I can't understand it. I can't understand it in my head why this has not happened for the last 30 years.
It is waiting for, it is waiting for Dr. Rishikesh Pai.
I can't understand it.
Yeah.
Why this has not happened? If I was health minister, I would have 30 years back.
No. Rishikesh, the first thing that you said, we need 1,000 Rajesh Jains and hundreds of Preetis and many of us who are in the championship roles to escalate this, to amplify this. And that is why this connect and collaborate initiatives are really the way
we are going to take, Hema, we are going to steal Dr. Rajesh Jain from you. He has to come to Foxy.
Yes. But thank you. This was very insightful. Last closing comments from Dr. Jayam Kannan, who is also, adolescent committee said she really from Kashmir to Kanyakumari. There was a huge marathon, something similar to what Rajesh ji has done. So we are all having the same kind of thought process in our DNAs. So Jayam.
Yeah.
Oh, this was really a lovely session. A lovely session.
I'm really very happy because I am associated with Dr. Sheshaya for the past 2 decades. I have been seeing how much he has been suffering to bring out his one-step test with all the oppositions, even within the city of Chennai. Even within the city of Chennai. So I really bow before you, Rajesh Jain, for having taken up this work. And I want Rajesh Jain, even in Tamil Nadu, to do this work. Thank you very much for your wonderful work.
He has to go for state, national level, madam, national level.
Yeah.
He has to be appointed for national level.
Yes. Thank you.
Thank you,
Paniswalam, your name is very famous in the on the television.
The ground realities that we are facing in the management of GDM over the country. Now we move on to the next session, which is the artist session, where we talk about new frontiers and fresh thinking on GDM. To chair this this session, we have Dr. Rishikesh Pai as the chairperson, and Dr. Ashma Rana will also be chairing the session. Dr. Madhuri Patil will be talking on optimizing outcomes in PCOS, obesity, and ART. And Dr. Anand Shankar will be talking on the use and misuse of metformin. Dr. Rishikesh Pai is the president-elect for FOXI 2022-2023. He's also the medical director, Bloom IVF Group, and administrator, FOXI Maneta Initiative, Director Corporate Affairs, IFFS International Federation of Fertility Societies. He has major achievements to his credit. Just to enumerate a few, he's been awarded with the esteemed fellowship of RCOG College of Obstetricians and Gynecologists from London, has been the past Secretary General, Senior Vice President, Deputy Secretary General, Treasurer, and Chairman of FOXI. He has also been the past President of ISAR, IAGE, and MOGS. Dr. Ashma Rana is a professor of obstetrician and gynecologist from Kathmandu, Nepal. We are honored to have her with us today. She's also initiated the Diabetes in Pregnancy Certification course in Nepal. She's also the Vice President of the Perinatal Society in Nepal. The first speaker in this session is Dr. Madhuri Patil. She's a member of the International Reproductive Medicine Research Network, clinical director of Dr. Patil's Fertility and Endoscopic Clinic, Bangalore, and she's also the editor-in-chief of the Journal of Human Reproductive Sciences from 2013 to 2020. The next speaker who will be talking on the use and misuse of metformin is Dr. Anand Shankar. He's the founder chapter secretary of Research Society for Study of Diabetes in India, Bihar chapter. He also happens to be the editorial board member for the American Journal of Internal Medicine and joint secretary, Diabetes in Pregnancy. I hand it over to the chairpersons now.
It's a great, first of all, let me thank Hema. She is like my teacher, though she is my classmate, and even Dr. Madhuri Patil is my classmate, but I look at both of them as my teachers because they are more advanced than me, and I keep on learning from them. Just to be a little tangent, today is a very special day. It is the 14th of May, and 3 things have happened this day. One was it's the New Year of the Sikh community. It starts today. The second, it's the National Pie Day, which was done in 1888, and because 3.14, so it is 14th of March, and it is celebrated as National Pie Day. Pi is 22/7, 3.14. But most important of all, today is the birth anniversary of Albert Einstein. He was born in 1879 on 14th of March. And he got the Nobel Prize for photoelectric effect. In 1922, he invented photoelectric effect in 1921. Apparently, he could have got 6 more Nobel Prizes because he was famous not for the photoelectric effect, but for the special and general theory of relativity. And so these are the 3 very special. So today is a very special occasion. And of course, it is today an artist day, and we have got two very good speakers, Dr. Madhuri, who will, she's highly educated and informed, and intelligently she'll give us a focus on PCOS and obesity. And then, of course, we would be looking forward to Dr. Anand Shankar's talk on metformin as well.
And
Ashma
Pi is here on the Pi's Day.
Yeah, and it is, of course, Rishikesh Pi's Day.
Thank you.
Thank you.
Yeah. At the onset, I would like to thank Dr. Hema and the organizers of SAIDIP for inviting me here today to speak on PCOS, obesity, and ART, and how do we optimize the outcomes. So I would basically talk on the relationship between PCOS and obesity and the effect of obesity on the features of PCOS, reproduction, the embryo quality, endometrium, the ART outcome, as well as pregnancy and labor. So we know that obesity has been closely linked with female infertility as well as PCOS, and it is not clear whether obesity causes PCOS or whether PCOS leads to obesity. But both obesity and PCOS share insulin and leptin resistance with increased incidence of metabolic syndrome, and obesity is also regarded as a multifactorial disorder having its origin not only after birth but from the intrauterine life. So what happens in the intrauterine life? Because there are several events and the intrauterine environment which has an influence on the fetus, and this results in an adaptive response in the fetus, and the thrifty phenomenon in the fetus is due to lack of resources. And after birth, what happens is there is difference in the intranatal as well as the postnatal life, and there's a shift from the world of thrifty to the world of plenty, and with an adaptive response in the child with increase in the LEP gene expression, and these elevated levels of leptin and leptin resistance result in increased appetite resulting in obesity, and also an increase in the peripheral insulin resistance which result in PCOS. And why the incidence of PCOS is higher in obese women, or why does obesity increase the expression of symptoms in obese women is shown in the slide. So basically, what does the adipose tissue do? It increases the storage of steroids and androgens, and this is due to peripheral aromatization, which result in raised estrone levels with a negative feedback on the hypothalamus, which decrease the serum FSH levels and selectively increase the LH levels. The truncal obesity results in insulin resistance, and that is what we talk, that is obesity, and this results in low SHBG levels with increased free androgen index, and this results in peripheral aromatization of the androgens with increased estrogen levels, and in the presence of increased leptin, which has action both in the hypothalamus or ovarian tissue, leads to anovulation and PCOS. So we can see that basically PCOS, which is a multi-gene environmental interaction resulting in hormonal changes, and these changes are exacerbated by obesity in a paracrine and endocrine manner via secretion of number of molecules, some of which are markers of inflammation, resulting in increased androgen levels and insulin levels with insulin resistance, which together then have an effect on the ovaries, resulting in increased ovarian follicles and ovulation, and estrogen resulting in menstrual disturbances, and hyperinsulinemia and insulin resistance increases the incidence of metabolic syndrome and cardiovascular risk, whereas androgen results in hirsutism and acne. And all these together have an effect on the psychology of the woman, and basically they have problems with the body image, self-esteem, and also there's an increased incidence of depression and anxiety. The other factor which I would like to bring to everybody's notice is that basically obesity is an inflammatory situation, because adipose tissue as an endocrine organ secretes chemokines and free fatty acids, which are important to the immune cell infiltration and initiation of the inflammatory process. And this initial inflammatory response is an important mediator of obesity, associated systemic inflammation, and increase in the abdominal obesity, which is one of the main points or the main features of PCOS, and this is basically related to the hyperandrogenism, contributes to the inflammatory load in PCOS. Obesity and adipocyte hypertrophy is also associated with insulin resistance and chronic low-grade inflammation, and causes most of the metabolic complications which are seen in PCOS women. Apart from obesity, PCOS is also an inflammatory process because it is represented by elevated concentrations of various variety of inflammatory regulators such as C-reactive protein, TNF-alpha, resistant interleukin 6 and 8, bisfatin, as well as adiponectin. And this diagram clearly gives us that there is an important link between the total and regional fat, insulin resistance, low-grade chronic inflammation, as well as the circulating sex hormones, which result in the manifestation of the various symptoms and signs of PCOS. So let us now look at the effect of obesity on reproduction. So first is we know that there could be menstrual disturbances, and what we see is precocious menarche, irregular cycles, and oligo or amenorrhea. There could be problems with sexual function wherein you can have difficulty of performance, or there could be impairment of desire, arousal, as well as there could be problems with the orgasm. And its basic influence is on fertility, and this is basically related to the hyperinsulinism as well as hypoandrogenism. There is anovulation. There's also exacerbation of the symptoms of PCOS because of obesity, and the incidence of infertility is almost 3 times higher. Obesity can also influence the treatment given to the infertile patients, wherein we have seen that there is poor response to fertility drugs. There's higher dose of gonadotrophins that is required, higher incidence of cancellation of cycles, altered endometrial function, and lower success rate with ART due to altered ovarian responsiveness and oocyte quality and decreased number of oocytes that have been responded, and high levels of estrogen which are seen in association with PCOS as well as obesity because of peripheral conversion of testosterone into estrogens can result in deep venous thrombosis. So we can see over here that there is a complex interaction between the pituitary gland as well as the pancreas and the ovary, which results in changes in the hormonal secretion pattern. And with the increase in the number of fat cells, there is increase in leptin and insulin levels and a preferential increase in the LH but not in the FSH. And then this stimulates a partial development of follicles that secrete supranormal levels of testosterone, and they rarely ovulate, and therefore they have low levels of progesterone. The hypoandrogenemia also impairs the granulosa cell function and the follicular development, leading to infertility. And obesity is associated with hyperleptinemia, which also results in anovulation, not only by induction of insulin resistance, also through a direct impairment of ovarian function. And what is the effect of overweight on the hormonal profile? So we have seen that there is decrease in hormone binding globulin hormone, IGF-BP1, and also response to controlled ovarian secretion. There could be low peak E2 levels and decreased endometrial receptivity and corpus luteal function or early embryo development. And there is high levels of androgen, insulin, leptin, insulin resistance, and also there's an increased risk of early pregnancy loss. So you can clearly see over here that the adipose tissue, because of its energetic disbalance, adipokines, and inflammatory and oxidative stress, in conjunction with environmental stressors, can result in dysregulation of the epigenetic machinery, which then results in various reproductive pathologies. Coming to the effect of obesity on the endometrium, we know that there are elevated circulating serum free fatty acid levels as well as C-reactive protein levels, which result in altered gene expression in the endometrium, which is important to the activation of the immune system and inflammation. And this results in increased production of pro-inflammatory mediators and enhanced immune cell migration, resulting in compromised acidulization and excessive inflammation, which may impair the implantation and also predispose the PCOS women to endometrial cancer. So what are the different mechanisms for this impaired endometrium? One is the hyperestrogenic state, which is due to the high activity of the aromatase system, resulting in increased estrogen production. there is decrease in the sex hormone binding globulin with increased free estrogen delivered to the target tissue. Increased estrogen results in decrease of the inactive metabolites, and there's also an increased incidence of endometrial polyps. And it has been seen that there is an inverse correlation between the BMI and the estrogen and progesterone receptors in the endometrium, the LIF or the leukocyte inhibiting factor in the endometrial glands, and also the leukocyte subpopulation. The other causes include leptin resistance in the peripheral tissue, insulin resistance and hyperinsulinemia, which result in reduced glycodyline in the endometrium, resulting in recurrent pregnancy loss, reduced IgA binding protein, which we know facilitates the embryo endometrial dialogue, and there has also been increased acute phase proteins and pro-inflammatory cytokines which have a negative effect on the endometrium and early embryonic development. There is also an effect of obesity seen on the ovarian follicles, where the lipotoxicity may occur in the ovarian follicles with increased C-reactive protein and TNF-alpha in the ovarian follicular fluid, which results in lipid accumulation both in the cumulus cells as well as the oocytes, and this then results in activation of the endoplasmic reticulum stress pathways. There is mitochondrial dysfunction and increased apoptosis in the cells of the developing ovarian follicle, resulting in poor quality oocytes and also an ovulation. And if you look at the effect of obesity on embryo and oocyte quality, most of the reports are very controversial. Some reports have said that there is impaired embryo quality only if the BMI is more than 30, whereas others say that there could be impaired embryo quality and as well as oocyte quality in the presence of overweight and obese women. There could be fewer normally fertilized oocytes, and basically there has been no relation seen between elevated BMI and increased risk of aneuploidy in one of the papers which was published in Fertility Sterility in 2016. But there are several papers which have said that there is no effect of increased BMI. But the ones which say that there is an effect, basically the mechanism includes high dose of gonadotropins that have been used because of increased resistance to the drugs for ovulation induction, which then impair the embryo quality, result in abnormal embryonic development, reduce the invasional capacity of the blastocyst, induce defects in the embryos and oocytes, and also induce chromosomal defects in the oocytes. And an inverse correlation between the BMI and the intrafollicular HCG concentrations have resulted in low concentration, in those low concentrations of several factors which affect the embryo quality, and this is significant in women who are obese. But one must also remember that we cannot say that the effect seen on the oocytes and embryos is totally related to obesity, because PCOS is also one of the compounding factors which can impair the oocyte maturation, the oocyte quality and fertilization rates, obesity probably may contribute further to the impairment of the oocyte quality and maturation. And it has also been seen that in PCOS women, the number of mature oocytes is less, and the number of oocytes obtained fertilized are also lesser in obese women who are PCOS as compared to those obese women who are non-PCOS. Again, when we look at the effects of BMI and ART outcome, again, we have a totally controversial publications. But one must remember that the cutoff levels for the BMI in Asian Indians is totally different from the international levels. And the normal levels are basically 18 to 22.9 as against 18 to 24.9. And we consider any woman who is between 23 to 24.9 as overweight and more than 25 as obese. And the thin Asians basically have more fat, they have less muscle, and therefore we say that they're sarcopenic with abdominal obesity, and this probably is related to genetics as well as environmental factors. And if you look at this paper, which was published in 2008, it has been seen that the BMI, which is more than 29, is associated with a reduced success of ongoing pregnancy, and there was also a 4% lower pregnancy rate per kg square meter of BMI increase. Then there was another paper which was, there were 3 papers which looked at the looked at the ART outcome, and they said that there was a trend towards a poorer outcome with rising BMI, as the live birth rate was reduced by 9% in overweight and almost 20% in obese women. And but this one paper, which was published in 2017, said that the BMI does not influence the outcome of ART. Then this was a paper by Provas et al. In 2016, which included almost 293,000 patients from 2008 to 10. And what he concluded was that the success rate and odds ratio for all pregnancy outcomes were that they were most favorable with low and normal BMI, progressively worsened with increased BMI, and obesity also added a negative impact on the IVF outcomes and did not reach a statistical significance. And he advocated more research to determine the cause and the extent of influence of BMI on the IVF success rate. Then this was another paper by Kuo et al. In 2016, which was a retrospective analysis of women who were less than 35 years, where he included 1,800 non-PCOS and 400 PCOS cycles, and concluded that there was a significant decline in the number of oocytes retrieved, the number of oocytes fertilized, and the number of transferable embryos with increasing BMI in women with PCOS. There was no difference in the cleavage rate, and in PCOS women, there was decrease in the pregnancy rates and increase in the risk of miscarriage. Then there was another paper published in 2017 in Human Reproduction, and basically it was a prospective RCT, and it was done in 9 centers of Nordic countries, and they concluded that there was a significantly higher number of spontaneous conception that occurred in weight loss group, and which was statistically significant with a p-value of 0.001. And the weight loss in obese women prior to IVF, they said, may not improve the outcome in IVF pregnancies. So what they concluded is that basically weight loss improves in spontaneous conceptions, but may not really have an effect on the IVF pregnancies. And there was another paper by Legro et al. In 2017, where he said that probably the p-value was not statistically significant for lifestyle versus very comparable standard care. And he says that there was, though it might be beneficial, he said there are several questions that remain to be answered. Which patients need to be intervened, how best to intervene, and the degree of weight loss and period stability. Because if a woman comes to us who's more than 35 or 36 years, we know that her ovarian reserve is less and her oocyte quality is also compromised. So whether we should wait for 6 months before she goes for an ART or we should take her up immediately. And most of the papers published say that it's best not to wait because we really have controversial evidence on lifestyle modification when we talk about ART pregnancies. And when we look at the effect of obesity on pregnancy and labor, in pregnancy, basically early pregnancy, there could be increased fetal anomalies, increased risk of miscarriage, and we know that there could be difficulty in ultrasound examination. And in late pregnancy, we know that we have already heard so many speakers speak yesterday and today that there could be increased incidence of PIH and GDM. Also, it has been noted that there is increased incidence of preterm delivery, and many a times there could be difficulty in induction of labor. During labor in the intrapartum period, there could be failure to progress, failure to have a VBAC, there could be shoulder dystocia, increased incidence of cesarean section, operative and anesthetic problems. And in the postpartum period, there is a higher risk of hemorrhage, infections, deep vein thrombosis, and basically it has also been seen that there is decreased contraceptive efficacy. And in the fetus, there could be increased incidence of both macrosomia as well as small for gestational age babies, increased risk of birth injuries, perinatal morbidity, which is 1.5 times higher. There could be early neonatal death and also perinatal mortality. So the take-home message is that PCOS and obesity is associated with increased androgen activity, ovulatory dysfunction, infertility, oocyte and decreased oocyte and embryo quality and ART success, increased insulin resistance, worsened psychological function, and also worsen cardiovascular as well as diabetes mellitus risk factors, which then results in reduced ART practice. And if you look at the effect of weight loss, it is really important in patients who have insulin resistance, and there is a very good evidence. When we talk about risk of diabetes and cardiovascular factors, for diabetes is no data, and for cardiovascular even the evidence is very low quality. When we talk about androgens, there is almost a decrease in the testosterone levels by 36%. There's increase in the sex hormone binding globulin and decrease in the symptoms of androgen excess like acne and hirsutism. There is improvement in the menstrual cycle regularity, and there could be a decrease in the LH levels, but again, this is not proven. And basically, they have seen that there's no change in the pulsatility of GnRH, which is again very important. And this then influences the pulsatility of LH levels. And we are not sure whether it improves the ovulation, fertility rate, as well as pregnancy. So the key messages for my talk is that excess body weight is associated with extended time to pregnancy. The weight loss increases spontaneous pregnancy rates in anovulatory PCOS, but the outcome of ART with weight loss prior to ART in PCOS has not yet been fully demonstrated. The implantation rate, the clinical pregnancy rate, and the live birth rate progressively worsens with increased BMI, and pregnancy rate is significantly lower in obese PCOS who are more than 35 years of age. And it has also been seen that clinical pregnancy rates are lower with high and the miscarriage rates are higher in obese PCOS as compared to obese non-PCOS patients. And therefore, when a woman is obese and is associated with PCOS, basically, we need to counsel these patients much more because they are at a global threat as compared to the other diseases. And it is a great challenge to the clinician to counsel them and to help them decrease their weight. And basically, it could be avoided by lifestyle modification, which includes eating healthy food and avoiding junk food, including physical activity in a daily routine, which is almost 5 times a week for at least 30 minutes a day. We need to sleep, advise them to sleep adequately and at a proper schedule, and also de-addiction. And I thank you all for a patient hearing.
Dr. Ashma, would you like to comment?
I don't see myself. Hello?
We can see you, madam. We can hear you.
Okay, I can't see myself there. Yeah, it's a very good talk, Madhuri. Thank you for enlightening what the role of, obesity and the PCOS. And we have Rishikesh Pai is a very good infertility person, and I think you'll make a better comment than me.
No. Dr. Madhuri has given an excellent
Pai,
view on. She has given an excellent view on the PCOS and its correlation to obesity. And we all know that, by common sense, we know that if the patient loses weight, there's going to be an increase in pregnancy outcomes, live birth rates, etc. So I think that, I have also heard that, if you tell the patient and counsel them that you should lose the weight over a long period of time, rather than telling them to lose weight in 1 month or 2 months, I think basically there should be a lifestyle change in the whole attitude towards life. The diet, exercise, it applies to every part of our life. We have to reduce our weight. Weight is the biggest problem which we all face. And as we age and become older and older, it becomes more difficult to lose the weight. Thank you, Madhuri, for an excellent talk on PCOS and obesity. Thank you.
Thank you.
Can we have the next speaker now?
Yeah. Anand.
Dr. Anand.
Yeah, good evening, everybody, sir. Respected chairperson and respected Hema ma'am, respected Sheshia sir, and namaste to all. Let me share my screen. Can you see my screen?
Yes, sir. Yes, Anand.
Yeah, ma'am. Thank you, ma'am. Thank you for giving this opportunity. Ma'am, you have given me the topic use and misuse of metformin. So it's a huge topic to the story to be told. Metformin itself a textbook like topic. So I just go through a few important aspects of the metformin because use and misuse of metformin in 15 minutes is going to be very harsh. So these are my disclosures. And we'll start with the metformin. What are the mechanism of action of metformin? The major proposed mechanism of action of metformin, although this is not 100% proven, but it reduced the hepatic glucose output, increased fatty acid oxidation, increased the interest in glucose extraction, improve peripheral insulin sensitivity, decrease gut carbohydrate absorption, and enhance the release of GLP-1 and other gut peptides, which enhances the absorption and utilization of the glucose at periphery. So these are the basic mechanism of the metformin. And you can see it is a multifaceted, multitasker metformin. So it's like women. Women are multitaskers, not like us that we only task one thing at a time. Now you see the recommendations by all the major guidelines around the globe, and all the major guidelines says that metformin is the first line of therapy for type 2 diabetes. Is starting from ADA, ESD consensus, Australian, Canadian, European expert group, Ministry of Health from Chile, IDF, IMSN, then Malaysian, Spanish, Venezuela, Brazil. You can see any of the guideline, even the WHO says that metformin is the first line of therapy. ADA 2020 says, you can see that the first line of therapy is the metformin. So what we're saying that metformin is the stay of the starting of the treatment of type 2 diabetes. Even the AAC 2019 guideline, metformin is the first line of therapy. And coming to our country, this is the RSSDI therapeutic wheel. This also shows the first line of therapy for type 2 diabetes is metformin. And in 2019, EC guideline also says that the diabetes, pre-diabetes, and cardiovascular disease developing in collaboration of the ESD, metformin should be considered in the overweight patient with type 2 diabetes with or without cardiovascular or moderate cardiovascular risk. So metformin is the core starting point of therapy in type 2 diabetes. Coming to the pre-diabetes, in pre-diabetes also, metformin has been used to prevent or at least delay the onset of diabetes in patients considered to be high risk of diabetes. And these are the from the ADA Standard Care 2020, which shows, and this is the Diabetes Community Lifestyle Improvement Program and the Indian Diabetes Prevention Program. Both has shows that the metformin significantly reduced the incidence of diabetes as per the Indian Diabetes Prevention Trial by the ID-SCLIP by 32% and IDIP-1 by the 28%. So metformin is one agent which has not only the first line of therapy, but also delay of onset or preponed delay or starting of type 2 diabetes. In the prevention of or delay of type 2 diabetes, ADA 2020 has said metformin therapy is for prevention for type 2 diabetes should be considered in those with the pre-diabetes, especially those with the BMI of more than 35, age 60 plus, women with prior gestational diabetes history, and these all are high risk to develop diabetes, so they should put on metformin to delay of starting of type 2 diabetes. Now coming to long-term effect of metformin, we know that we start giving metformin to all our diabetic patients, but what are the long-term effects? There are reports shows that metformin could cause vitamin B2 deficiency by reducing the vitamin B2 absorption in the GI tract. It has been reported to average 6 to 30% of the patient could show vitamin B2 deficiency due to the metformin use. In addition, some study has reported the serum vitamin B12 level are inversely related to the duration and dose of metformin use. In 2020 ADA standard care, the long-term use of the metformin may be associated with the biochemical B12 deficiency, and periodic measurement of vitamin B12 is recommended should be considered in metformin-treated patients, especially in those with anemia or peripheral neuropathy. So any patient coming with any sign or symptoms of the peripheral neuropathy or having clinical anemia, a patient is feeling not very well or lethargic, they should be investigated for B12 deficiency. Meanwhile, the vitamin B12 may be unreliable marker for overall vitamin B12 deficiency because of variability of the measurement methods. Maybe a study have investigated the homocysteine increase in the vitamin patient taking metformin, but it's still very controversial to conclude on these studies. Now, coming to the metformin in pregnancy, we know that metformin category in pregnancy is B, and it shared this category along with the insulin. So metformin and insulin is category B drug in pregnancy. We have to keep this in mind. The glyburide, which is we called glibenclamide in India, is category C drug. Acarbose, that is the alpha glucoside inhibitor, is category B drug, but it is not indicated or approved to be used in pregnancy. So I just highlighting those categories which are there here in to be used in pregnancy. So metformin is category B drug. Now, what is the ACGOG recommendation? ACOG recommends that insulin is the preferred therapy if glycemic control is not obtained on non-pharmacological treatment. If patient cannot take insulin or declines to take insulin due to some reason, metformin can be used. So in pregnancy, ACOG says that metformin is the first line of therapy, and glyburide should not be used in place of metformin. So glyburide is not a substitute. It should not be used because of its a category C drug. And second thing, if somebody want to use metformin, he has to or she has to give a declaration of decline using metformin of the reason. In the NICE guideline, which is updated last year, 16th December, also shows that the woman with gestational diabetes or hyperglycemia in pregnancy, metformin is off-label use. And even the woman with the gestational diabetes who have a fasting glucose 6 to 6.9 millimole per liter, with have a macrosomia or hydromnias and want to start on diet and exercise and not want going for insulin, again, if they are going to give metformin, it is off label. So again, these two big guidelines which set up that metformin can be used, but it is not the first choice of therapy. What is our situation? This is the review article, and I'm happy to have Dr. Rakesh Jain today's meeting. He has written this article, review of the FIOG with ADA, WHO, IDPHG guideline of GDM with the low resource setting and integration of DIPSI with the Ministry of Health and Family Welfare, Government of India guideline. And this is compiled all these things, all these guidelines, and what shows insulin is the first drug of choice, and metformin can be considered after 20 weeks of gestation of medical management of gestational diabetes mellitus. So first is first, if somebody diagnosed to be hyperglycemia in pregnancy or GDM, she should be on medical nutrition therapy for 2 weeks. If sugar target is not achieved, that is a postprandial not achieved less than 120, then less than 20 weeks pregnancy, she should be on insulin. More than 20 weeks of gestation, metformin can be started. Now, we have to see the evidence. If we started metformin, what will happen afterwards? So these are the metformin gestational diabetes, the offspring follow-up, that the MIG-TOFU study, body composition of metabolic outcome at the 7 to 9 years. And these are the silent feature. I'm not going detail of the whole study. Everybody knows about that. Metformin is safe and effective treatment for women with gestational diabetes with respect to the pregnancy outcome. 2 years old offspring of the woman with gestational diabetes randomized to metformin and insulin treatment during pregnancy has similar body fat percentage. So there was no difference between the insulin and the metformin cohort, and they have found to be safe as the insulin is there. Long back in 1994, also the congenital malformation in offspring of diabetes women treated with the oral hypoglycemic agent, which was the metformin in 7 patients, and they also found to be safe when they are used in the first trimester. And a study found no major congenital malformation in infant with the diabetes women treated with the metformin at time of conception and during the first 8 weeks of pregnancy. No obvious indication of therapeutic abortion in patients who have taken metformin due to embryogenesis. So metformin sounds to be non-teratogenic. Again, 2006 pregnancy outcome of the first trimester exposure to the metformin, and this meta-analysis was done. And what they have found that metformin treatment is the first trimester was associated with the statistically significant 57% protective effect. On the basis of the data of this analysis, there is no evidence of an increased risk of major malformation when metformin is taken during the first trimester of pregnancy. And this published in 2004, and this was the changing of use of the metformin. Again, the first trimester exposure of the metformin was not associated with increased risk of any malformation, and they are compilation of the meta-analysis of all group, and they have found to be metformin safety. The whole study tilted towards the metformin, and this found to be no malformation or any congenital defect in the metformin users who have been treated for the metformin in GTM. In 2018, the metformin exposure in the first trimester in pregnancy and risk of all and or specific congenital anomaly exploratory and case control study was done. And this large international population-based database was found, and there's no evidence was found on overall increase of the congenital anomaly at the first trimester metformin exposure. So now we know that we use the guideline says we can use metformin after 20 weeks of gestation, but there are evidence that within the first week of the first trimester, we can start metformin without any complication. And this is a pregnancy outcome among the women, the polycystic ovarian syndrome treated with the metformin. And this is very important. On metformin, the 40 women had 46 pregnancy, 47 fetus, 1 twin pregnancy, 6 women with 2 single twin pregnancy, 33 women with 1 single pregnancy, and metformin reduced first trimester abortion from 62 to 26 weeks, is 26%. So metformin shows to be a good and protective in nature, and these are the patients who have been treated for by the metformin for PCOS. Now this is ADA statement of 2017, and this says that the metformin may be associated with the low risk of neonatal hypoglycemia and less maternal weight gain than the insulin. However, the metformin may be slightly increase the risk of prematurity. Umbilical cord level of metformin are higher than the simultaneous maternal level, and in 2020, same thing was again repeated. Metformin as compared to the insulin was associated with the low risk of neonatal hypoglycemia and less maternal weight gain. First time they have observed this also. Metformin readily crosses the placenta, resulting in the umbilical cord level of metformin is as higher or higher than the simultaneous maternal level. But this is a bidirectional. This is both from the matters to fetus and fetus to maternal, both sides the metformin crosses. The recent meta-analysis concluded that the metformin exposure resulted in smaller neonates and accelerated postnatal growth, resulting in higher BMI in the childhood. So probably this is the thirsty child is getting plenty of food out when they are born, and then they're getting increase the BMI. There was a randomized double-blind controlled trial comprising metformin with other therapy of ovulation induction in the women with the polycystic ovarian disease have not demonstrated benefit of preventing a spontaneous abortion or GTM, and there is no evidence-based need to continue metformin in such patient. These are the PCOD patient treated with metformin and now going for pregnancy. The metformin in GDM, according to 2020, and they are very specific, said there is some women with GDM requires medical therapy who, due to cost, language barrier, comprehension, cultural influence, may not be able to use insulin safely or effectively in pregnancy. Oral agent may be an alternative in these women after a discussion of the known risk and need to more long-term safety data in offspring. So if they want to use, they have to counsel the patient about all these parameters. However, due to the potential of growth restriction or acidosis in setting with the placental insufficiency, metformin should not be used in women with the hypertension, preeclampsia, or risk of intrauterine growth retardation. And these are the Pregment 2 study, and this is the quoted within that ADA also, and published in 2019 in the Lancet Diabetes and Endocrine. And they have interpreted that in pregnant women with PCOS, metformin treated from the late first trimester until delivery might reduce the risk of late miscarriage and preterm birth, but does not prevent gestational diabetes. So this is very clear that they are benefit, but they are not any benefit in development of gestation or prevention of gestational diabetes. Now, use of metformin in polycystic ovarian syndrome. It use metformin may be proven beneficial in subset of population of women with PCOS. Hyperinsulinemia is an important parameter in decline whether or not to initiate metformin therapy in women with PCOS with the hope to preventing or delaying the onset of type 2 diabetes. Cardiovascular risk factor, including the markers of the subclinical inflammation and dyslipidemia, may be improved by the metformin therapy. So these are the beneficial part of the metformin which is using in the PCODs. For ovulation induction, metformin is not as effective as the clomiphene, and these OBS and gynae people know better than us, as a first-line therapy for women with the PCOS. And there is no clear-cut data to suggest that metformin reduce pregnancy loss or improve pregnancy outcome in PCOS. It is currently recommended that metformin to be discontinued with the first positive pregnancy test result. So they use it, not an issue. They are getting benefit, but if they conceive, we have to stop metformin and start insulin if they require. Now coming to the misuse of metformin. Again, there's an off-label use of in the PCOS, unlicensed use, and this paper is 2012 by the British Journal of Clinical Pharmacology is there. Metformin in children and Aldosent in UK. They are prescribing metformin to increase between 2000 to 2000, and in particularly among the girl aged 16 to 18 years. The main indication of metformin prescribing are the PCOS. At present, metformin is not licensed for PCOS and obesity treatment in adult or children. So we have to restrict ourselves for all those conditions. Misuse of metformin in weight loss. And this is the behavioral changes. And eating it is from the International Center of Eat Disorder in 2019, and they found that metformin abuse in the patient with the eating disorders as a pursuing behavior is a rarely reported but a very dangerous entity. Clinicians treating eating disorders should be increasingly aware of the potential abuse of the prescription of medication unapproved for the weight loss. It is not yet approved for the weight loss, so we must not misuse this agent as off-label use. Again, we have very cautious about when you're using metformin in the renal patients. In renal disease patient, we should not use. I'm not going in detail of that. Of course, a misuse of metformin in hepatic patients, metformin should be avoided in severe hepatic impairment patient, and especially when we are talking about the pregnancy, sometimes during pregnancy also hepatic enzyme increases. So in those conditions, we have to stop metformin if somebody is taking metformin and switch over to the insulin. These are the list where we should not use metformin, and I think everybody knows this. I'm not going in detail of that. There are a few darker side of the wonder drug metformin. There are some reports, the suicide commitment with the metformin were there, and there was a case report published. Patient taken 60 grams of metformin to attempt suicide. Patient was sugar level was 707 mg per dl, and then he has a metformin toxicity. A treatment was induced with a sodium bicarbonate infusion, hemodialysis. If the patient has a lactic acidosis, renal deficiency, electrolyte imbalance. So these are the darker side of the wonder drug. There's another dark side of the wonder drug, metformin used in the high altitude for the performance increase, because metformin has been introduced to be may have ergogenic properties at high altitude by improving the muscle glycogen replication. And this is the misuse of metformin by the healthy people. And there are few papers are there. I'm just quoting two of them. So use the drug as per the label. Metformin is and remain the first line oral therapy for treatment of type 2 diabetes according to the national and international guideline. There's an impressive safety record of the drug showing that it has a clinical use of more than 50 years now, and still we are counting on that. There are lactic acidosis, and very rare, and their reported incidence of lactic acidosis in patients receiving metformin is very low, 0.03 per 1,000 case per year, and approximately 0.015 fatal case per 1,000 per year. So it's just negligible, and I have not seen in Chennai when I was working with Sheshia sir, and in Patna when I'm practicing, any patient with a lactic acidosis. The current label strongly recommend against the use of metformin in patient whose kidney does not work normally. So these are the ADA label recommendation. So what we have, the SAIDIP 2001 conclusion, medical nutrition therapy is the main history of treatment of hyperglycemia in pregnancy or GDM. Insulin is the first line of choice of therapy. Metformin and insulin therapy is accepted medical management in pregnant women, metformin with the GDM and uncontrolled with the medical nutrition therapy. If blood glucose post-pregnant failed to reach the target that is less than 120, metformin can be initiated after 20 weeks of the pregnancy. The dose of metformin is 500 milligrams twice daily, orally up to 2 grams per day. The use of metformin proven beneficial in PCOS. Current recommendation that metformin be discontinued with the first positive pregnancy test report. Thank you so very much, Hema ma'am and Sheshia sir, Balaji sir, Sunil Gupta sir, and Anil Kapoor sir for giving this opportunity. Thank you, SAIDIP. Thank you, ma'am.
Excellent talk. I think Dr. Ashma, would you like to comment on the talk?
Hello.
Yes, Ashma.
Yeah, it's so nice. You have really put up all these uses and misuses of metformin. It's a wonder drug. Of course, I think almost like a misoprostol, in abortions and other thing. Same way in GDM and also upcoming thoughts. And for pregnancy and all, metformin is a wonder drug for us, isn't it, Hema? And you have nicely elaborated everything. Thank you so much.
Thank you, ma'am.
Yeah, I actually put this topic, Rishikesh and Asma and Anandji, that every time the same questions are asked about metformin. Will the OBGYNs like to continue when they're using it for PCO? Will they continue till first trimester? Will they want to continue throughout the pregnancy because then the GDM may not happen? In fact, Rishikesh and Nandita had produced a paper on that as well. And then, why to stop at 12 and then restart at 20 weeks because the guidelines say so? Are there really lots and lots of side effects of metformin in the long term, as AD has said? And then like the diabetologists always say, don't touch metformin. Better to go for insulin for a tighter control. And we as OBGYNs don't agree because millions of women on insulin we don't want. We would rather give metformin and maintain our targets with the MLD. So this is a whole basket of questions. I want Dr. Rishikesh to respond to this. What do you do in your practice with respect
I think, Hema, what I think we need to ask this first to Madhuri, because Madhuri is where the metformin starts in PCOS patients. So how would she take them, and after they conceive, how would she take them further and give them over to Dr. Anand Shankar so that he manages them in pregnancy when actually the GDM sets in? So I feel that maybe Madhuri can throw a light on the early part, and then maybe he can talk about the latter part.
Yeah, basically, earlier what happened was the various evidences according to the Cochrane said that probably only a long-term use may be helpful. And then the second Cochrane review in 2014 said it's helpful in reducing the OHSs. But the most recent review which has come, which has analyzed, I think there were more than 17 RCTs which were conducted, and what they concluded that metformin basically does increase the pregnancy rate only when gonadotrophins have been given. So it's important to know that whenever, even if you're doing an IUI, that is a non-ERT cycle or an ERT cycle, use of metformin along with gonadotrophins increases the pregnancy rate. And there were several papers now which looked at the combination of clomiphene citrate with metformin, and they also looked at letrozole with metformin. And today, clomiphene citrate is no longer the first line of treatment in PCOS. It is letrozole which is the first line treatment in PCOS, and more number of papers have been published wherein they've used combination of CC with metformin, and they've said that it definitely improves the pregnancy rate. There are about 4 papers which have also looked at using letrozole with metformin, and these papers also have shown that addition of metformin to letrozole improves the success of ovulation induction, because there are a few patients who are resistant to letrozole also, but when you add metformin, they have definitely improved the ovulation rate as well as the pregnancy rate. So today, basically, letrozole is the first drug of choice, and addition of metformin to letrozole has improved the pregnancy rate. And especially, that was a most recent paper which was published in 2018 in BMJ. And the Cochrane review says that adding it to gonadotrophins improves the pregnancy rates. And the 2018 international guidelines have said that basically there's no harm in continuing metformin, and it is the clinician's decision whether they want to continue or discontinue. And they have given almost about 7 references when they have given this recommendation in the international guidelines, which were published in 2018, which was headed by Helena Ted, and it was published in Fertility, Sterility, and it was also published in Human Reproduction.
So I wanted to ask a question to both of you, that like a lot of papers are there on myoinositol and D-chiroinositol, because one of the big problems of metformin is GI disturbance. So in your diabetic region, means in our non-diabetic PCOS group, there's a lot of buzz on replacing metformin with myoinositol, D-chiroinositol combination. So is there also in your diabetic area this combination? Is it being tried out or used by any chance?
I'll just answer the infertility part of it. So most of the studies which were done in infertility, and there were most of them were from Italy, and basically the sample size was very, very small. It either included 18 patients, 20 patients, and the maximum patients I think included were 26. And they were not randomized controlled trials. They were just patients who were given insulin. There were no controls. And according to the most recent, recent evidence, that is, which comes from the control ovarian stimulation in IVF from the ESHRE in 2019, as well as from the international guidelines which were published in 2018. They said that it is still experimental and should be used only in research settings until we definitely have an evidence when we compare it with the controls. As Dr. Hema yesterday, rightly, when she presented her data on using inositols in GDM, in pregnant patients, and what she said was that the number of, and they had also added vitamin D. So basically it was not sure whether it was the myoinositols which decreased the incidence of GDM or it was vitamin D, because the number of patients who developed GDM was almost similar in both the groups. That's what Dr. Hema said. So I think till we really have RCTs in our hand, I don't think we should shift over to myoinositol, and basically we can probably tell them to eat more of the food articles which contain inositols. And we know that myoinositol, which is available in the market, is too expensive, and we are adding a lot of expense to our patients who are taking treatment for infertility. And we know that the cost of infertility treatment is also high, and at least I do not prefer adding an additional cost by using myoinositols.
Coming to the GI intolerance with the metformin, I think Dr. Sunil Gupta sir is here and Dr. Paris Sarvam sir is also here. Metformin does causes some GI disturbance, but not to that extent of stopping a metformin.
Yes.
Just change plain metformin immediate release to sustained release metformin, or change the tablet, or which is the capsule binders, like the capsule which carries. Just change the brand. The metformin very compliant with the GI. Other thing is there, if somebody is very GI upset with the metformin, give metformin after the food. That also increase the acceptability. Give the some food and then give metformin, and that will increase gradually. If somebody is not able to tolerate 500 milligram, start with the 250 milligram and gradually increase the dose to 500, 850 and 1 gram. That is the highest dose to be given twice daily. So I think Dr. Sunil Gupta and Paneer Sarvasam, your comment on that, sir.
Yeah. As per Anand Shankar, yes, you have done well, Anand Shankar. I'm happy that you have covered all aspects of metformin.
Thank you, sir. Thank you, sir.
As you have pointed out, this gastric intolerance is quite rare, sir. But as he pointed out, sustained release is good. Even the smaller dose is good, if at all indicated. But the gastric disturbance, like our lactic acidosis, is very rare complication of our side effect of metformin.
I agree with this. The lactic acidosis, I don't think any one of us have seen metformin-related lactic acidosis. It might be there in some of the ICU settings when someone is in the critical stage and in hypoxic, some other. When it comes to pregnancy, I don't foresee big issue. The only thing is metformin intolerance is there, and we can't ignore it. And our obstetrician colleagues should know that it can cause GI disturbances. It can cause sometimes very bad diarrheas, and that need to be known. Otherwise, people may go on taking medicine for diarrhea, and it could be because of metformin-related intolerance. And the only thing is that if such thing happens, you can start gradually, and then maybe you can stick to 500 milligram twice a day sustained release, rather than going for 1 gram BD, because it can increase the risk of having such side effects. And I feel everything is already very well covered, but what Hema madam wanted to emphasize on the 12 weeks, after 12 weeks of metformin therapy, when you use it in PC or infertility, in that situation, we should certainly withdraw it. There is no proved role of continuation of metformin after 12 weeks of pregnancy. It will not prevent GDM, neither it will prevent missed abortions, or if there's some data on preeclampsia, it will not do that. And that is why we should not be using metformin after that. We have, I feel Shankar has covered everything very, very well. But certainly metformin, it is not that diabetologist doesn't want to give metformin and gynecologists want to give metformin. It's not exactly so. Even we give metformin, but we usually explain, because you have a documentation. Your ADA recommendation is very strict in 2021. It says that the first choice, drug of choice, is insulin. In less resourceful situations, if the patient doesn't want it, if patient you have some compromised state with the patient, then those situations you can certainly put a note there, write it down that patient doesn't want to take insulin, and then you can give for blood glucose for gestational diabetes. But still, in our country, metformin is being used, and we will continue using it. The long-term data is not very much in favor, because more and more negative papers are coming, more and more meta-analysis are coming on negative aspect, even from PCO group, even from MIG tofu group, where they have used insulin versus metformin in MIG trial. So now MIG tofu trial, the offspring of diabetic mother, after till 7 years, everything was good. And then 7 to 10 years data is again not in favor. At least the adult cohort has not come very good. So we have to be cautious, and we should know that this is a drug which is crossing placenta. Insulin doesn't cross the placenta. That thing should be kept in our mind. The drug which crosses the placenta, the long-term safety of it should be known. But certainly it's one of the beloved drug for all of us. And we, for the convenience of the patient, we can certainly use it. But when it comes to academics, insulin remains the drug of choice. Anand, hopefully you will agree with this.
Absolutely, sir. Absolutely, sir. Thank you, sir.
Thank you so much.
Not only it passes the placenta, in lactating women, it also comes in very
milk.
small
It is
milk,
yes.
milk also. So if a baby is consuming metformin without having any disease, We don't have any long-term safety data of that. That's why we are just documenting. We are not saying that we should not use it. Use it. With documentation, we have to use it. That's the point.
Yes, and there are some special situations which I feel are also mentioned in the literature, that if someone has placental insufficiency, someone has a preeclampsia, someone has a IUGR, in those situations, metformin should not be the drug of choice.
I have mentioned all these things in my presentation and slide also.
Sir, I wanted to ask one question, because many doctor colleagues of mine, I know that they use it as a lifestyle thing, to maintain weight and all. So you had already put a light on it that it should not be used. But the prevalence is quite a lot in society, especially in educated class and all. So what is your take on that?
Actually, sir, we are a society of users of off-label medication. We are using all medications off-label without prescription. So we cannot help them. And sir, 2 days back, I have seen 3 sulfonylurea on the single prescription. Again, it's off-label. What we do? We cannot help.
Rishikesh.
It's anything which is off-label, that is off level.
Yeah, Dr. Rishikesh.
Dr. Gupta.
There's only one glucose lowering drug which is approved by drug authority in obesity. That is only liraglutide. No other drug in the world. Okay. One. If metformin comes for the use of prevention of diabetes, it will come for the GDM cohort first. Because DPP trial, diabetes prevention program trial, have got metformin has given better benefit even than that of the lifestyle modification in GDM group, GDM subgroup. So if it comes for prevention or lifestyle,
metformin was non-inferior to lifestyle modification.
Sir, in GDM subgroup, I am telling you.
GDM subgroup also. 50,
it is almost 54%.
35 or 38%.
No, sir, it is 54% in general.
Something, yeah.
Yes,
if I correctly remember.
Yeah, for DPP, metformin was second in the overall cohort, but for GDM subgroup.
So what is GDM subgroup? Can you throw a light? Because a lot of listeners are listening. They may not know.
Okay, so diabetes prevention program is a primary prevention of pre-diabetes to conversion of pre-diabetes to diabetics. So they have done lifestyle modification versus metformin. And they had GDM women with past history of GDM as also one of the cohort as a participant for primary prevention of diabetes in future. So the lifestyle modification has the upper hand in the overall cohort. Overall, this total around 1700, something like this. So they had 54% people could prevent diabetes from development from pre-diabetes to diabetes. 54% prevention in overall group. Metformin could reduce up to 37 or 34%, what Dr. Rajiv Chawla says, and it was actually second. It was not 54%. Lifestyle modification is the upper hand, but they had cohort. The subgroup analysis has shown those women who had past history of GDM did much better with versus other towards prevention, and they could also prevent up to 54%. And now they have got
Thank you,
DPP
Dr. Gupta. I think this calls for another conference on controversies.
Even that trial again has shown that it is almost equal to that of lifestyle modification in prevention. Of course, the risk is now 54%.
Yes. Thank you very much, Dr. Gupta. Thank you, Dr. Madhuri and Dr. Anand Shankar for those brilliant talks. And a very big thanks to Dr. Rishikesh Pai and Dr. Ashma Rana, all the way from Nepal. Thank you. I would
gained a lot of knowledge.
Thank you. Thank you.
I would like to take this opportunity to thank our sponsors for today. Our program would not have been possible without their help. Torrent Pharma, Shield Connect, USV, Novo Nordisk, Montana Eris, and Zelina Life Sciences. A very big thank you to you all. I'm sure our 2,200 plus delegates have not realized the day passing by, the evening passing by, but we have come to the last session for the day. This is the AICC RCOG session. It is going to be a panel discussion. The moderator for this is Dr. Uma Ram, and she'll be moderating on ultrasound in GDM. The panelists for this session are Dr. Bhaskar Pal, Dr. Anita Kaul, Dr. Chinmay Ratha, Dr. Sita Ramamurthy, and Dr. Sudeshna Ray. Dr. Uma Ram is Director of Sitapati Clinic and Hospital, Chennai. She is the Chair, South Zone AICC RCOG.
Only we can't hear you clearly.
Is it better now?
Yes.
Yeah, so just to repeat, in case you all have not heard about Dr. Uma Ram, she is the Director of Sitapati Clinic and Hospital, Chennai, and she is Chair, South Zone AICC RCOG. The panelists on this session is the first one is Dr. Bhaskar Pal, who's a senior consultant gynecologist, Apollo Glengale's Hospital, Kolkata, and Chair AICC RCOG, Vice President AIGE, President Bengal Obstetric and Gynaec Society. The next panelist on this session will be Dr. Chinmayi Ratha. She's the Director, Resolution Fetal Medicine Center, Navadoya Hospital, Senior Consultant, Fetal Medicine and OBG, Yashoda Hospital, Secunderabad, ICOG Foxy Certification Course. She's the Center Head and also the Center Director for Fetal Medicine Iron Donald Ultrasound courses. The third panelist for today is Dr. Anita Kaul, Clinical Coordinator, Apollo Center for Fetal Medicine, New Delhi. She's also the Director, Apollo Cradles, Delhi NCR. She has been instrumental in introducing FMF certified training and quality assurance in nuchal scanning and obstetric ultrasound. Dr. Sita Ramamurthy is the fourth panelist today. She's a consultant fetal medicine and obstetrics, Apollo Glengale's Hospital, Kolkata. She's the Clinical Secretary, ISOPAR, Kolkata chapter. We also have Dr. Sudeshna Ray, who's the Associate Director of the Department of OBGYN at Jaslok Hospital, Mumbai. She's also attached with HN Reliance, Breach Candy, and Saifi Hospitals, Mumbai. She's actively involved in social upliftment through NGOs and CSR initiatives. I hand over to Dr. Uma Ram, the moderator for this session.
Thank you very much, Purni, and thank you to Dr. Hema and the SAIDIP team for inviting us to this panel. And it's a privilege to be a part of this meeting as the AICC RCOG session. And I have a very power-packed group of panelists with me, and we hope that in the next 45 minutes, we will go through a series of cases and which will highlight the use of ultrasound, its value, its pitfalls in the management of women with hyperglycemia and pregnancy. And I think this is an extremely important area because we have at least 1 in 5 women who are walking into our clinics today having some aspect of hyperglycemia and pregnancy. And therefore, it's very important for all of us as obstetricians and people who manage gestational diabetes to understand the value of ultrasound in these women. So I'll begin with the first scenario. This is a 26-year-old primate. She's booking with us at 7 weeks of amenorrhea. Her fasting sugar is 130 and her HbA1c is 9. She's had an early pregnancy scan done outside and it shows a viable pregnancy, but there's a week lag. So if I can ask Bhaskar to comment on, how you would counsel this woman about her pregnancy and possible concerns. You're muted, Bhaskar.
Thank you, Uma. I think right at the outset, we need to check whether this lady is a known diabetic or it has just been found. I would suspect she's a known diabetic, otherwise we wouldn't do a fasting sugar and an HbA1c. Otherwise, we would have just started off doing a glucose load test. So we need to check what medication she was on. The early pregnancy is done and there is a 1 week lag, so we need to adjust her dates according to her scan dates because it's more than 5 days. Now, there are 2 important parts of counseling. Number 1, we need to counsel her regarding the risk of abnormalities, and number 2, we need to counsel her regarding what to expect in a pregnancy in her pregnancy with diabetes. I wouldn't say that we should put a cutoff of HbA1c where we should recommend a continuation or termination. I think the decision is entirely up to the woman. It is up to us to counsel her that what is the risk of malformation. Now, if we take a background risk of malformation, which is around 2 to 3% in pregnancy, at a HB1C of 9%, at an HB1C of 9%, we would expect a malformation rate of around 6%. We need to understand that the risk of malformation goes up as the HB1C goes up, and she needs to understand that. And based, for some people, 2% versus 6% might not be a very high risk. For some women, 2% versus 6% might be a very high risk. It is up to the individual perception of the couple, and we need to leave it to them whether they need to decide to continue or whether they decide to terminate. If they decide to continue, we need to review her glycemic control and put her on capillary blood glucose monitoring and put her on insulin. I wouldn't really wait for giving a trial of MNT for this patient with a HB1C of 9.
Yeah, fair enough.
Yes. Very much. And we need to talk to her about what are the implications of diabetes in pregnancy, during the pregnancy, about the risk of IUGR, the risk of macrosomia.
Would we admit her?
Yeah.
I wouldn't admit her. No, not really.
Okay. Well,
we would.
Sudeshna, you could argue that her admission may be required if she's somebody who is not very compliant, may be coming from far away, may not have the ability to do SMBG. Then someone like this who wants to continue her pregnancy because we want her to get quickly under control, admission may be required. But if she's somebody who is able to do all of these things and report quickly, we could manage her as a now. But she definitely is somebody who needs to be
I mean, I would have thought that at 7 weeks with the kind of sugar she has, and because we know that diabetes is teratogenic, shouldn't we be more aggressive?
Yes, Anita.
Yes, I think Anita, the issue is we need to get her sugars quickly under control.
Yes.
I think Uma raised the issue of compliance. You and I, the sort of setup that most you and I practice in our patients usually would be doing their capillary blood glucoses and sending it to us every 2 days, and every 48 hours we review her insulin dose, and we don't need to. If you're looking at a medical college setup, yes, this patient definitely needs an admission.
So the key is that they need to come under quick control, and they need to be counseled, as Bhaskar says, about abnormalities. We've corrected dates, but Anita, I wanted to ask you, are you concerned a little bit about this lag in early pregnancy in somebody who's very poorly controlled? Even I know we would correct dates, but there is some concern that very early growth lag could be a marker for subsequent abnormalities as well, because just as Anita mentioned now, hyperglycemia is in itself a teratogen. So it's just a flag that we need to keep in track of. Now, this lady is very committed. She comes under monitoring good sugar control, and then she comes for the 11 to 13 week scan. There's a lot of anxiety in the couple because they have been counseled by Bhaskar that there's an increased risk of abnormality. They're coming to you, Anita. Can you tell us how good can we be in picking up of abnormalities at the 11 to 13 week scan, and how much reassurance can you give the couple?
So yes, the fact that she had a HbA1c at a sort of critical time would cause me concern, because as Bhaskar said, it is true that the more the hyperglycemia, the more the risk of congenital abnormalities. But the congenital abnormalities are reasonably specific. So neural tube defects, heart defects, skeletal defects. So they're reasonably specific. I mean, the pathognomonic is sacral agenesis, which of course we can see when we scan, but that's actually quite rare. But things like anencephaly, occipitaloencephalocele, those kind of neural defects, we are very, very sure that we would have picked it up. So if we see a normal brain at 11 weeks and we don't see that, I'm very confident in reassuring her that, look, at least that bit I'm sure of. The heart defects are the ones that I would be a bit more concerned about, because we're not as confident with heart. Now, I mean, the point is, Uma, that the way things are moving, we've got better scan machines. We've started doing anatomy scans transvaginally, and we are really focused in picking up early problems. So in heart, which is the one that I'm perhaps not so confident, I would, things like VSDs, ASDs, TGAs, those kind of heart defects, we would suspect them
her
at
back.
least. We would suspect them and say that, look, we are reasonably comfortable, or we are not, and come back again. But we're not. I mean, we're getting better and better. So if her BMI, you haven't told me how her BMI is.
We'll come to that, Anita. We're discussing BMI a little later. We'll come to that. But let's assume for your sake that her BMI is somewhere around 26. Yeah. So I'll be kind to you.
Much more confident about telling her that, we've had a fairly good look. We are very sure that this baby doesn't have neural tube defects. We are confident about the sort of 4-chamber view. There's these things called the X and V sign. So we are reasonably confident about heart. We are reasonably confident about the skeletal abnormalities, like sacral agenesis.
Fair enough.
So I would be very positive.
Yeah. So with a reasonable degree of certainty, assuming she's in a center like yours, where there is a person who is qualified to do a detailed anatomy at 11 to 13 weeks. And I think that is a caveat that we need to put in here, because not everybody has the capacity to do a detailed anatomy scan at 11 to 13 weeks, but it is possible. So what about aneuploidy screening? Can we offer, I'll come back to that in a minute. I wanted to ask.
Aneuploidy would be as much as for her.
No change because of her diabetes.
Correct.
Okay.
Preeclampsia, sure. Yeah.
Sudeshna, would you like to preeclampsia screen this lady?
Yes. Am I audible?
Yes.
Yes.
Yes, you are.
Definitely, I would like, because as Dr. Bhaskar said, that we have to counsel her for the the problems that she can face, and preeclampsia is definitely one of them. Okay. There's an increased risk by about 10 to 30% versus 5 to 7% in non-GDM. So I will definitely want to preeclampsia screen this lady, though I know the dual marker or the double marker test is not as sensitive in picking up the genetic screening, but the PAP-A and the PIGF screening for preeclampsia in the first trimester should be done for this lady to kind of have an idea about the preeclampsia.
So I think there isn't, for the first trimester screening, I don't think we need to worry about her glycemic status. But if we miss that and we offer her quadruple, then certainly we need to. The reason I put the question about preeclampsia screening is this is somebody who is a primate, who has hyperglycemia. We may be starting her on aspirin anyway. So even if you are not able to do the preeclampsia screen, this is somebody who qualified to get the aspirin. If you are able to, sorry, Anita?
No, I'm saying that we are very efficient now in doing preeclampsia screening. So
okay.
I think she
so Bhaskar, coming back to you, when would you like, so she's had this 13-week scan. Anita says she's reasonably confident that there isn't any significant anomaly. When would you send this woman back for an anomaly scan?
Given our current regulations, I would send for an anatomy scan at 18 to 19 weeks, and I send her back for a fetal echo at around 22 weeks.
Okay, all right. Good. So
Can I come in here?
Sure, Sita. Yes.
Yeah, I think these sort of ladies may qualify or may benefit from an early anatomy scan as well, between 16 and especially because of the A1C of 9 around the first trimester, as we've said. So some of them would qualify for an early anatomy scan, and then again for a detailed one later.
Okay. So my only, I agree, and a lot of units, that's what happens. My only concern with that is when we see them at 13 and then we send them back at 16, sometimes they are reluctant to come back at 18 to 19 for another scan because they feel they've had too many. And And sometimes at 16, especially if there's adiposity and you've lost the transvaginal advantage, really your imaging may not be as so if we think we're going to not do the 18,
Uma,
it may be smarter to send them.
The other thing is that, I do think that we frighten them fairly at 12 weeks. So I think it's just adding to reassurance by calling them back. So I agree with Sita. I would
16.
Probably, yes. Because, at 9 weeks, you're saying, oh, things are so bad. There's this risk, there's that risk. So they are under stress. So the more you reassure them,
so you want to bring them back at 16, 19, and 22?
That's a lot of scanning, and people may not come back for the most valid scan.
My policy, Uma, is that I actually go by what the fetal medicine consultant says. Yes. And if the patient is not overtly high BMI, and at the nuchal scan, if they have had a decent view and are reasonably sure of things, I would call them back at 18 to 19.
Okay. So we have two viewpoints, and I think it is valid to bring them back at 16. I'm not saying no. My only point is that if you think this woman then will refuse to come back at 18 to 20 weeks, then it may be better to do it at 18 to 20 than at 16. Chinmay?
Ma'am, I think a consensus view can be that if they've had a 11 to 14 week scan at a center like Dr. Anita's, where they've gone to that extent and seen everything with that clarity, then probably this patient can come back at 18, 19 weeks. But if they've not had a very good 11 to 14 week scan,
yes,
then better call them at 16.
Yeah. I think that's a sensible view.
That's
a fair enough. The anomalies can better call them to a place where you are very sure of the anomalies.
Fair enough. We are coming to that.
Sorry, a lot of them do come very often in that period to get their glycemic control as well. So that is why I was saying that, we could.
No, I agree. I get your point. I'm just putting the pros and cons together. So we move on to the next scenario. This is somebody who's had a previous normal delivery, a 3.3 kilo baby. Her BMI is 38. She's had a scan at 7 weeks where they've said, it's a viable pregnancy. She's not had a scan at 11 to 13 weeks. She's had a target scan elsewhere where they've said everything is normal. And now she's come to you and her recent labs confirm that she has gestational diabetes. So Sita, are you happy? You look at the target scan images, it's reasonably done, you think. Are you happy to just say yes, or would you want her to have another fetal echo and a detailed scan again?
As Chinmay put it, that if it's done in a place where the images are good and I'm happy and it's a proper cardiac screening has also been done, then maybe I'll accept it. But if not, then I will definitely do it at a center or do it in my center as well, where I'm happy and I'm satisfied with all the images or all the screening, detailed screening which she would require, because GDM as such is basically type 2 diabetes which presents in pregnancy. So the risk of if you're looking at especially cardiac defects, it is high compared to the controls. Of course, not as high as the pre-gestational ones, but equally high to be of concern. So I would definitely do one where a cardiac screening, if it's done properly along with the anatomy scan, is you're happy with it, that's fine. But if not, and if the obstetrician wants it, then we can do another fetal echo, dedicated fetal echo.
BMI of 38 with GDM, if the previous scan, irrespective of when it is, it's not in a fetal medicine unit, has to be repeated in a fetal medicine unit.
Right, fair enough. So Chinmay, Anita had asked for the BMI earlier. I'm giving you a BMI of 38. I'm not being kind to you. Can you tell me what are the challenges in imaging somebody like that? Because we want a picture like what's on the left of the screen, but otherwise we may end up getting something like on the right of the screen. So how do you make that good image happen in women with high BMI?
So thank you, ma'am, for the question and for putting it across so clearly as the left and right side of the screen, because we are struggling with what we want and what we have. Yeah. Now, BMI of 38 is a challenge with or without diabetes. And the problem with high BMI is that our acoustic window, which is through the front of the abdomen, is a lot of fat, and that fat attenuates the ultrasound signals. So our pictures are extremely poor, as you've seen here. And not only that, high BMI patients are poor to, it's difficult to visualize the fetus, they also have a higher incidence of anomalies, either like just obese women as such, or when they are associated with diabetes. And some of these diabetic women are on insulin, which they take on their abdomen, and that lipodystrophy there also adds to the poor visualization. So the thing here is that we have to counsel them that there is a little difficulty in visualization, but when we do that, we can scare them. So we have to tell them that there are methods of, circumventing this. One common thing which we all do is we have presets for high BMI now, because this is a very common incidence, and in fetal medicine centers particularly, I think, 10 out of 30 patients are high BMI every day. So we have a set preset for high BMI where the tissue harmonics is pushed off and the velocity settings are adjusted so that our penetration is better. Other than that, what we do is we use other acoustic windows, like we try to scan them from the lateral aspect or from below the pannus with a full bladder. And sometimes we use the transvaginal method to overcome these problems. In fact, there is a Green Top guideline on care for obese women in pregnancy, which clearly states that at least in first trimester, it's better to use the transvaginal approach. And at any stage in pregnancy, when you are scanning these women, inform them of all these problems and tell them what are the precautions that you're taking. So one, we should be aware that there is a difficulty in scanning, and second, we should know how to circumvent that. So we use all those methods and try and get as best as we can.
And then we write a disclaimer as well, Chinmay.
Yes,
Don't
ma'am,
forget, in very, very...
Yeah, and then they come to us and say, what does this mean, poor penetration? What does it mean? You put it very nicely, and then we have to tell them that it's adiposity. So, yeah. So, Deshna, she's on medical nutrition therapy. She checks her sugars in the labs twice a week, and her fasting is in the range of 85 to 90, and her PP is 130 to 135. This is her growth scan. And, are you happy with what you're seeing? She's now about 33, 34 weeks.
So yeah, so the growth scan means it's definitely high, but if she's well controlled, the glycemic control is fine, and if it is only controlled with the diet and nutrition, I would not really scare her very much about the impending delivery or the problems that we can face in the delivery, but we'll keep a definite watch on it, and we'll repeat a growth scan after 2 weeks to see how the curve is increasing. If the centile goes above the 90th, then definitely we are dealing with macrosomia, and then definitely we are going to talk to her about the mode of delivery for her. So
Sita, all right. So you're not, yeah. So you are concerned that the baby is larger,
yes,
but you're happy with the numbers that she's showing you.
I think,
Tita, do you want to?
Yeah, I would slightly be worried about this growth acceleration here. The AC catching up on the 19th centile, already at 34 weeks. So I would be more keen to start her on insulin because we need quicker control. I also want to know what the lipo volume is at this point, if there is associated hydramnios as well. And I think there is possible and a benefit of starting insulin so that we can, check this growth rather than moving it further across, moving away from the charts by the time she reaches 35, 36 weeks.
I mean, I'd agree with what Sita says, because this is showing us that the baby is showing acceleration. So, I mean, we definitely want her, because if she's checking sugars once every 2 weeks, that's absolutely not good enough.
Yeah. So this is a common scenario when somebody is on medical nutrition therapy, because they only check and we don't know what's happening in between. So we need to get a few 4-point sugars at least. And for all you know, except on the day that she's testing, there may be poor control. So the fact that the baby is accelerating is something that we need to keep in mind as an indicator of loss of glycemic control. and incorporate that and not just look at the numbers and say, actually, these women need a lot of convincing because they believe that these sugars are fine. And we do know that it is a continuum. There isn't an absolute value above which something dramatically starts happening. So the correlation of sugar, of the glycemic level and the growth is different. So we've discussed, and then the question, if you now achieve tight glycemic control with whatever it is that you do, insulin, can you change the metabolic risk of this baby? Probably not, because the adipocytes are deposited and we are not going to be able to go back on it. So
we need to emphasize the need for closer monitoring and explain to her that it is normal for the sugars to go haywire in the second and third trimester. They believe as a guilt phenomenon. They go on a guilt trip that I've done something wrong. So, and that's why they sort of go on a defensive trip. I think it's important again to counsel them that it's okay to have, they need for insulin at this stage.
Yes.
And one more thing, ma'am, I don't know why our labs never report pregnancy values. I mean, when they give us the glycemic values, they give the normal non-pregnant values as the standard. So that's why patients get very reassured.
Yeah, true. So I think we'll come back to other aspects of fetal growth. But I think the message that we wanted to give with that case is we need to keep an eye on how the baby is growing along with the sugars. Now, moving on to this scenario, this is a gravida 5. She's had 2 deliveries, 2 miscarriages. She's had GDM in the first pregnancy. Now she's a type 2 diabetic on insulin. She presents at 17 weeks, obviously with very poor control. She's had a target scan done outside where they've told her that there is bilateral talipes deformity. And then the couple were told, when you go for the growth scan, they'll look at it with a little bit more detail. So I can see Anita perking up there with, and she's saying, gosh, what is going to happen now? So Anita, Chinmay, Sita, as the ones who do major scanning, Sudeshna and Bhaskar, this is your patient. And this is what we are seeing.
She's already 26 weeks now.
Yeah, she's 26 weeks.
No,
17.
17 was
supposed to come at 20.
She's had a target scan at 20 weeks where they've told her she has bilateral talipes, but that is correctable.
Okay.
So,
but right now, what gestational age is she?
26.
Right now, she's 26.
Oh.
So, this would be considered one of those skeletal abnormalities that you tell diabetics, that there are slightly more risk of skeletal abnormalities. So sometimes in bilateral clubfoot, you work them up much more. You send off microarrays and things like that. But in this setting, I would go back and try and review her sugars around the periconception times.
They were haywire. They were haywire. Yeah.
So I would say that, look, this is probably as a result of poor hyperglycemia. I don't need to really worry about genetic abnormalities as such. I have a reason why this has happened. Again, as you said, tell her that this is very much a correctable abnormality and just focus on making sure that she's euglycemic and continues to be so till the end of pregnancy.
Yeah. So, Sita or Chinmay, any other comments?
No, true. As ma'am said, that is probably the most reasonable thing to tell them. But at the same time, there could be coincidental, other reasons for having this bilateral talipes. And if she has polyhydramnios, again, because she's diabetic, she can have polyhydramnios, and that will add to the confusion. Because conditions like, progressive arthrogryposis or other problems, we'll start thinking of that. So we'll tell them, basically, again, we are going to scare them essentially, because we ourselves will feel a little scared because we don't know, how things were in the beginning. And if she's not had any checkups, she's not had any screening tests as well. So all those things we have to tell her at this point.
So she needs a detailed scan head to toe again, whenever she comes back, and then explain to her, problems that can happen even despite having a so-called normal scan at this point, apart from the talipes.
Yeah.
Yeah, but then we would be worried about coexisting genetic abnormality as well.
So in this case,
we can't do anything about it right now, but we have to counsel them that there is a possibility of.
But you know, this particular
markers.
Yeah, but this particular sort of talipes is so much in a setting of polycontrolled diabetes. You think
Yes.
of the most common thing first.
So this patient actually, in the follow-up scans, there was very poor muscle mass in the lower limbs, and there was also a low-placed pelvic kidney. And at birth, the diagnosis of sacral agenesis was actually made.
Really? Can you go back to your spine, because that looked really nice. Those images. Mm.
Yeah, the lower end.
Why you kind of get scared? Anyway,
yeah.
Okay,
So there was a
it's
lot of
looking
talking to be done with this family. Because at this point, the fact that there was poor glycemic control at the start is not something that, why was this not picked up is a question that came. Why was this not flagged? Now, thankfully, because they moved multiple places, it was, it was a very late scan, and therefore the imaging was compromised. Is an explanation that was given. But I just put this here to say that sometimes, despite all the care, because the best opportunity to do a detailed anatomy scan, especially to look for the spine and the skeletal defects, the experts can correct me if I'm wrong, is when the baby is a little bit smaller, around 18 to 20 weeks. So the importance of that scan in a good center cannot be overemphasized. Okay, so we move on to another scenario. This is a Gravida 2, previous normal delivery, normal antenatal care. This is how the baby is looking at the time of the 20th week scan. This is 19 weeks and 6 days. And then here, she comes back for the growth scan, and this is, she's about 29, 30 weeks. And you can see that there is a polyhydramnios. The single vertical pocket is 10.5. I'm just reading it out because it's a little small. And you can see that the abdominal circumference is actually just about touching the 90th centile. And there's polyhydramnios. So at this point, Sita, she's had a glucose screening at 25 weeks, which was normal. She did not have gestational diabetes in her first pregnancy. And you're seeing this now.
We repeat the glucose test, of course. That is the first thing to do, because you don't know how well that was done and where it was done and all those things. But the ultrasound is definitely showing signs of possible glycemic
So even if that was normally done, she could have developed afterwards. So
yeah, definitely. So we need to repeat that. And of course, again, if that is also normal.
If that is also normal, would you think of?
Because of the hydramnios and the accelerated growth, we have to go in for a detailed scan, like we mentioned earlier, and look for other possible causes of macrosomia.
Okay.
Most importantly, tell her that what are the possible causes that might not be picked up by a sonography.
Okay.
And it will be evident only after birth. That if the glycemic control is, if there is no diabetes, if there is no other identifiable cause, then we still don't know what is this happening, and then we might be able to give you the answer after the baby is born.
Yeah.
Like sometimes, we have had missed out fistulas, esophageal fistula. So we have had those.
But this is more like a large baby.
It's it's a larger baby with polyhydramnios, and therefore diabetes is something that would top the list.
That's the first
but there could be something else that the
overgrowth syndromes. Beckwith-Wiedemann or Simpson-Golabe.
So we tell her all that, and then at 36 weeks she comes in and has a stillbirth. So is there any way, I mean, of course, we'll ask ourselves, the family will ask us, could we have avoided this? And at this point, the value of ultrasound in preventing a stillbirth is limited because there isn't placental dysfunction. And most of the time, especially if there's hyperglycemia, it's a metabolic process that's happening. There's some lactic acidosis setting in, and therefore there is stillbirth. So,
I mean, one could argue that a biophysical profile or something would have like predicted things, but that prediction, the time frame is not that. This scan was, I think, done around 32 weeks.
Yeah, 30
and
weeks.
The IODs happened at 36 weeks. The only thing is that after 30 to 36, did we never see the baby again? Because there was some
No, she was seen. She was seen.
So she should have had a scan after 2 weeks, because there were signs of that centiles changing. Because even if we didn't have evidence of hyperglycemia, there was a change in the centiles of the AC and the estimated fetal weight tending towards an overgrowth. So probably we could have just rechecked after 2 weeks and seen whether this was still going ahead.
Ideally 2 weeks, 34, 36.
It's very difficult to say whether this stillbirth is preventable or not. I think apart from how this baby has been monitored between 30 and 36 weeks, we need to see how her glycemic control was between 30 to 36 weeks. So number one, we need to see whether we managed to control her sugars. Number two, we needed to see how we monitored this baby. Of course, she needs, if her sugars are bad, she needs a 2-week, as an obstetrician, I would send her for a scan every fortnight. If there are any abnormalities, we might repeat the Dopplers in between, starting from 32 weeks. I would get a CTG done once to twice a week, depending on her glycemic control and ultrasound findings. In spite of doing all that, yes, some stillbirths would happen, and that would, I would say, that's not preventable. But we need to set our record straight whether it's not only ultrasound, whether we've monitored the baby properly and whether we've achieved our glycemic control.
I mean, what was the weight at 36 weeks, the weight of the baby?
His baby was about 3 kilos.
So it was overgrown then.
Yeah, absolutely.
Yeah.
So,
I mean,
this lady had a few values that were high, few sugar values that were high, nothing dramatically off the chart. But
do you get them to, like, for instance, if on ultrasound we are seeing overgrowth, do you get them to validate their glucometer readings?
Yes.
And make sure that, because, and we are, I don't think that we should be apologetic about telling them that you have to do a 5-point sugar monitoring every day. I mean, I don't think you should be. Do you think obstetricians tend to avoid?
In this kind of setting, I think that's going to help, because her lab readings are saying something else, but there is evidence that there is overgrowth.
Absolutely, as we discussed in the previous case, anybody who doesn't require anything more than MNT, I would ask for not a 5-point, a 4-point sugar check daily till I'm satisfied that is good control. Then I will switch to once a week, and even then insist on a fortnightly lab report to see that correlates.
Yeah, exactly.
That's one. And patients on MNT, if we see that the lab reports and everything else don't correlate, that is when we need to fall back on a 4-point sugar monitoring. We do a 4-point, we don't do a 5-point.
And if there are patients, if there are women who cannot afford and don't have a glucometer, we can actually bring them into the hospital for a day and then monitor the sugars during the day and see what is happening.
And after 32 weeks, ma'am, what about daily fetal movement count for these kind of women?
We do advise, and as Bhaskar said, we would do a CTG, maybe not at 34, but usually starting from 36 weeks. But if you look for evidence for that CTG in the prevention of stillbirth in a diabetic pregnancy, it's limited. Yeah.
So exactly, it's an obstetrician's nightmare,
Yes, true.
Of facing this kind of a situation. But even if she was a diabetic and like moderate glycemic control, is there anything on the ultrasound? I mean, as an audience, maybe not as a panelist, I'm asking, but is there anything in the ultrasound that can predict?
No, we do. We are really very obsessive about monitoring. So even the subtle changes of abdominal circumference, as which is there, we look at it. We look at we look at changes in the amniotic fluid. So you do look at these subtle changes, and then every time you see it, you go back and make sure that she's actually measuring things correctly. She's assessing herself, her sugars correctly, because we can't believe that we have a baby which has accelerated its growth and the mother's telling us that no, everything is fine.
Is okay.
We just do not believe that.
I think it is a nightmare from a public health point of view.
Yeah, I know.
Because your resources are limited and you do not know what to do. In a private sector, we slightly blessed because we tend to err on the safer side in terms of monitoring.
Yeah.
That's where the counseling and documentation...
Sorry, Sita. Yes, go ahead.
Yeah, sorry. That's where the counseling and documentation is important, because despite everything, if all this happens, I mean, we have to explain to her, and at some point, I think scaring is better, because then they realize the importance of monitoring and coming for regular checks.
Yeah.
No, we have found the daily fetal movement count chart very helpful, because that puts the ball in her court to some extent. So the 3 times after the meals counting and documentation, because that helps us.
They stay focused. So the reason I'm putting yet another growth chart showing an accelerated growth pattern is 2. 1, because in many places, they don't give growth charts. I mean, I've been hearing this from when I was a postgraduate student, but unfortunately, even today, in many units, a growth chart is not given. And so I think an obstetrician should have a blank growth chart in their clinic to plot and see what is happening to these babies.
No, I think you should not accept.
If they're coming from a specific center, Chinmay, I agree. But sometimes you have.
Ma'am, all machines have growth charts embedded in them. You don't have to pay extra for those charts.
Right.
So you just have to report.
We should demand the growth charts.
You have to demand.
Because without it, there is no way you can see that there is a change in the growth rate. So that's the first point. And here you see somebody who seems to be fairly well controlled. Actually, till about 33 weeks, everything is okay, and we tend to relax. And then suddenly we are seeing an increase here. And when we got an estimated fetal weight at 36 weeks, the ACs hit the 95th centile. So if you have somebody like this, Bhaskar, she's had 1 abortion. What is your delivery plan? And how will you change it? Bhaskar, and then maybe Sudesh.
My delivery plan is a cesarean section, but in my mind.
Yes.
And how I get her to agree to that is the counseling.
Okay.
In very plain and simple words.
Okay.
You remember, for those in the audience who do not know about the Montgomery ruling, this is a very educated lady in the United Kingdom who had GDM and who had a big baby. And then she went in for a vaginal delivery and she had a shoulder dystocia and the baby died. And she went to court saying that I was not told about the risk of shoulder dystocia, and then I would have asked for a C-section. The obstetrician argued that you should not talk about a risk of shoulder dystocia, A, because it is less than 1% chance, and number 2 is that then every woman would opt for a cesarean section, and it will increase the morbidity of cesarean section. The lady actually won in the obstetrician won in the lower court, and the lady went to the higher court, where the higher court gave a verdict saying that depending on the education of the patient, you need to counsel her about the smallest of risks. And they said this is called the Montgomery ruling, which has changed the way people counsel and people take consent in United Kingdom. And that's how they have moved away from informed consent to what is now called shared decision making. So essentially, informed consent is how far you can go with the patient, and you document everything. So in my mind, this patient should have a cesarean section once you talk to them about the risks of shoulder dystocia or else. If she's very keen on vaginal delivery, then I would go for an induction, early induction, somewhere between, somewhere around 39 weeks. And if she receives insulin, again, this is not actually tallying. Her growth and her sugars are not tallying. So again, this lady needs, like the previous case, the earlier case, she needs to be, we need to look at how her sugars are. And if she's on insulin, then I would tend to deliver her between 37 and 38 weeks. And if she's not requiring insulin, at 39 completed weeks, the latest. Very reluctantly, I would agree to an induction if she's hell-bent on it. Otherwise, I have cesarean section in the back of my mind.
Yeah, even if I opt for delivery, giving her an option of vaginal delivery, it would be a very, I would be explicit in telling her that my threshold for a cesarean will be very, very low. So,
so we saw her at 36 weeks with this. So we counseled her, and we did tell her that if she, the couple were very, very keen on a vaginal delivery. They were not willing to, they said we'll go through an induction if understanding that it may not work. But we said we will induce her around 37 plus weeks because already the baby was going up. But before that, Chinmay, I want to ask you, how, if accurate, is this estimated fetal weight? I mean, in this chart, actually, her AC is on the 95th centile. But if you look at the weight, actually, it's just somewhere in the region of maybe 60 or so. But having said that, for 36 weeks, 3.1 kilos is large. So how accurate, and this 10% plus minus, how accurate is it at that extreme?
So ma'am, because it's 10% plus minus, when our estimated fetal weight increases, that 10% also increases. So suppose it's 200 grams, we are plus minus 200 grams. If it's 2000 grams, plus minus 200 grams. And if it's 3.5 kg, then it's plus minus 350 grams. So our accuracy also reduces proportionately. Having said that, there is a recent paper in the UOG by the FMF group where they said that if you do the estimated fetal weight at 32 weeks vis-a-vis 36 weeks, you will be more accurate at 36 weeks. And if you use a cutoff of say 97 centile instead of the 90th centile, you'd be a little more accurate in picking up your LGA babies. But your decision at 36 weeks to deliver a patient at 37 weeks based on an estimated fetal weight done on ultrasound may not be completely justified if you're taking a 90 percentile cutoff because of this lack of accuracy, because you may then end up delivering the patient at 37 weeks and not having a weight commensurately high, and then questioning your own decision of that delivery, mode of delivery, timing of delivery, everything at that point. So they have suggested in that paper, they have suggested a two-stage screening where you do a scan at 36 weeks and classify, estimated fetal weight based on above 70th centile in the first stage. All those who are above 70th centile at 36 weeks have another scan at 38 weeks. And then if they are above 85th centile at that stage, then you go ahead and treat them as LGA and, deliver them in whichever way. If they are not, then you take them till full term.
Uma, I just want to come in. If the patient has got GDM or diabetes mellitus, shoulder dystocia is impossible to predict based on the absolute fetal weight. So I would rather go by, if it's an LGA baby, I wouldn't worry about what are the percentages, what would use your error rate. But I would be more guided by how her sugar control is, what she's requiring, vis-a-vis the baby weight before deciding whether I want to deliver at 37, 38 or 39 weeks, but definitely not later than 39 weeks.
Yeah,
I think, sir, that's what all the papers are also saying, because they're saying that ultrasound assessment is not accurate, but you have to have some benchmark, so you're using one of those parameters.
So I agree, and I think therefore, if we obviously, it's as Bhaskar said, it's shared decision making, and if we have couples who are very, very keen, then we need to offer them an induction slightly early, maybe around 38 weeks, and if we are waiting that 2 weeks, we could get another weight estimation at that point. But it's not just about weight, it's about where the head is, has it dropped in, is it floating, all of that. So that becomes an obstetric decision making in terms of what we want to do.
We can't really predict the truncal obesity. I mean, the shoulder.
Yes, absolutely.
So counsel and document that you've discussed the risks of failed induction and shoulder distortion.
Absolutely.
Can I comment about the estimated fetal weight?
Yes, Sita.
Estimated fetal weight, you have to sometimes, different machines anonymously use different parameters for the estimated fetal weight. Though we have standards, though the AC we can see has increased, the estimated fetal weight, if it takes BPD and FL and AC, you will get a different weight. And that can actually change your entire scene there. So that's why it's important to also not only look at the estimated fetal weight, but also look at the AC.
Look at the other parameters.
Very true. Very true. And we should use the same formula each time. Yes. Okay. So moving on to a slightly different scenario. This is a 35-year-old. She's had one section and then for breech, and then she had a IUFD at 24 weeks. Now she's diagnosed to have GDM on diet, excellent control of her blood sugars, and this is at 29 weeks and 6 days. And this is what you're seeing. So the abdominal circumference is just above the 5th centile, and Dopplers are normal.
So in these cases, the first thing I ask them is their diet control too harsh? And are they on metformin? Because I think the metformin babies, I really find them much smaller. So was she like that?
Actually, she was. Okay. Actually, she was. She wasn't on metformin. She was on diet, and she was, very, very strict. And we actually did go through her calorie need, and we asked her to increase her calorie intake, and you can actually see that in couple of weeks everything looked a little bit better.
She didn't have any other hypertension or anything like that?
No, she was not hypertensive. Of course, we were worried because she'd had a 24-week IUFD the previous time. So we didn't know whether there was any placental dysfunction. So we did, monitor her, bring her in more often for her blood pressure monitoring, told her to keep a watch on the counts and all of that. But we also looked at her calorie restriction, and it was she was
very
really followed the rule.
But here I would be, with the previous IUFD, I would worry about the vasculopathy.
Certainly.
So, but Dopplers are normal.
Dopplers are normal. So she did come back every 2 weeks to have her scan in Doppler, and those stayed normal. She actually went.
No, I don't think that is what Sudeshna is meaning. I think Sudeshna is meaning she would want to look at whether after the previous IUFD somebody has looked at her phospholipid screen.
Yes.
Yes, all that was done. All that was done. It was an unexplained IUFD. She didn't have APLA. She actually had a placental HPE as well. It didn't show anything.
Okay.
I think, our endocrinologists say that, don't do so much of diet restriction and let them eat, and it's their job to kind of control it, and they have a lower threshold of going on insulin. But I do think, we see it actually a reasonable amount. I don't see so many macrosomic babies, but I do see more smaller babies, and it is for the reason that they're really they're just starving and they're hungry the whole time. But it's the obstetrician has said, no, you have to be like super strict about it.
But
anyway.
I think that is my observation with our endocrinologist as well. I think that's one of the reasons is very few women, even if they're initially controlled on MNT, they manage to stay on MNT. So I think the endocrinologist's viewpoint is that sometime or the other, going ahead, they'll need insulin. So why not sooner rather than later?
The other point that Anita made is actually valid, that we are seeing a lot of babies which are small to begin with. So again, looking at where that baby centiles are before we do an MNT or add metformin is something that we need to keep in mind. And just as we are watching that growth acceleration, watching a small baby also is important. Need not have preeclampsia.
Those who are on GDM who've got only one abnormal figure, maybe these are the patients you can look at managing on MNT and talking to them about diet. Who's got florid GDM, to be very honest, it's a better approach to not be very strict with their MNT and have a lower threshold for starting them on insulin.
Yeah.
But it's a dynamic thing, so you have to, see how it evolves.
And also tell them that it might be over after your pregnancy. You might be weaned off that insulin because somehow
you
many
tell
people
them, no,
think,
you have to tell them, you'll be weaned off the insulin.
Yes.
You tell them you
absolutely.
might, and if it doesn't happen, doesn't happen.
Yeah, fair enough.
So anyway, they'll go on OHA,
How-
they'll not be on insulin.
How are we for time? Not.
Dr.
We're
Pune?
usually over time, are we not?
Yeah, but I'm very excited that 2,227 still watching us.
Oh, thanks, Emma. That's
shall I?
That's
I have
Emma's
two more
One last
cases.
case, Uma. One last rapid fire round.
Okay,
That's
fine.
Emma's magic.
This is not rapid. This was, I'll skip this. This is just complicated. So this was a baby where actually this left multicystic kidney was picked up antenatally, but this VSD and bicuspid aortic valve was not picked up. So there was a little bit of counseling that needed to be done. And I'm just putting it here to say that sometimes postnatal scans will be required to follow up and complete. So this one, this is the last case. This is somebody, previous cesarean section, poorly compliant, pre-existing diabetes, and she was on insulin. Now at 33 weeks, she comes in with query pains for 2 hours. Uterus is irritable. This is how the baby is looking. Whoever wants to kind of, obviously we have to rule out the causes of why she's come in with pain. But I just wondered, given that the focus of the panel is also on ultrasound in clinical management, is there anything that we could use ultrasound in to manage the situation?
yes, ma'am, we need to see what's the Leica status. We need to see how the Dopplers are.
Okay.
And doing a cervical length at this stage is like, I don't know, I'm not so sure, because clinically you will be able to see.
Cervical length, because you want to make out whether she's threatened preterm labor or not. Because if she's not, then you have time to correct it. Because she's
but clinically also they'll be examining. So
true, but
okay, fine. We'll give
cervical length at this point will have more of a negative predictive value than anything else. At least we'll be sort of. But at 33 weeks, even if she goes
and steroids, that's the other reason for you.
Steroids, and if she has to deliver, then
she's a poorly controlled diabetic.
From our point of view, from an obstetrician's point of view, is whether we make a clinical decision of whether it is a threatened preterm labor or whether we are unsure whether it is a preterm labor. We don't find an uterine contractions or the cervix is fine. In the second situation, we might ask for a cervical length and be reassured that there is unlikely to be preterm labor. And then we just give her the steroids and steroids.
Then you would avoid steroids. If, for instance, she is not threatened, and we are
I would still give her steroids.
But irritable uterus,
any
it doesn't matter. I would not. At 33 weeks, I would not in this fulminant diabetic lady, I would not give her steroids. You could get
we would admit and give
at 33 weeks.
You're on an insulin infusion maybe. But
okay, so Bhaskar wants to give steroids.
I would be admitting her.
Yeah.
If at 33 weeks somebody requests admission with abdominal pain with diabetes and knowing what it will do to the lung maturity, I'll give her steroids and I will immediately increase the dosage of insulin. There are actually guidance on by how much you should increase.
That is why we keep saying.
Fair enough. So, okay, just a quick, vote, because there is a difference of opinion here, and I will. The moderators will give my view in the end. Sudeshna and Bhaskar want the steroids. Chinmay wants the steroid.
I
Sita,
don't.
Anita wants the steroids only if it is a threatened preterm, not otherwise.
Because I think a lot of
but it's irritable, ma'am. Irritable at 33 weeks.
Let's Nita give her word.
It doesn't matter.
Are you going to counter Bhaskar, or are you going to agree with Bhaskar?
No, I agree here. I too would give steroids.
One of those rare moments of agreement, is it? Okay.
Only one.
Okay, I actually, I'm actually inclined to agree with Anita, in the sense that this is a 33-weeker. I know that as a diabetic, we are worried about lung maturity, but since she's a very poorly controlled diabetic, obviously, if she's in labor, we would give her the steroid. There's no doubt about it. But if my vaginal examination, the os is closed, I tend to do a cervical length. And if I get a length which is, say, 2.8 or 3, and the uterus is, and she's not contracting, it's just some kind of pain, and obviously send off the urine protein, etc. I tend to hold on the steroid a little bit, because you don't want the decompensation to happen if she's not going to go into labor. Give it a few hours, see what happens.
The only concern of giving steroids here is, suppose if you delay the delivery after 7 days, then the steroids might be ineffective. But for controlling sugars, you're already admitting her, so that should not be a concern.
Yeah, no, I agree that in general, in somebody with threatened preterm labor, just because she's a diabetic, you don't withhold the steroids. That's not the message that we want to give.
So here your irritable uterus is different from threatened preterm labor. If it's threatened preterm labor, we all agree.
No, I'm just emphasizing the point that you can use cervical length for 2 values. One is for prediction, and one is to distinguish if somebody is actually likely to deliver soon or not. Now, because you know that repeated doses of steroids can have negative impact on the baby, you want to use that steroid at a point in time where it is most appropriate.
No, Suma, I agree with you. If you say I'll wait for a couple of 4 to 6 hours, if the pain subsides, that's fine.
Yes.
But even with suppose let's assume this patient has got a urinary tract infection with an irritable uterus, she might be going into a preterm labor. So we don't lose anything if we think that there are no cervical.
You lose a lot by giving steroids. No, I don't. The thing is, Bhaskar, that we are.
No, I didn't say that. I said we don't lose anything by waiting for 4 to 6 hours.
Yes,
before
to see
giving
what
steroids,
is happening.
to decide what is happening.
And I think there are a lot of situations, not just in diabetic women, in a lot of situations where someone comes in with a little bit of pain. Obstetricians don't tend to use the cervical length to triage at that point, and that's maybe something that we need to kind of get incorporated into our
we've also seen cases where we've had a short cervical length and the lady has gone for days and weeks.
That is true. That is true. That happens.
That also happens.
Yeah. Recently, I had a triplet who refused admission with a cervix of 1 centimeter and then stayed on for another 2 weeks. I mean, but we have to use some points. So thank you very much, all of you, for a really, really wonderful, engaged panel discussion. I just thought I'll sum it up with some key messages that ultrasound dating, first of all, is extremely important in pregnancies with hyperglycemia, because more often than not, they're going to be delivered ahead of time. And aneuploidy screening is an offer that has to be made as routinely for these women. They are at higher risk of preeclampsia, and we should emphasize the need to address this risk. A detailed anatomy scan at 12 to 13 weeks is important, and it can be done by people who are qualified to do it. I've said 12 to 13 and not 11 to 13 because most people are happier to see these babies at 12 to 13 for the sake of the anatomy. And an early target, keeping in mind that we still have that 20-week hanging over. It's not yet become 24. So 18 weeks to 19 weeks, and especially looking at the heart and the spine by a specialist. Watch the growth, plot it on a growth chart, and use the baby's growth to modify your glycemic control. understand that ultrasound alone is not effective to prevent stillbirth. And even though a woman is diabetic, there may be other factors that are operational that could have resulted in the stillbirth. So a routine stillbirth workup is necessary. Estimated fetal weight to guide delivery, we need to be aware of its limitations. And sometimes when there is a late anomaly pickup, there is challenges, but even in the postnatal period, the care needs to be, continued and tied up with the other subspecialists who are required. Any other quick messages from each one of you, and then we'll wrap up the panel.
No, thank you.
One key message from all of you.
Thank you, Uma, and thank you, Hema.
Thank you, Dr. Uma. Thank you, Dr. Hema.
Yeah, thank you. Uma, can you move out of the slide share so I can see everyone back on the screen?
Yeah, sure.
Yeah, thank you, Hema, for inviting AICC RCOG to do a session.
Okay, the first comment of looking at all my beloved panelists, I was just beginning to think 9:15 p.m. on Sunday, and I'm seeing Bhaskar Pal and Sita Ramamurthy Pal there, and then hum tum ek kamre mein band ho aur webinar shuru ho jaye. That is what has happened today. We have locked them up.
For the first time in the same
really
Is that right?
with us.
Yeah.
Okay, that's
the first
special.
time we are on the same panel.
I hope somebody's taking a picture.
So that's a great thing in itself, and I've just loved the discussion on this panel. So before I thank all of you, I want all of you to join our team and thank all the delegates, the 2,000 plus who have been with us throughout yesterday and today, because I had specifically asked them to keep a track, because very commonly they'll register, they'll stay for 5-10 minutes, go away, floating kind of a crowd. But this time we've seen they're all glued on, because this has been such a complex issue made so simple with some heart-to-heart targeted messages, which bring us to the ground realities of practice, especially in the Indian context. So join me in thanking all the delegates for having inspired us and encouraged us more and more. So I would also ask all the other guests here to switch on their videos, because yet again, the last thing I want to say is that I remain in an attitude of gratitude to the tech team, Shriman, Seshan, Vismay, and Subbu, who have very, very seamlessly supported the entire event. Even the pre-event promotions, they really helped us a lot. And this was one of the smoothest two-day marathon that we have managed. And finally, on behalf of all of you, many, many thanks to Dr. Rita, Dr. Purni, Sheetal Joshi, Dr. Divakar, the silent pillar behind the success of every event of artists. So having done the first things first, now lastly, all the distinguished faculty from all the SAIFOG regions, all the connect and collaborate organizations which have joined hands in our mission to defeat diabetes, all my endocrinology colleagues who have been so kind and so cooperative in trying to manage with our tantrums of, we want to push this topic, this is more relevant to the OBGYN, because we wanted to have a large section of OBGYN practitioners to understand more about everything that is happening around diabetes in pregnancy, because we are now getting to be taking the central role in managing most of these women. And of course, the brilliant faculty on this last panel of ours, led by Uma, who is the South Zone chair of the AICC RCOG, continuing her term for many, many years now. We are so proud of all that you do. And Bhaskar has stepped into the prestigious position of the honor of AICC RCOG, one of the most brilliant brains from Bengal, who is here with us. Sita Ramamurthy, Anita Kaul, Chinmay, Sudeshna, who has come from the studio, she says. we love the lovely faces on the panel. Last but not the least, the one who has always stood by me, Dr. Madhuri Patil, from the inception of our organization, Artists. She has been the silent force behind most things. One to everyone, Artists is here, and hard. Maybe stay together and do more together to make this world a better place. Thank you so very much. Namaskar.
Thank you once again. It was great being here. Thank you.
Shriman, please tell us when we are online.
Hello, Hima.